Hi, everyone. Hi, everyone, and welcome to Impact in Healthcare's first virtual event and our first rally. We're so grateful that you joined us. I'm Abby. I am a nurse living in New York City.
Hi, I'm Laura. I'm an emergency medicine doctor in the DC area.
Hi, I'm Violet. I'm a political scientist living in Maryland.
We wanted to do this event for healthcare workers across the country to show solidarity in our fight for people over profit. We wanted to discuss the moral disparity that affects our healthcare workers and every day how we see how our patients could be getting better care. And we're so grateful for you to be here with us.
Yeah, we're really excited that everyone logged in. We had a few people that were able to meet us in person that are sort of in the DC area this morning, and we're so excited to have some really great speakers lined up today. We can't wait to hear what everyone has to teach us and have some really great solidarity.
Yeah. Also, we should mention we have another founder here who wasn't able to join. Violet, do you want to talk about Sarah?
Yeah, so Sarah is our fourth founder, and she lives in Canada and was not able to make it today. And we just wanted to kind of share a little bit about Sarah's background as well. She's a nurse in Canada, and she has a master's in public policy, and she's incredible and is very passionate, and we miss her a lot. We wish she could be with us.
We love you, Sarah. We missed you. We wish you were here.
So the three of us will be hosting, sort of emceeing this event today. Sarah is helping us, of course, behind the scenes and has helped with the planning, putting all of Impact together. So she's not here on screen with us, but we can't state enough how much she's contributed to this project.
Mm-hmm. We have so many amazing speakers. And first of all, I just want to give a shout out to Anthony. We went down to Union Square in DC today. We walked to the Washington Monument. Peggy did okay. I loaded up on ibuprofen. I did all right. And we had such a great speech. You're going to see he will be our first speaker kicking it off. And we had some of his crew, his EMS crew come. We had some nurses who were in the area. They also came out and we walked for healthcare to make a better system for all of us. I think we need to share how we all got involved with each other, right?
Where do we even start with that?
Where do we start? Yeah.
So this was all a big Abby fan project is basically how this started.
No.
A little bit. So I think we all followed. So Violet and Sarah and I followed Abby on Instagram, and I think all of us had some conversations with you, right? About like various things. So I was a resident, so we had talked about some resident stuff. I know you guys had similar conversations.
Yeah, about politics. Yeah, DC politics and national politics. Yeah, and I think it just came to a boiling point after COVID. We were just like, hey, what's going on with this? And can we do anything about it? And just these three women, Sarah and Laura and Violet, just happened to message me around the same time. And they were like, we'll help you. And I was like, okay, cool. And then we got on a Zoom call.
Yeah, the Zoom call was great. We were on for about 15 minutes. We were initially talking about planning our, inaugural march, which we at the time thought might be in person. And we were on the call for about 15 minutes talking about the things that sort of were upsetting us about healthcare and that we thought needed to really be reformed. And I think about 15 minutes in, we were all sort of like looking at each other and we're like, we just need to say it. We've got to start a nonprofit.
Yeah.
Yeah. Laura was edging around and she was like, well, is a rally enough? Is a march enough? And she didn't want to say it. None of us wanted to like pull the trigger.
Yeah.
And then Impact was born.
And then, we became what we are now. We are forming committees as we speak. We have some committee leaders. Some areas we still are looking for leaders. So if you want to get involved in a leadership position, you can do that. You can email at iwanttohelp@impactinhealthcare.org. Also, if you want to get involved in a committee as a member, you can also do that too, which is a less involved role if you're super busy. And we want to make advocacy accessible for everyone. So as much as you're able to engage or as little as you're able to engage, we still want you part of this movement. We have to change the system from the inside out. I think healthcare workers need to lead this charge. It's ours and we should own it.
And that's something we really want to emphasize throughout this event. We have some really great interdisciplinary speakers today, and we know we're going to learn so much. But the big thing for us is that this is just a starting point. Mm-hmm. We are building the organization. We're building these departments. We're building these committees. So if anything you see today really speaks to you and you're inspired and you want to get more involved and you want to learn what grassroots activism is and you want to learn how to get more involved with us, send us an email. Maybe give us a couple days to recover from this event.
We're going to be sleeping. Let's be honest.
Give us a week.
Yeah.
But if you see anything that really speaks to you, just send us an email. Let us know your name, sort of what your role is, and how you want to be involved, and we'll get you set up.
Something I think too we need to talk about, not only are we going to have different departments, right? Like we're going to have a nursing department, we're going to have a resident department, but then on top of that, we're going to have some grassroots also, like we already have LGBTQIA group started. We already have leaders for that. And we're going to have different things like that, talking about disparities in healthcare and ways that we can get involved on a social level also.
Yeah. So I think we've said it from the beginning. We want this to represent everybody. If you don't see yourself represented, come in, get involved, start a chapter, start a department.
That means we need you.
Yeah.
If we don't have your group that you fit into, that means we need you as a leader. Definitely.
Yeah. We definitely want you here. We want everyone to be represented. We want everyone to have a voice. We want our mission to serve all of healthcare workers. Obviously, we can't say that we know what every healthcare worker needs. So we do need you guys to tell us what that is.
Yeah. We want this driven by you. We want to be the vehicle, but we want you to drive the car. We want to take this wherever you want it to go.
Yeah.
Is that a really cheesy analogy?
Yeah. I like it. Yeah. So this is just going to get cheesier throughout.
It is.
Just hang in there.
I cried when I listened to Anthony's speech today. I just want to let you guys know. So be prepared because, I mean, we have some amazing speakers. We have Shirlene. We have Harrison. We have Sabine. We have Rick. My God. We have like this amazing group of people who really showed up when we're talking about people that are already exhausted, just like everyone, right? They're working a ton and they put in extra hours to record, to write, to come to our meetings, to participate in this. So we want to give a special shout out to all of those people. I'm already getting emotional.
Yeah. This is going to get a lot cheesier. You can heckle Abby in the YouTube comments. That's what I'll be doing.
Yeah. We do I'm sorry, I just saw a comment about a physician associate department, and we definitely want that. We need that. We also need an NP group too. So we need leaders. So if you're interested in that.
Yeah. I know right now we do have a PA signed up.
Okay. So we already do.
Yeah. Ambulatory care is also a great idea. Like I said, we want this to represent the interests of everybody. So if you think you know somebody or you think you'd be a good leader, come send us an email.
Yeah. Also, we need to give a shout out to Michael, aka Bedside Rounds, who is like live. He's doing a viewing party on Discord right now. Hey guys. Hey everybody in the Discord. Guys. We love you. It's amazing. Thank you, Michael. We love you.
And also thank you for trolling our YouTube comments. We appreciate it very much.
Yeah, we appreciate the tech support.
While we're talking a little bit about some of our friends, we should give some shout outs to the people that have really been helping us promote and have been so supportive of us getting started. This is going to be going throughout. We have so many people to thank that we're going to thank you all 15 times.
Yeah.
Bedside Rounds is saying, so I'm going to thank him first. Thanks, Michael. We love you.
Thanks for not getting sick of us in a group chat too.
Yeah. So we have Rad Girl Creations is a big one. We want to say thank you. She helped us with our pin packs and she donated. We intended on paying her, splitting the costs or something like an artist fee. She donated her profit to us and she gave it to us in advance so that we would have money to put on this event along with the donations we collected. So thank you, Aubrey, from the bottom of our hearts. Thank you. Thank you.
Riot Healers, obviously. We've got all of our sweet swag here. Riot Healers everywhere. We can't say enough good things about Jacqueline. We're obsessed with her. If you haven't, you don't even have to buy our merch, but like you should just go buy her stuff because it's amazing. And she's the kindest person I think I've ever spoken to.
Yes. Yeah. She's an amazing human being and she is a nurse and she wants to see healthcare also transform. And she did a lot of this again, like as a donation and to help us to get started so that we would have a way to fundraise, which helps us so much. So thank you, Jackie. We love you.
We have so many people.
We'll sprinkle them in.
All right,
we'll sprinkle them in throughout. Yeah, we don't want to bore you.
And also, we'll probably cry.
Yeah.
So we haven't thanked you yet. Stay tuned. You have to watch the whole thing.
Yeah. Laura, let me just ask you. So, Laura, you work in the emergency room. What are some of the moral injuries to healthcare workers that you've seen while you're working there?
So I think there's a lot of things. I mean, I think a lot of them are common throughout healthcare. I think the ER is having a ton of understaffing like everyone else. As a doctor, I feel pretty privileged. I think our nurses and our techs are just being so dramatically understaffed and taking these ridiculous patient loads, and everyone's doing it with a smile, and everyone's, absolutely busting their asses to try to make patient care as safe as they can. And I think what we've seen throughout healthcare is just seeing people really pulling together as individuals because the system isn't taking advantage of them. I think we've seen a ton of violence against healthcare workers, especially in like the ER. I know the ICUs have been really rough with that. I know some of the places I trained, we had like some pay freezes, like cost of living pay freezes. I think we've had the moral injury of watching people die of things that we've never seen people die for over the pandemic. There's just so many things.
Yeah, I agree. I mean, I think, when I was working in the COVID ICU, I definitely felt, I felt sad, and I felt it was bad for me, but it was really difficult to watch my coworkers go through it. That was really difficult for me. People who had their own health problems and maybe were close to retirement and worked, tirelessly their whole career even, and then for that to happen towards the end of their career. And I think a lot of healthcare workers this year and last year lost coworkers to COVID, and I think we can all acknowledge that most of the cracks in this system existed, right? And COVID has exposed that and exacerbated the problem. So I want to see, I know everyone talks about this, that they're fed up and they want to do something, but I just want to see a place where we can pool our energy so we can sort of try to take back this system from people who maybe just have a business degree and they are running a hospital system and they don't understand what it's like to, and that's not to say that they're bad people, but if you don't understand how to provide patient care, then to me, you should not maybe be the person in charge. Maybe it should be the people at the bedside.
And I think, speaking about moral injury in the ER, I think something that I've also seen through the pandemic and the places I've worked, and I think we've seen it sort of throughout the country, is people really pulling together, like healthcare workers especially, really pulling together in a way that I don't want to say we've never seen before, because I think healthcare workers have always wanted to take care of each other. But I think we have seen just sort of this sort of attitude of no one else is taking care of us, so we're going to take care of each other. I think that's sort of how Impact started, was we're like, we can't, like, no one's looking out for us. We've got to do this for ourselves. And I think it's been a really motivating thing for me. I think it's been a huge thing with getting Impact going, of just seeing how many people really want to make this a better system for us and for our patients. And that's my favorite thing about Impact, is that, like, so many of you guys are logged in and watching and like commenting and showing up for things and actually want to make a difference. And that's huge. And that's so inspiring. And we can't say thank you enough for that.
Yeah. We love you so much. We love you guys enough to go live right now, which is a scary thing. I'm just going to say it. It's really scary. Yeah. But we're here. We're here for you. We want to support you. We want to highlight your hard work. I mean, you're the reason why we're here. I'm happy. I'm so happy about this turnout. Happy. Yeah. Oh my gosh. So, I mean, going forward, tell me who you both are excited to hear most from the speaker. I know all of our speakers are amazing, but I want to hear who you individually are looking forward to. I'm
going to go with Sabine. I was really interested when we were... when we were having our meeting and she was talking about some of the direct access issues that she was having, that was one thing I was like, I want to hear more about that.
Yeah.
I'm so stoked for her speech.
Yeah. She's talking about direct access with her PT patients, right? Yeah.
So I'll be Sabine's one of my oldest friends, so I'm very excited that I was able to recruit her to be involved in this. We've had these conversations our entire life, so I'm super excited to hear the same rants we've been having for years. I'm really excited about that. I'm also really excited for Shirlene's talk about residency and residency exploitation and the culture of medical education, because also a rant that I personally love to go on. So I'm very excited to hear about that. But I don't think I can choose a top favorite.
No, me neither. I'm really looking forward to William's speech. He's doing he's talking about pharmacy and how their role in the hospital, and it's a similar thing, right? If we're talking about direct access to PT, I mean, it's a similar issue that you have in pharmacy sometimes too, right? Is getting your patients the treatment that clinically they need. And then you have to deal with insurance companies and all of this. So I'm really looking forward to that. Also, I'm really excited that we have a respiratory therapist on board.
Yes.
Rick is going to be here talking. That's going to be really cool. Sarah, I'm really looking forward to. I mean, we have so many. Harrison, we mentioned before, the PA.
Can I say, Anthony, even though I've already seen his speech, like I'm still excited for you guys to see it.
So
yeah.
good.
Yeah. And then we have bedside rounds. We have a debate, the IM versus ED debate. Drop it in here who you think won quickly. And then we're going to take a poll at the end of it.
Can I say that that's the one I'm least excited about because you have to listen to me and Abby talk, and that's not a good time. Like you're gonna be sick of us, and that's fine.
No, you're not.
That's been my entire last 4 months.
Sorry.
Yeah, it's fine.
We're funny.
We crowdsourced a lot of that from our Instagram pages, and we discussed about why do we have this beef? Does the patient actually poop in the elevator? Is that a lie? I think it's a lie. Yeah.
What don't we understand about each other?
Yeah.
What dumb questions do we ask each other that don't have any business?
Yeah. I just want to mention too, we are doing this live. And so some of our speakers, the times might be slightly different. They might change. Just keep checking in with us. If you can't stay on the whole time, just keep checking back with us because it might change a little bit.
We initially wanted to do Anthony's speech at 2:30. We're running a little bit behind, just making sure that we have a really high quality sound for you guys. We want that to be as high quality as we can possibly get to do it the full justice it deserves. So we are going to be switching our schedule a little bit. I think you're listening to me and Bedside Rounds and Dr. Worst Games argue about EM versus IM doctors to begin. So we'll be getting started with that in just a few minutes. If you have questions, comments, thoughts, concerns, drop them in the chat. We are following that. And we're really excited to see everybody speak today.
Yeah, I can't wait. Thank you so much.
Yeah. Anybody else? Any last minute thoughts?
Yeah.
Want to listen to me monologue for the next hour?
Always.
First of all, I'm stoked to listen to you talk.
Oh. I'm going to go mute my headphones. But we will be back after the EM to IM panel, I think.
Are we? Okay.
All right.
Yeah.
So anybody who is excited for anybody in particular, drop it in the chat.
Somebody said in the chat that they think emergency medicine won. So I just keep thinking about that.
I'm not sure EM won.
And watch it and see what you think about it. Yeah.
Yeah. Also, I think someone had an Insta story about like who would win, and everyone was like, "Oh, EM fights dirty," which is
true.
Fair.
Yeah, which is fair. Yeah.
It's all the elevator poop. We're just gonna sling it.
We did okay though. Yeah. Okay. So I believe, obviously. Okay, so I think we're going to go now to the IM versus ED panel. We'll see you guys shortly. Thanks again.
Yeah, thank you.
My name is Abby. I have been a nurse for 13 years. I was a CNA before that. So I've been in healthcare for a long time. I've worked in a lot of different specialties. I've done long-term care. I've done mental health. I've done home care. I've done LTAC. And then I've worked med-surg and step down. And I landed in the COVID ICU up until this year. And now I'm a RN organizer in New York City.
All right, great. I'll go next. I'm Laura. I am an ER physician up in the sort of DMV area. I just finished my residency, so I've been in practice for about 3 years. I'm currently doing some health policy stuff and working clinically as an attending.
My name's Christina. I've been a nurse for 12 years in the emergency department, and I've been a charge nurse for half that.
I'm also a nurse. I've been a nurse for 10 years, and then I was a tech for 5 years before that. Most of my experience has been in the ER, but I have a few in the ICU scattered in there.
Well, I'm Jim. I've been a hospitalist for 20 years, and I was in private practice before that for several years, and before that I was in public health. And I've done a bunch of stuff with nurse practitioners, nurse midwives. I've done some overseas stuff, and I had a lot of different kind of cultural experiences. And but I've also been chief of medicine and chief of my group. So a lot of different experiences.
My name is Michael. Some of you may know me as the one behind the Instagram account Bedside Rounds. Been in medicine since 2008. Started as a basic EMT. Now internal medicine trained. I'm a hospitalist. I have a sprinkling of leadership and medical director experience to go with that as well.
All right, great. So we're very excited to have everybody here for our EM IM Battle Royale. Go ahead and place your bets now on who's going to win. I'm betting on the ER.
The ER always wins.
We're scrappy, like we fight dirty. So quickly, I think we should just start by discussing a little bit, why do we fight so much? Like, why is there so much beef between the ER and the general medical floors, med surge, tele, whatever we want to call it?
I think there's different goals. The ER is trying to get them, turfed as quickly as possible, and I am in the floor, and the hospitalists are, trying to avoid admissions if they can, and get people out of the hospital so they don't really have a lot of time to go back down to the ER and admit. So there's also probably different reimbursement mechanisms that make it difficult to concentrate on the same goals.
From a chart, the most roadblocking thing between the ER and the med-surg tele floors is report. And yes, report. We'll just go with that.
Right. Short and sweet. I love it.
I mean, from my perspective, I know that this isn't always true, but if I want to go with the spiciest thing, I mean, it feels to me sometimes like I have a patient that's coming up, and I'm in the middle of about 1,000 things I haven't even gotten to yet. And then what it feels like is sometimes the emergency room nurse is sort of dumping a patient on me because they just want to like get rid of that patient, and they don't care if I'm busy, or they're just like, here, bye. And the patient's a mess. And I'm just like, thanks, bye.
What are the things that we don't know about each other? So Michael, Jim, do you want to start? What are the things that I don't know about you that I do that annoy you, that I need to understand better about your workflow to make me less of a pain in your ass, basically?
We're all motivated by whatever is going to make our work shift easier, right? Because we're all under so much strain and stress, and on my end, not accepting another patient makes my workflow easier, right? Probably the same thing on the accepting nurses. Well, definitely the same thing there too, right? And I can see the same on the other side. An admittable patient, getting them moved, it's got to be a huge motivating factor on the other side too. I think one of the things that is so annoying for me is that our shifts usually start and end at the same time. And it's a problem because I can imagine as the ER doc, it's kind of shitty to have to sign out a patient that you got just about everything on, or maybe you kind of sit on this patient for a lot of your shift because you're thinking, well, maybe we can turn it around or whatever. And then you're like, damn, I'm out of here in an hour. I got to get my charting figured out. I guess this person's not going to be dischargeable the way I thought. And so I'm getting this call at 6:29 p.m. when my shift ends at 7, because our shifts, like the way they line up almost exactly in many buildings, it makes it so that now I have to decide, do I basically ruin my chance of leaving at the time I want to, or do I do what I think is a shitty thing, is now dump an admission on my colleague for the oncoming shift as well? And there's never any conversation about staggering shifts to prevent this from happening, but I know it's so common on our end, and Jim, you can chime in on this too if you want, which is that like 5 to 7 p.m. time where you just know you're going to get calls. It's going to pick up a lot, right? And then, I don't know, I'm sure it's the same on the other side too.
I think there's ways to mitigate that, but it also is, where I work, it isn't that everybody has the same shifts, because the ER stagger shifts. I think a lot of it is that patients, there's nothing going on at 7 in the morning everywhere in the world, probably. And then it just builds and builds and builds, and then it explodes in a marvelous, influx of patients between 2 and 10 or 12 midnight. So no matter how you shift it, you're going to get a bolus of patients at the end of the day. And we have the way we do it is we have different shifts, but you don't have to decide whether you're going to take it or not. You have to take it up to a certain point, and we leave a half an hour, catch up time, so that if we leave at 7, for example. Some of us do, because we have different ways of doing it. We have a 3 to 7 shift and a 7 to 3 shift, which really is nice for the hospice. But from 3 to 7, if you're on that shift, you're on call to the ER till 6:30, regardless. So if you got a 6:29, you have to take it. But you'll be done by 7:15 or 7:30, depending on how hard it is and also how busy it was between 3 and 7. So I think there's ways of mitigating it, but I think the way patients flow, it's really difficult to make it so that, you have to staff in ways that just don't make sense for people. If we would have to staff to make it make sense. You'd have to staff from 11 to 8 or something like that, and nobody wants to work that shift. You know what I mean? And who wants to work from 11 a.m. to 8 p.m. every day?
So that's an interesting point, because that's what the ED does, is like those busy hours, we extra staff a physician. And I guess my question there is, since I know like rounding, like we don't round it. So
well, we have to round. So the rounding, you're rounding all day, and we have 2 admitters. So that means that we only admit if the admitters get overwhelmed. So it's pretty nice for where we work. I love our schedule, and I love the way it works, but it wasn't always that way.
And I think in general, I think what you're saying is valid, Michael, as far as like when I call, I don't actually know what time our docs or our hospitalists change shift, because it's not 7 o'clock. Because I always call at 7. I'm like, hey, are you guys about to sign out? And they're like, what are you talking about? Absolutely not. So I always, like, if I'm calling about the time I think they're doing shift change, I try to be like, hey, are you about to change? Do you want me to wait? Because we don't change shifts at 7 in my ER where I'm at now. We didn't actually at my old ER either. So it's reasonable. Like, that's fine. Like, if it's at your shift change, I'm fine with waiting for the next doctor, especially if it's like, can I go ahead and put in a bed request and get this patient moving? I think that's a fine thing. I can call you and tell you the story later and get all the full orders in. But I think, and this is probably something we're going to have to come back to later as well, like Abby and I talked about this earlier, is a big thing for us is the timestamp for when we put in the bed request is like a metric that we're really dinged on. Like I'm evaluated based on when do I put in my admit order. So we'll call you, and like, I'm okay with you calling me back later, but I have to go ahead and get that bed request in or I'll get flagged for it, stuff like that.
On the order part, it's something that me as a charge nurse dealing with bed board has to put in the bed board system as well. And I have to report when physicians are being delayed in getting bed orders put in, and try to come up with some explanation as to why that happened. And sometimes it's just because, well, it's the ER and we're just busy, and they don't know that we just got like 20 ambulances back to back. Like, they don't know what happened, but I have to be accountable. I'm not accountable. I have to be accountable for basically tattling on people, even though I know there's a story. And so then I would always try to like say why, or I would just not tattle.
How many times did you come to me and be like, Laura, did you forget to put in that admit order? Like, ooh.
Because I would have everything except for the order, and I was really trying, and I knew that you guys were held responsible, and then somehow I was held responsible, and it's not it's not any of us intentionally doing anything. That's just the nature of at least the emergency department, because that's all I know. Like, I can't control who's coming in and how many people try to tank at the last, like unexpectedly, or, you know, someone is, you know, running through the hallways as they do in the middle of the night in the emergency department. Like, so there's just all these things. And I never enjoyed being in a position where I was expected to basically tattle and perpetuate this us against you team. Like, we're not a team at that point.
So I guess my question with this is, you know, we're evaluated based on these time-based metrics and so many other metrics, we'll get to it, but like, does that actually affect patient care? And I'm not saying the answer is no. This isn't a leading question. Like, I think in the ER, it is important to get patients dispoed promptly because we have 20 in the waiting room and we have to move. But like, is it actually capturing the quality that we're looking for to say, oh, I have to call you, I have to put in my admit order within 2 hours of the patient being in the ER, and you have to see them within 30 minutes? Or is it just like, is this something we need to be measuring and we need to be dinged for, and we just need to have better staffing to accommodate that time pressure? Or is it just a stupid metric?
I think metrics are just stupid in general, but I know why they do them.
Mm-hmm.
You know, it's a way to measure throughput, which is also a term that is annoying to me.
It's really problematic that there is a burden on a nurse to document physician-related workflow variables. That inherently sets us up to it builds resentment, you know? And unless you have a really strong, good workplace dynamic, like personally, you with that given nurse, it's really hard to work neutrally. It sucks, you know, because then you're having to do really unpleasant things, or like your name is going to go down on some documentation that, you know, does it throw someone else under the bus too? Like, that's tough, I think.
I do want to get through a couple things that I just like jotted down as far as things that I don't understand about internal medicine doctors that I know I'm making your life worse by not understanding. So I'm hoping we can get through some of those so that people can also hopefully understand a little bit more. Some of the things that sort of stood out to me were, I mean, I know in the ER as a resident, I was not capped. I saw the patients in my beds, and that was what I was expected to. I think for ACGME, I think the residents are capped a certain number of admits and a certain number of patients per day. But I imagine hospitalists, like once you're an attending, you're not, you just see patients, right?
There's no cap. There's only building capacity and nurse staffing, basically. What do you say, Jim? Sounds right?
Yeah, that's same with us.
I think we should also acknowledge, though, that nurse ratios have been out of control and all over the place. Yeah. And even if Jim and I can manage making the medical decisions and the documentation, we've had to do some, not us, but really unfair situations. And, you know, safety concern type situations have happened on both the ER side and the inpatient side too.
I have to agree to that. Yeah, I agree completely.
Yeah, and I think we're going to have a lot to talk about with nursing staffing.
We'll get to it. Yeah.
I do have a couple of things I noticed that you added to the doc, Jim, that I think are really interesting, and I'd love to touch on just briefly if we can. The one that stands out to me first is using the hospitalist as a consult to support sending home from the ER. I love that. I'm all about that. Is that something that's super like onerous or super burdensome to y'all? Or
yeah, it really is. We feel like, from our standpoint, the way I feel about it, now I don't know if everybody feels the same. I feel like that the decision to get somebody out versus admission should be able to be done by the ER. Mm-hmm. So just add another hour to my workday to go down and see somebody and just either, you know, say, yeah, I agree, they can go home, or no, they should come in. To me, that's an hour I really shouldn't have to spend. I understand why you do it, because you're not sure, and I get that, so I don't usually complain, but internally I'm complaining.
So I guess from my perspective, and maybe I think everyone's practice patterns are a little bit different, but really the only time that I use the hospitalist consult is when I think a patient needs to come in and my hospitalist isn't sold on it. And I'm like, I'm seeing the patient. That's sort of how I feel, is like, if I see the patient and I think they need to come in and whatever I'm saying on the phone isn't selling you on it, my answer to that is always come see the patient. If you consult on them and you see them and you still think they need to go home, that's fine. But I think I'm on the same page. If I think the dispo should be something that I decide, and sometimes, not often, but like sometimes the hospital doesn't agree with me on that.
It doesn't happen very often, but what's happened is that I go down there, or our colleagues go down there. They say, yeah, send the patient home, and then the ER calls another hospitalist in another group because they don't like the answer.
Yeah, that's not great, but
I find out later they're admitted to the other group.
I'll tell you what I love though, which is if some ER provider calls me and they say, hey, I got this person, I'm not quite sure if this needs to come in or not. And then we have like a conversation. I may pull up the chart and look at the stuff and, give whatever I think would make sense as far as recommendations or whatever, like, a TIA patient that really does not want to come in and, what would be an acceptable discharge plan or whatever. If I can just do that and not have to generate an encounter and, leave where I am and go to the ER and see the patient, interview them, do an exam, and then do the documentation, which boy, do I hate more than anything. If I could just have a phone conversation and help with dispo in that way, like that's actually really feels really good.
Yeah.
Yeah, I wouldn't mind that either.
I do love
the time you have to go down there is what's difficult.
Yeah.
I think that's fair. I think
because they're scary down there in the ER.
There's always somebody screaming. There's always somebody naked. Like, it's always something.
No, I'm talking about like the staff, actually.
Oh, I was too.
Scary.
Actually.
Oh, okay.
Same page.
We are.
Yeah, and I think that's fair. I mean, I don't get like, I don't need face-to-face consults in the ER a lot, and I think that is like I think that's a little bit shitty because I feel like it's putting the burden of like medical legal responsibility on y'all, which I think is unfair. But I do like, something that I've loved since COVID is like, I had a COVID tachycardia who was just fine. Like, she was recovered, but her heart rate was sitting at like 130. And I just called my hospitalist. I'm like, what do I do about this? Like, we don't get this in the ER. Like, I'm not discharging post-COVID patients very often. And I love having those conversations. And I love when our medicine colleagues are willing to just talk me through, like, this isn't something I've seen. Like, what do y'all normally do when you discharge this patient?
Yeah.
I love you guys when you're open to those calls too.
Yeah. Laura, the thing is, I don't know if anyone agrees or if everyone agrees with me on this, but to me, it's so important that we trust the scope of practice of ER docs, and we can help guide people towards, hey, maybe this one doesn't need to be admitted or whatever. But if someone on the phone is like, I really don't think this one should go home or whatever, not going to fly, failed the road test, whatever it is, I have just made it my policy to just bring somebody in, even if I think it's soft. Sometimes it ends up kind of being a waste of time, but we call it patient safety. Sometimes I go and see someone at the bedside, I'm like, holy shit, this person with normal labs and normal vital signs looks like they're gonna die somehow. Like, how is that possible? This person looks so sick. But I thought this was such a waste of time too, So if we give a little bit of grace to the ER providers, and then they see that we kind of pull through for them and back them up, then here's one thing I gotta say. I don't know if I'm getting on topic here, but Jim, you and I and the other hospitals, we have no idea how many times a day it's happening that somebody that was really in the gray zone was managed and treated and turned around and discharged, and we never got that call. We never heard about it, right?
Yeah.
I know we're supposed to be fighting each other, but I think this needs to be said. Like, we have no concept of how many times there is some degree of like high acuity care, and then we don't see those patients sometimes. And it really is protecting us on the inpatient side too.
Oh yeah. And there's also, by the time we see the patient, they've stabilized the patient and they look a lot better.
Yeah.
So it's hard to make judgments sometimes because the ER has done their job and the patient's better, still has to be admitted, but didn't look, when they first came in, you hear the ER person saying, God, this guy looks terrible. And then, by the time you're there, they've stabilized and they look better.
Thank you for the credit there. We very much appreciate it. That was like something that I had on my notes for EM docs. And I don't think medicine is nearly as bad about that as like surgery or OB. Sometimes we'll get really mad at like, why are you calling us for this simple abdominal pain? And I'm like, do you know how many abdominal pains I didn't call you for today though? It was like 30. Like,
and then you know what? I think this sounds like a medicine patient. So why don't you just call medicine for the bowel obstruction post-operatively? Sounds like a medical problem.
I always apologize so much for those. I feel so bad, but like, your point about soft admits, I actually have a question, and then I also want to talk about something related. Do you prefer, just personally, like this doesn't have to stand true for everyone, when I call a soft admit, I'm like, hey, this is soft, I know, but is that more or less annoying if I acknowledge that it's a soft admit?
It's got to depend on the person, I think. But for me, at least, if I'm going to get a story of somebody that doesn't sound very sick, and I know up front you already think that's the case, like a 4 a.m. Lady can't go home because she can't take 3 steps and her social support is awful and everything is normal, but we just can't send her or whatever. Yeah, of course, like I it helps me to know that. I think other people may not care as much. I think by the fact that we are in this conversation, we're generally people that care more about these interpersonal things. Some providers generally don't give a shit what other people think at all. They just want the information they can go on about their stuff.
That's fair.
Yeah, I think everybody on the panel, and probably a lot of people are watching, are respectful of their colleagues. And so, we have a debate, but, we're respecting each other. And that makes it less of an angry back and forth debate.
That's true.
We haven't got to the nursing side.
I'm
kidding.
That's gonna get feisty.
I'm kidding.
And then that was my other thing was I think Jim, you added it to the notes. I know something I want to talk about as well is social admits, like these soft admits. I think the worst one I ever had was a guy who I admitted with a chief complaint. I'm pretty sure he's blind, and that was the whole complaint. And it ended up being a pretty interesting case. But like, I feel like those were a much bigger thing in my practice before COVID. Obviously, with the bed situation in COVID, they've gotten a lot more challenging. But I think that's something that a lot of the hospitals that I've worked with have been sort of annoyed about is doing social admits. And some of them are totally understanding of it. But at the same time, like, it's really hard to discharge someone from the ER who's homeless and can't walk. Like, that's not like something that I'm comfortable with doing. And I feel like the system, I think, puts us in this really weird situation of like, they're not sick enough to come in and I don't have anything else to do with them. So what do I do? Like, and I know it's the same thing for y'all on the floor. Once they're there, what do y'all do with them?
We have to put them in. I mean, that's the trouble. We have to put them in because the social support system is so, is not good enough. There's not it's not just the fact that there's not as many social workers in the ER, which typically there aren't that many. It's just that where are you going to put them? The social workers can only do so much.
Mm-hmm.
Yeah.
So it's a sign of our healthcare system that needs so much work.
Mm-hmm.
So social admissions are just because of our healthcare system. I bet other countries don't have social admits. I'd be interested to see, in some of these other countries that you hear they have greater coverage, whether they actually have these kinds of admissions.
I want to say something else here, just to back up on what Jim's saying. It sounds like Jim and I both, by the way, would accept your social and soft admits, but we have to medicalize people here, right? We have to declare them some sort of, like sometimes end with inability to care for self as the number one diagnosis, right? And this is beyond just a failure of our healthcare system. It's a failure of our social safety nets, right? A failure of our overall society to protect people as they age and become more mobility impaired and just need more help in general. So doctors and nurses are having to medically manage people in hospital beds for this stuff. And we got to have the most anywhere, I think. Perhaps in other countries they happen to some degree, but it's so common every building has got them, you know?
Mm-hmm. I know there's some programs about this. I think it's Denver just started doing, like, has built transitional housing basically for patients because they had so many long-term patients and there wasn't the social infrastructure for them in Denver. So the hospital system built it. And I think that's something that we're probably going to have to start seeing a lot more of, is hospitals as the only even semi-functioning social safety net. I think we're going to have to start getting more into the housing business, because I think it is important that we take these patients, and I think it is important that we, I guess, don't always medicalize the aging process or medicalize just, sort of these long-term issues that really need social support, not medical support.
Yeah. I just have this message though to anybody that doesn't like social admits. If you're on the admitting side, like, are you really putting yourself in the position of the ER provider and thinking about this human being that you're taking care of and what happens if you discharge them and you know that they're not able to take care of themselves? Like, you have to see yourself as what would I do in that situation? If it's not a dischargeable patient, then it's pretty clear what you need to do within the specific role of being a general medicine admitting provider. As much as we hate the failure of our social safety nets and otherwise, it's the only humane thing to do, really.
And I mean, I hate that the only social system that works is the ER. Like, I wish we had social systems where it wasn't just down to us to provide support for people who just need social support. But at the same time, I do think it's important that, since we are the only ones that are doing it right now at a macro level, I do think it's important that we do it. All right, this got real serious, and now I'm going to make fun of internal medicine doctors for a little bit. Y'all ready?
Good luck.
Yes.
I'm
Let's
excited.
Good
go.
luck.
I'm ready for this. So I think the big things, and I think probably none of these apply to you guys because you guys have basically answered all of my questions in the way that I want them to be answered. But the big thing for me that's always been an issue with trying to admit patients is, and this again varies by hospitalist, but I think the big difference in practice is that we don't think as much in the ER about a diagnosis. Like, we're very dispo focused, and it's something we talk about with our medical students. I know, and I know you have a response to this, but like, it's actually, I was thinking about it, like when I was a medical student, there was like a thing we got all the time was think dispositionally. Like, it wasn't like, oh, like, does this person have Addison's disease? It's, okay, are they sick enough to come in? And like, once you figure that out, everyone's sort of like, all right, we're bored because we all have ADHD that's not treated. So I think that's like a big thing. And I know, like, I totally understand. Like, sorry, Michael. I totally understand that.
You have ADHD, Laura? I had no idea.
What?
I'm so surprised to
This is
hear
why
you say that.
Laura and I get along very well.
Wow.
How many fidget toys do you think I have on my desk right now?
Yeah, I don't know. At least one.
Like 7. Anyway, but like, I understand. I think to a certain extent, and this is a conversation I have with patients a lot, like, I think in terms of diagnoses that are going to kill you. And then once I get past those, I'm like, I don't care anymore. Sick, bring them in. And I always feel so bad when like the shop I'm at now doesn't have MRI at night. And I'll be like, oh, well, they need an MRI. And I'm like, yeah, get it later. Like, they're not getting TPA for a stroke. So it's not a right now problem. And I always feel bad, but at the same time, like, that's how we're trained to think. And I know it's really annoying. So you guys can make fun of me now.
Sometimes we need a little bit, Laura, because I need to know what sort of care I can start arranging. Am I dealing with a neurosurgical emergency, or am I dealing with acute back strain, for example, right? Since we're talking about MRI. Sometimes I may not be the right attending for this patient. So there's that. But really my main gripe is I just don't know why you guys need to all right, Abby, here we go. I don't know what's with all the IV fluid. Like, why do you guys love the why are we giving so much fluid to everybody all the time? Because
love it.
I want to know that too.
I just
And
want
how
to
about-
I basically want to stop a bolus as soon as I start hearing about the case. All, like, not every time, but 18 times out of 20, like most times. Explain, Laura.
I don't actually have a good answer because I don't really do that. Like, I don't want to say I'm afraid of fluids. I'm a little bit afraid of fluids. Like, I feel like I take like the house of God approach of like the less you do to a patient, the better. So I mean, I think for like young healthy people with abnormal vital signs, we're gonna give fluids. Like I tried to explain to my mom one day about how the ER approaches medicine, and it's basically like if something goes fast, you make it slower, and you have 3 ways of doing that. So like the fluids are just like the first way of bringing the heart rate down, and that's like the depth of my understanding of how to make things go slower. I promise I'm a real doctor. I went to medical school and everything. So I think for young healthy people, it's just like a reflex thing of like we have to, especially if we're thinking they might be able to go home. One of the things that we have to do to get them home is have resolved vital signs. Like I don't send anybody home if their heart rate's above 110. So if I have a 25-year-old come in with a heart rate of 130, I'm gonna give her a liter of fluids. I might give her like some Visceral or something to calm her down, some pain meds, with the hope that I'm gonna get her home. Like I think a lot of those are, I'm trying to get her tanked up enough that I can get her out of here. Maybe I fail, and then I bring them in and they've gotten fluids that, you wouldn't have bolused 2 liters, but my goal was to get her tanked up and get her home. With old people, kidney disease, heart failure, anything else, I personally don't like, I'll do 250 or 500 of fluids. I don't think we should be bolusing aggressive fluids. I fall out of my sepsis metrics again. I know this is your point of big sepsis. I don't think it's appropriate in a lot of situations to do the 30 per kilo bolus for like unproven sepsis, but it's another thing we do get dinged for. Of like, if you're not doing these sepsis metrics on anybody who meets any service criteria, you're going to get flagged.
But why not just make like a dot phrase? It says, in my opinion, this patient should not receive the full 30 ml per kg bolus.
And Christina, you might actually know this. Were you on the sepsis team? I don't remember.
No, I wasn't.
Okay. What I was told in residency, and I have not fact checked this, but this was like from our sepsis team in residency, was that even if you document that, if you don't meet your metrics, like even if you say, I don't think this patient needs 30 cc's for whatever, you still fall out.
Yeah.
The only thing that I was told that we could like change for was you can calculate ideal body weight and do it based on that. But I have been told, like, as part of my training, that it doesn't matter if you don't think it's medically appropriate, you still have to do it.
So to Jim's point before of like a nurse's job to kind of like tattletale, that's part of my job is to to assess that. Like I have a cascade of a sepsis protocol where I can say like, this is what happened. And then I have a place to document, did the provider respond appropriately? And if not, it gets escalated immediately to like my manager, which is really messed up.
Which means that management and people in charge of quality in the hospital are dictating how we hemodynamically manage people's fluid volume status.
Yeah.
Well, they're just following the national sepsis guidelines,
which I think is another
which they are.
Oh my God, these guidelines.
They are.
I know it's.
But the thing is that the guidelines take a little bit too long to change with evidence, and that's the trouble. The whole saline versus lactated ringers is. I think a lot of these protocols have saline instead of lactated ringers when we know lactated ringers is safer.
Yeah, but I mean, even if we're using saline, if we're bolusing appropriately, we still have data to show like it's probably fine. It's just that we're hitting up small bodies with like 2.5, 3 liters. And I have been hearing this for years. The ER doctor tells me, yeah, I gave it that just because I keep getting emails from quality. I'm hearing that everywhere. Every building I go to, if I actually have a one-on-one talk with the ER doctor, they're literally saying, I just don't want to get any more emails and fall out of sepsis stuff.
But you're getting those because they're getting national guidelines, and they get, the hospital gets dinged and millions of dollars if they fall out. So
reimbursement goes down. Yeah. So this is money.
Yeah. It decreases.
But there is some things that I think hospital reimbursement doesn't make clinical sense. But when you have guidelines that are evidence-based and you're making decisions, quality decisions based on good evidence-based guidelines, there's nothing wrong with a national, let's get rid of let's reduce sepsis campaign. and hospitals are okay to respond to that. So I think there's a division between, evidence-based guidelines that hospitals do give you pressure on that I think is okay because it's clinically valid, versus things that are just like length of stay is, annoying, and it doesn't really affect patient care as much, other than a patient having to stay because they didn't want to stay or whatever.
Yeah, and this is something actually one of my classes talked about pretty extensively a couple weeks ago, of like the quality metrics we're looking at for like the big ones that CMS measures are readmissions for heart failure and quality metrics for heart failure and MI and pneumonia, I think. I think there are 6 total, the 3 we looked at in my class.
But there's data coming out that readmissions for heart failure is not as valid of a measure as they thought it was going to be.
And really it's for all of them, of like readmissions isn't really a marker of quality, or like, are we giving aspirin for every chest pain isn't really a marker of quality. So it's like, we're being dinged, and the hospital loses up to like 2% of CMS funding if they're in the bottom 5% or something. I don't remember the exact numbers, but if you're not meeting these metrics to a certain level, you lose tons of funding. But like, it's measures that don't actually really correlate to care. So we're being like, I get it. I shouldn't give 30 cc's per kilo to every patient reflexively. That's not good medicine. But it's also like, the hospital's going to lose money that, for Medicare patients that I provided care, but this non-evidence-based guideline, and I really think it turns into people who aren't clinical practicing medicine and telling me what my medical guidelines are, and not letting me, who like has eyes on the patient, who knows their EF, who knows like these extenuating circumstances, they're not letting the doctors make medical decisions, which I think is really frustrating for everybody.
Yeah, Laura, I know we don't want to spend the whole time on this, but I can tell you from my time in a very small building and being the main physician responsible for sepsis outcomes in the whole building, a really small building, it counts to just say, this is my medical judgment that this person technically qualifies for a particular bolus amount, but I think that it would be harmful to the patient. And okay, yeah, it'll end up being flagged and go to quality, but I don't think it counts as a true fallout failure necessarily. So I guess what I'm trying to say is I think that all the ER providers, and like plenty of admitting providers as well, can fight back a little bit and push back so that we're not just stuck bolusing people because we're so burned out from getting emails. And like the emails that I would get are like, hey, this is the case, please review it on your own time and write a response in terms of what you think happened and what you would do the next time. It's like, I really don't want to have to deal with that email, so I get it. But we need to like work together to find ways around this situation.
So this is a very specific and very annoying one, and I wrote it in a deliberately annoying way. I don't care about social history unless I care about social history. So that's like one of my favorite things is when my house list is like, oh, what's their other medical history and what's their social history? I'm like, I don't know. Like, unless they're here for drugs or alcohol, I don't ask. Like, and I just don't. Like, I don't.
Like, but
I know you're
care
gonna
that
be so
much.
You're gonna be
No, like it's okay.
Okay.
It's a waste of time. Like in the ER attending.
You
Right,
do need to know about alcohol though, but you don't have to do. I mean, I don't really care if you ask for the social history. I ask it anyway.
Yeah.
What hospitalist cares?
Well,
they have themselves.
My favorite one, and I have told Abby this story like 5 times because it's just like the funniest story to me, was I at one point had a girl in residency who like came in extremely ill, like coded 4 times in route, and we got her back and we did all this critical care, like she was intubated, lines, and all this stuff. And then one of the ICU residents came down and was like, how much alcohol did she have last night? I'm like, I don't know. She was dead when she got here. Like, I don't know these things.
Well, what I do care about is lying on your documentation.
Yeah.
That, patient that as a non-smoker, I go in, I smoke a pack a day.
Fair. I just don't document stuff. Like, I don't document murmurs because I'm going to forget what patient had the murmur unless it's like a florid murmur and I think it was something relevant. Like, I don't, people will have templates that say no murmurs. I'm like, I don't remember.
Are you getting a lot of pushback from hospitalists that you don't have a social history, in a family tree all put out there for.
What's the 23andMe printout? Do you have it attached to the chart?
I wouldn't be surprised if someone came in with that one day. I'll let you know. I get a lot of pushback from like, oh, what other medical problems do they have? And I mean, I think the entire ER approach is, we teach our med students to do the 3-minute history and physical of like, if you are here for something related to chest pain, I'm going to give you the relevant things related to chest pain, not that you had laser eye surgery 6 years ago. Like, and I feel like I do get a lot of pushback from those. And I'm like, I told you the things that are relevant. Like, I'm also a doctor. I don't think that their gout is relevant to their asthma flare today. I mean, maybe it is, but like probably not the main driver. But I get a lot of pushback for stuff like that. And I'm like, I don't know. It's probably in my HPI because I usually like dictate all of that stuff from the chart as I go. But like, I might be presenting the patient to you while I'm outside of another room and I don't necessarily know 13 medical conditions. I get a lot of pushback from stuff like that. Like, I feel like most hospitalists are like you guys, and like they do want what's best for the patient, and they do respect us as sort of as doctors. But this is like one of the things that, just talking to my colleagues, like we do get a lot of Monday night quarterbacking, and you alluded to this earlier. Like, you'll come down and see the patient, and they look pretty good. I'm like, yeah, because I worked on them for 4 hours. I promise they're still sick, and they still need to come in. And I think there's a lot of propensity to sort of play, devil's advocate or Monday night quarterback or whatever, and say, oh, you should have done this differently, or why didn't you rule out this? And a lot of the time the answer is because when the patient came in, this was their complaint, this is what they looked like. And based on my clinical acumen, which is like not zero, it's not, it's maybe not the best in the entire world, but it's also like, I've done some training. I know a few doctor things. So that's, I think, going back to, you're talking about wanting an MRI to make sure it's not a neurosurgical consult. And I get that. I totally understand that, like, you need to rule out, does this patient need to be transferred? Does this need to go a different level of care?
Laura, I was just trying to be toxic a little bit.
I know,
okay.
I'm a pushback.
We don't have to stay on that one.
No,
That's
I'm a pushback because, like, to a certain extent of, like, if I didn't think it was I do, like, we diagnose sciatic rhino, we diagnose spinal fractures of, like, if I don't think it's a spinal emergency, why do you? You haven't seen the patient,
There are some basic things that the ER should do, though, right?
I'm sorry, say it again.
There are some basic things that the ER should always have before they call the hospice, correct?
Yeah, I think that's fair.
Because we actually had a team of ER and hospitalists working together to create that. It wasn't as easy as you think, but we did come up with, okay, this is what you need to have before you call the hospitalist, and everybody agreed on it. So, when that doesn't happen, then we have the reasonable, we can say, hey, where's my Chem 7?
Yeah.
Jim, don't you hate if an ER doctor calls you because there's like a fracture that ortho is like, cool, I get to operate, but cool, I'm not going to be the primary because my hospital leadership will support me in not doing that. And then you get a call and there is zero lab work at all, even though they need general anesthesia. That boils my blood a little bit.
Or they would have to admit these people. Why are we admitting ortho patients with no problems? Why am I admitting an appendectomy?
That's right, Jim, keep going.
I admit a 23-year-old appendectomy with absolutely no problem. Other than that.
Yeah, I totally agree with that. I have a question actually with that, because like, this is one of the situations where I'm like, I'm happy to order stuff for you. Do I really need to wait for the Chem 7 to come back? Like,
yes, you do. Because, for example, I've had a couple of cases where they didn't have a Chem 7 and the ER doctor said, well, I know the person's coming in anyway, so just take them and you'll get the Chem 7 later. Well, I needed to know, the person ended up, having acute kidney injury, which I didn't know. Another thing was, they're going to go to cath next day. So I needed to know where they were, where they were to go. Were they going to go to cath? They could have gone cath maybe that day if the creatinine was okay. So, I mean, those are some things where you really absolutely need to know. What the potassium's 2.8, why wasn't that corrected in the ER? Well, we didn't have the Chem 7.
Yeah, and also, this is important too, Jim. If some of these labs are abnormal enough, it will affect which unit the patient needs to go to as well, right?
Exactly. Yeah.
So like a hemoglobin level, electrolytes and kidney function, really, it matters. So.
But it doesn't take that much long to, it doesn't take all that long to wait for Chem 7 or a CBC.
Okay, wait, hold on. I have two things. Sorry. First,
I'm gonna lose.
Yikes. This is scary a little bit.
I
Sure,
want to
go
say,
ahead.
no. I just, okay, wait. I want to echo something that was just said that um it's the bane of my existence when somebody gets admitted and just like what we were saying, where now they're admitted to the wrong unit and I just did the admission. I don't know if the doctors are privy to how much information I also take and how complicated my admission is, my nursing admission. It takes a long time. And I don't know if anybody ever looks at it, but I have to do it. And if that patient gets sent to me and it's the wrong unit and I did that admission, I'm going to come down to the ER. I'm going to be the one screaming and taking my clothes off and running around because it is the worst day of my life every time that happens. Okay, wait, Laura, you said, I'm looking at your notes right now and I'm dying to see what this says. Chicken points.
Oh, this is a fun one. I love
What does this mean?
Chicken points. So my favorite, and I totally get this from a nursing perspective. I just think it's really funny. And this is honestly more of like an outpatient medicine thing than it is inpatient medicine. Of like the number of people that I get sent into the ER because their blood pressure is 220 and they're completely asymptomatic is insane. And I'm just like, cool, do you want to leave? And they're like, yeah, I'd like to leave. And I send them home. Like, I feel like what I mean is like chicken points of, I don't care about, like, if you're fine, if you feel okay and your EKG doesn't have florid ischemia, I don't care about your blood pressure being 220, or like, I totally get it that like, I have to get your SVP below 180 to go to the floor. I understand that. I just think that the chicken point is just fun. Or like, I think I told you about this, Michael. I had a patient a couple weeks ago who had a good story for ACS and had like multiple negative tropes, multiple negative EKGs. And I was like, all right, cool. She has a good story, bring her in, for the workup, but like not emergent at this point. And it was like the hospital that I was working with was like, you need to call cardiology. And I'm like, for what question? Like, I don't want to, and this goes back to some of your cartoons of like, why am I calling this consult if I don't have a question for this person? Like, I don't think they need to go to cath. I don't think they like, I've given them an aspirin, I've got some nitro on it. Like, what I'm calling to be like, yes, hello, this person has a heart and their chest hurts and they're not related. Like, and I get it. Like, I know you guys are busy, and like, if it's a consult that's actually needed, I don't mind calling that consult and like taking a little bit off your workflow, because I think we do have some more resources sometimes. Like, I have a clerk to call my consults for me. Like, I do have more resources sometimes than you do. But I think that like, that's one of the things that does frustrate me is when medicine will be like, hey, did you call this consult? And I'm like, no, I don't have a question for them. Like, I know how to manage this.
Yeah, I think in some buildings, there's no ischemic workup ordering that can be done unless it's ordered through cardiology. But like in the places I've been, I can order nuclear stress testing, I can order treadmills and whatever. So I don't need cardiology for that. And I suppose I'm being generous with whoever this person was, but it sure would be a shame if that person was just lazy or like not wanting to do the work that they're supposed to do. I wanted to attack an ER nurse briefly, if that's okay.
Yeah.
Go.
Christina's scrappy. You better watch out.
Attack me.
Hi, Christina.
Hi.
Sometimes there's these admitted patients, and I just want to like get one thing done as I admit them before they actually start being packaged up and bundling or what. Like, usually there's like 30 to 60 minutes or whatever. But like, and I'm not talking about admission orders, but I can go into the ER encounter side and put an order in for like, hey, how about some IV labetalol for this blood pressure of 230 in my stroke patient to get that down, as an extreme example, but just like something that seems like it may be time sensitive and like standard of care-ish, and it's like nobody, I'm trying to be,
Don't be. Just bring it.
Just do it.
I have to phone the ER,
Mhm.
reach the ER doctor and say, hey, can you please put in this order for this patient? Because if I do it under my name,
Mhm.
then like suddenly there's a significant vision impairment with whoever else is like looking at the screen.
Because they think we're cooler than you are, so we win this one.
Yeah, that does happen.
No, you, I'm sorry. Go ahead, Christina.
Oh, no. So yes, I will admit that that absolutely 100% happens more often than I like. Um, and that is, I find an individual nurse's practice, how they practice, and also extenuating circumstances of what's going on with their other patients. Like, is that their priority right now? But some, and then some charting systems, when they're admit orders, we don't necessarily even see them. They go in a different part of the chart. So if you told us that you were going to do that, when that's the problem, the EMHR, then there's no excuse for that. But sometimes it's because of the charting system and how it's set up. Sometimes, like where I work right now, if you put in an order for the patient as opposed to my ED physician putting in an order for the patient, I now have to wait for pharmacy to verify your order before I can even go and pull that medication.
Right.
And do the ED physician orders they just go straight to Pyxis? Like
They just go straight and I can get all of them. They don't have to get verified. But once it's an admitted patient and an admitting physician is putting in orders, our process where I currently work is I don't have to do any admission orders until they've been in my department for 4 hours.
Yeah.
Wow.
There's
Yeah.
a big,
And so I don't even release, not me, but like ED nurses aren't even told that they're supposed to release admission orders until they've been there for at least 4 hours.
right.
Some people practice differently. And if I know that I'm always holding 70% of my patients in the ED, because that's what we're doing, then I know you're not going anywhere. And I'm at a point where I can, in my workload, that I could focus on all of, because once I release those, then it's just a gazillion things for me to do. And at the end of the day, I'm not a med surg tele nurse. And so, and then I have to go in and do those. So me personally, I wait until my ED patients are stabilized. In that extreme instance, I wouldn't have waited on you personally. I would have gone to my ED doc and got an order for something and called you and let you know that that was happening. Because we like instant gratification in the emergency department.
Yeah.
And so on the floor, they have rapid responses and all of those things. I have an ED physician and it's super convenient. And most ED physicians are against in an emergent order for me or a somewhat critical order for me right now. And then I can deal with you or the ED physician can deal with you. But I do know that it is a practice of some nurses that if it's an admitted order, it's not their job.
It's also a little bit of a turf battle between nurses. Like if there's an admission, this is my doctor putting it in on the floor, and the nurse downstairs put it in. First of all, like you're saying, the system doesn't even communicate. Like I don't even think the ER can see those orders where I've worked. And even if they could, then I would still see it. It would show up as maybe even a duplicate in mine. Like where I've worked, it's like hands off. Like they don't touch it. That's mine. Like, and that's mine to deal with. And if it needs to be given in the ED, they have to call the ED doc and get an order for it.
And some systems are so broken that when you put in your orders and you've been in my department and say, I want to do some things for this patient and I release them, as soon as they just move within the computer system from the ED to the floor, all of the orders that you've put in have completely got canceled. And now I have to call you and really piss you off because now you have to put in all of your orders again.
Yeah.
Because of the computer thing.
That's happened to me too.
This is really super as a problem. Because that's I mean, some people are boarding in the ER for 24 hours or less, and that's a big delay in care. So, we worry about throughput and discharges, and it's just this whole cascade if you have even a 4-hour delay of care, it's a big deal. So, and I don't think administrative people are actually looking at that little section of time, and they are, but not really. You know, they're sitting in the ER. They're bored. They only start worrying about it if they're there for like 24 hours. But 4 or 6 hours sitting in the ER is a lot of time that orders could be getting going, and they're not. So, you know, I think it's something that the system needs to look at a little bit more carefully.
Hi guys, welcome back. As you can tell, we had a lot to say with the EMIM panel. So in the interest of not boring you for 2 straight hours, we're splitting it into 2 separate panels. So that was the doctor side of things. Drop in the comments who you think is winning so far. It's definitely not me. I was losing. So we're gonna take you to some of our other speakers and build some suspense. And we'll come back to the EMIM nurses, the really interesting part, in a little bit.
Next, our video will be Anthony. He is an EMS worker. He's been through COVID, paramedic. He lives in New York City. We're so thrilled to have him. He actually came to DC. We walked with him. We walked from Union Square to the Washington Monument, and we listened to him speak about his experience. We're so thrilled. Everybody, here's Anthony.
Hello, everyone. Thank you all for tuning in and being here today. My name is Anthony Almagera. I am a lieutenant paramedic for the Fire Department of New York City, Emergency Medical Services Command. I am also the vice president of the FDNY EMS Officers Union, Local 3621. As you are all very aware, today we are here for a momentous event. We are here today to demand that this country recognize essential medical workers in a way that is real, tangible, and long, long overdue. Beyond the empty slogans of calling us heroes and throwing up a sign in a front yard and offering us a free beverage at a participating coffee chain, we are here today to articulate our demand in clear and no uncertain terms. You know what I'm going to say. We want equal pay and benefits, and we want it now. Equal pay to our fellows in other frontline services, and equal benefits of all those across the medical community spectrum. Am I out of line here? Should I just go slink away and take the crumbs that are offered? What do you say? Woo! Hey, you know I've been working EMS for nearly 20 years. 20 years in New York City. 20 years ago, I started out going to EMS school and living out of my car because I couldn't afford rent. 20 years ago, the Twin Towers were rubble, so the focus was elsewhere. But I joined and believed and persevered. So in those years, I have been in your homes and your workplaces. And I have seen the vicious impact of not having access to healthcare has had on everyday families. Oftentimes in EMS, we become the primary healthcare providers due to our fellow citizens' lack of healthcare insurance or access to decent, qualified medical facilities. And over the past 24 months, the medical reality, this incredible inequality, has only gotten worse. As we all know these last 2 years, well, you tell me in these last 2 years, what's happened to you, and what do you know, and who do you know that's been hurt, devastated, and bankrupt? Yeah, that's what I'm saying. I'll tell you this, going into the pandemic, EMS wasn't the service that New York City deserves. Do you know that very few members stay in the service for more than 5 years? New EMS workers can't make a living on $35,000 a year in New York. I'll tell you, the benefits offered are worse. So we've become a corps of novices, well-intentioned, but sometimes acting well out of our scope of expertise. In the height of the coronavirus crisis, I had emergency medical technicians with 6 months experience running an ambulance with kids who were fresh out of the academy. They coped incredibly well, but it wasn't fair to them. They'd stumble and falter, ask questions, and stare into space, wait for an experienced tech to take over. And we did, and they did, and they got better, but it's not how you run a world-class emergency medical service. For myself, I didn't weather the pandemic so hot. I thought I could handle anything my job threw at me, that I could witness any amount of suffering. I thought I was that someone who could I thought I was that someone who people could lean on. After all, I was the senior paramedic who could restart a person's heart or detect a rare aneurysm and save a guy from drowning in his own blood. I was the union vice president, blasted the higher-ups on Twitter and butted heads with them in person to defend my co-workers' rights. I was the guy who cooked a 9-course meal for his friends at Christmas and organized group vacations to Hong Kong and Dublin and Uganda. I thought I had all the right moves codified and memorized. But I thought wrong. Yeah, you know. Because when the virus hit in the spring of 2020, I was already emotionally drained and disillusioned and disintegrating. My body was taking a toll. I had been worn out by my job and the frustrations of fighting for better pay and benefits. I had an arm injury incurred from carrying my now dead lieutenant out of his home. An event that shook me to the core as I saw my future laid out in front of me and his helplessness and fear. The injury meant I couldn't carry anything heavy, and a job where lifting dead weight was routine. I was contained to light duty, chained to a desk, a computer, and a dispatcher's radio. So I packed on the pounds and churned with unspent energy as COVID raged. Normally in New York City EMS, we normally handle 35,000 to 4,000 calls a day. A nice number, right? Well, I'll tell you this. In the 5 boroughs during the height of the pandemic, we were handling 6,500 to 7,000 911 calls a day. Cardiac arrest patients, normally in the 60 to 80 a day range, shot up to over 400 a day. You know, we in the unions have told our city governments for years that EMS was critically understaffed, woefully underfunded, and completely mismanaged. That we were lucky to continually just get by with what we had, and that if the big one ever hits, the proverbial chickens would come home to roost. Well, what happened? During early March, we started to bang out that drum even louder. Where were the PPE kits? What were our contingency plans? Where was the energy and the compassion New Yorkers had after 9/11? Now we were meeting up with COVID-19. As we soon came to find out, there was none. We watched in horror as the call volume shot up, and we were unable to keep up. I watched in horror as we responded heroically in spite of the odds, but eventually we could not keep up. Calls went holding for hours. Hospitals couldn't handle all the patients we brought in. They started to use our stretchers to perform patient care. Keeping the worst afflicted strapped down, they are attached to ventilators as the medics watched helplessly and unable to go back and respond to more 911 calls. And so eventually we started to get sick. At one time, over a quarter of our workforce was out. At one time, over a quarter of our workforce of about 4,000 was out sick. There were days I'd respond to 12 to 13 cardiac arrests. I personally saw more people die in those first few months than in the last 5 years of my career. And as we got sicker, then we started to die. As of today, 16 of us have passed away due to COVID. And we also have endured 4 suicides. This job extracts a heavy toll in normal times. But the pandemic left us empty and lost. Like newly graduated EMS cadets, we were looking around for the experienced and confident to save us from ourselves and our weaknesses. But we were all afflicted, and we were all in it together. We still have too many members out there who will be unable to come back to work due to COVID. We have had members who had to leave and take care of sick family members, then who lost their jobs, and then lost their health insurance. They had to choose between buying food and being able to see a doctor. This is the reality of our world. During a global-wide pandemic, people actually lost their medical insurance. In my job, if we come off payroll, we lose our insurance. The choices were literally life and death for us and our families. As emergency medical service personnel, we know from life and death. This is our business. And yet things happen so fast to all of us. The pandemic highlighted something that we in the medical community have known for years. We need what the rest of the world has. We need recognition and care and respect, and we need it now. For far too long, we have accepted a pitiable status quo and watched our loved ones suffer. So we are here today because we are you. We live and work in the same communities you do. We are your neighbors, your wives and husbands, your children. We are your nurses, your doctors, your EMTs and paramedics. And if you are healthy, then we are healthy. But don't we all deserve a country where those who take care of us are taken care of properly? Don't we all get to enjoy the great bounty of this country? The old adage of united we stand and divided we fall has never been truer. I began this speech by stating as a medic, I go into your homes and see how you really live. I have seen many who just get by and survive. At the end of my career, I want to see something different. Equal pay and rights along with universal health care is just the start, but it's gotta happen. And it's gotta happen now, and we gotta make it happen. We are the change we have been waiting for. And I'm gonna fight for it. Are you? Yeah, I'm with you. Thank you all for attending. I wish you all peace.
Thank you so much to Anthony and his entire team from EMS in New York City. We really appreciated that you guys came down and joined us. And that beautiful speech that Anthony gave that really just highlights the issues that EMS has. They're underpaid, they're underthanked, and we are so incredibly thankful that Anthony and his team were able to join us today so that we could talk about that.
Absolutely. Thank you again, Anthony. You're a leader and we love you. Thank you for your words. It really resonated with everyone who's been in this system, and we're so grateful for you. Continuing with this theme of healthcare workers who are overlooked sometimes, overworked, underpaid, we have a respiratory therapist, Rick, who is involved in policy. He is a strong advocate. He's a very experienced, a very knowledgeable provider, and we're very lucky to have him. And I'm particularly looking forward to hearing from a respiratory therapist. So, without further ado, here's Rick.
So I'm hoping you guys can hear me.
Adding more chaos.
This is what not to do in a code blue.
Just be more like respiratory. If you need an airway calming, what not to do in a code blue. Don't run around the room adding more chaos. You will get kicked out by the judge knows. Don't bring your chaos here. There's enough chaos in the emergency room. Just be more like respiratory.
So I'm here today. I'm excited to represent. It says you're not sharing. I'm not sharing my screen with you guys. Let me see what's going on. All right, let's see. Hopefully you guys are seeing this. Let me check with our technical support folks. Are you? Can my friends over here see if there we go. I'm getting a heads up. I'm getting a yes. So we get ready to start. Hopefully you saw my video that I started with. If not, if we have time at the end, we'll play it again. It is changing up the energy a little bit. Anthony and all of our paramedics, they deserve so much more than what historically we've been able to give them. And in respiratory, we feel your pain. The point of my discussion today is to try to help empower us and let us go ahead and see what can we do and how can we combine policy and the clinical world. We are respiratory therapists. We are here to serve. And it's time to finally connect the dots. And hopefully a couple of the points we raised today will help us do that. And I look forward to this just being the start of a discussion, and hopefully we will have people chime in and we'll be able to continue this discussion. This is my bio page, starting over here to the top corner. I have a lifelong dedication to both philanthropy, advocacy, as well as volunteerism. I was in the local newspaper in first grade when my teachers went on strike, for advocating to the governor to resolve the strike. And I offered my PAPI money, which was 50 cents a week, to help fund and get the teachers back in the classroom. I'm obviously a respiratory therapist. You see a picture here of me playing Santa for our holiday reunion for all of our ECMO graduates. If you're not familiar, in front of me is an ECMO pump there, which is an artificial heart-lung machine. I'm constantly interested in learning and educating myself, and sometimes I teach. These are not human lungs you see, but these are pig lungs. So in the round picture, it's working with a group of very talented surgeons. And in the square picture, I have 2 PICU fellows, and one of my favorite ventilators, the oscillator. These are my previous and current affiliations. Today's discussion in no way reflects anyone's viewpoint other than my own. I am a trained respiratory therapist. I'm a graduate of a 2-year community college program. I went on and got a bachelor's degree in public administration from FIU, Go Panthers. I have a post-bac certificate in supply chain management, and my graduate work is in health informatics. I did step away from the bedside a little bit. I co-founded a nonprofit with a nurse called People in Crisis United to meet it was born out of palliative care as well as a response to the Haitian earthquake of 2010, to really meet the quality of life needs for the kids. As clinicians, we're often focused on making our blood gas perfect, correcting the electrolytes, but we really need to make sure that kids are able to be kids and people are able to be people when they're in the hospital. So I did a lot of work with that. You'll see in the center there is Mayor Daniela Levine Cava, the first female mayor of Miami-Dade County. I helped run her first campaign to overturn an incumbent and take a seat. And I learned a lot about nonprofit leadership from her, a lot about organizational leadership, as well as policy. I sat on the board of the South Florida chapter of the American Society for Public Administration. I returned to the bedside at Johns Hopkins All Children's, and I helped Kimberly Bacardi run her Good Karma group, which was a philanthropy group of about 700 different philanthropists. And altogether, I've raised over $1 million for charity, mostly in South Florida, but elsewhere as well. Unfortunately, I have no financial disclosures or conflicts of interest to report. I'm not sponsored by Figs, Gucci, or Prada. If anyone would like to give me some conflicts of interest and sponsor me, I am open to conversations. And I thought it would be good to start with a meme here. Why did you become a respiratory therapist? And the meme says, because I had a passion for being able to say, I told you so. That's not quite why I became a respiratory therapist, but I am glad I became a respiratory therapist. Many of us stumbled into the field, and I would be one of those people who stumbled into the field. I really thought respiratory therapists just help people do breathing exercises to cope with their problems, to cope with life. I thought maybe they taught Lamaze classes. So I would practice going, he, ho, he, ho. And come to find out, that's not the case at all. In order for us to really advance our field and to make impactful changes, which is what we all want to do here today, we need to do better at our communication. We need to do better at our advocacy. And that really starts at the bedside. Over the last couple years, I've become an aficionado of memes, if you will. Here you have I Need RT Stat, who came across in their safety reporting portal, their icon for respiratory care looks like two people yelling at each other. And I'm going to be honest, sometimes that does seem to be the case, but when we're yelling at each other, we're not really communicating effectively. And we need to do better to do that. And it all starts at the bedside. We need to really kind of hone these skills at the bedside so that we can build upon them and bring forth meaningful policy change. So as we continue, hopefully you'll be able to see that in this presentation. This lady over here is saying, do not make me use my respiratory therapist voice. So I really fell in love with policy when I was working at Johns Hopkins Hospital in Baltimore. Those of you that work in pediatrics might recognize this book. It's the Harriet Lane Handbook, which is what we consider to be the Bible of books. It tells us what doses we need, how to manage situations. It's really, really heavily relied upon to help deliver really effective and safe care. I circled the editor up top, Dr. Jason Custer. I had the pleasure of working with Dr. Custer when I was at Johns Hopkins. And one day he ordered some sort of treatment for a teenage patient. And in true respiratory fashion, my preceptor at the time, or my former preceptor, kind of gave a big sigh, and she rolled her eyes and kind of made this dramatic gesture and said, okay, I'll go do it. This might sound familiar. Respiratory therapists kind of have a bad rep for being sarcastic and also just being salty at times, I would say. And the interesting thing is, this happened on night shift. And the difference this time was Dr. Custer asked, well, why is your reaction this way? Like, what did I do wrong? You know, I want the kid to get better. And what myself and my senior therapist pointed out was the dosing of this type of treatment was double what they were receiving on the adult side. So this patient was going to graduate over to the adult side in the next year. So why are we doing double dosing now? And then in the following year, they would be getting a more normal dose or a unit dose. And Dr. Custer said, really? I didn't know that. And we said, yeah, you know, we thought you knew that. And he said, no, we didn't know that. And we asked, well, why is it that you guys, you know, order it this way? And he said, well, because the Harriet Lane, that's what was printed last year. So that's what we printed this year when we did the 18th edition. He goes, but if you guys want it changed, we can, you know, make sure that we have the appropriate date dosing so that the following years, they'll have the right dosing in there. So from the 19th edition on, this was the moment that I really fell in love with the influence of policy and change and how words matter. This was a conversation on night shift at like 2 a.m. It was just a conversation amongst very cordial colleagues, but it really resulted in meaningful change that didn't just impact my one patient at the time, but it impacted many patients. This is a reference that is used across the world, and now patients were going to be getting better care across the world because at 2 a.m., this respiratory therapist happened to be a little bit salty. And I just think that that's pretty cool. And that's when I realized that words really do matter, and our communication with each other matters. And that's when I really became more involved in policy. At Johns Hopkins, they had a professional development program, and I was able to actually focus on research and then see how research can be translational into more meaningful policy. And my research was looking at isoflurane in the pediatric ICU with the ECMO pump, and how we could better manage our opioids and hopefully cut down on some of our drug dependencies. Um, I was then able to use what we learned there in writing clinical policy work and department policy work, which then meant that not just my patient was getting better treatment, but all the patients were hopefully getting better treatment. Um, and just sometimes just changing one word in a policy really, really did make a difference in the quality of care that that patient received. Glenn Milano here. He's the president of the Florida Society for Respiratory Care. Recently, I heard him talk, and he brought up, these high rollers, these MBAs, and Ivy League business schools, they teach and they really develop and hone on how to hold and cultivate crucial conversations. You know, when you're negotiating multi-million or multi-billion-dollar deals, a lot of times there's opposing opinions, strong emotions, and the stakes are high. What does that sound like? That sounds like everyday patient advocacy to me. There are oftentimes many opposing opinions. Everybody wants the best thing for the patient, but oftentimes we have different ideas what that is. We become very involved. So these conversations become very emotional, and there's a lot at stake. These are the lives of our patients. These are life and death decisions we're making, as well as the livelihoods of those taking care of these patients. Mr. Milano recently, he proposed that we need to do more to educate and become better at holding crucial conversations. And I believe that that's true. And I think that that goes across the board. Actually, a current colleague of mine sent me this meme this morning, how veteran RTs talk on rounds. And it says, okay, I respect your opinion, but it's wrong. And really, we need to do better, right? So oftentimes what I've learned is the one thing might work really well at one hospital because of all the other systems that come in play, but at another hospital, maybe it doesn't work well. So sometimes what it takes is dedicated clinicians at the bedside who are willing to piece together the puzzles. For instance, I had a nurse practitioner once ask me, Rick, it's weird. Every time that we give platelets here, we have to go up on our heparin. And I said, well, platelets make you clot. Why is that weird, right? That doesn't seem weird to me. And she said, well, where she came from, the blood bank actually prepared the platelets with a little bit of heparin in them so that they didn't have to adjust their heparin drips when they administered platelets to their ECMO patients. Kind of what was being discussed in the last forum, where sometimes it sounds like we're working in very fragmented areas of the hospital, and we don't know how the different departments necessarily operate, or maybe the intricacies. This really highlights that, right? Where she worked, it makes sense that they didn't have to go up on their heparin. But then where I was working, it made sense that we did have to go up on our heparin when our ACTs weren't in range and we had to give platelets or FFP. So although the first comment that she made sounded like bizarre to me, then on further discussion, it clicked and it made more sense. And we were able to learn from each other that there's so many different systems at play that just because something works in one system doesn't mean it's going to work in another system, because there's so many other gears. I did put a side note: if you're not including your respiratory therapist on rounds, you are doing it wrong. Respiratory therapists, the evidence already exists out there. We are able to help improve outcomes. We're able to ensure patient safety. And when we're included in the conversation, we're able to all have a shared mental model. You can see the picture up here, which is from um, AHRQ, that shows you these people here are definitely not on the same page. And it seems appropriate, being that we're in times of a pandemic, right? Surely the guy in the golf polo is not appreciating the same risk factors that the people in full PPE are in hazmat suits are appreciating there. So I just think that we need to do better at being inclusive to achieve that mental model. Brene Brown, one of my favorite leaders of all time, says all change begins with shared language. And sometimes what it means is we need to have different discussions with our different disciplines so that we can better understand what it is that we're saying, because maybe we're saying the same thing, but we're using different language. And there's a little quote from ICU Explained, who's one of my favorite accounts to follow. This is a prescription program on how to build your advocacy muscles. If you don't practice advocating, you're not going to be able to be effective in your advocacy. And it really takes commitment. It takes practice every day. It means every day being informed, every day staying engaged in meaningful conversations, whether that's at the bedside, online, with colleagues, and always making sure to follow up on conversations that require follow up. Dedicating time to stay well read on best practices from both professional journals, scholarly journals, and then not just sitting on that information, but really being able to leverage that information for meaningful change. So that means volunteering for committees, engaging with your elected representatives so that they know they're not the clinical experts, you're the clinical experts. Engaging with policy decision makers and letting them know from the front line what your needs are, what is working and what is not working. And then the hack to that is there's strength in numbers, there's strength in voting. So you want to make sure that you're communicating that you aren't just representing the voice of yourself, but you're representing the voice of many people. And that matters. That matters to politicians, that matters to administration, and that's how we're going to be able to improve systems. We have switched, or there's been a lot of push for moving towards value-based healthcare. But what kind of values are we encouraging? Those hospitals who have engaged in value-based reimbursement, what is working, what's not working. We need to let the legislators know. Oftentimes when politicians are part of the healthcare system as a patient, they get the VIP treatment, but we need to let them know what the reality is. And we need to make sure that the values that are being upheld are things like making sure we're well staffed and making sure we're adopting safe staffing ratios, and the patient safety is a highlight. During the pandemic, I had a friend named Sarah who was called to the trauma room at a level 1 trauma center, and she worked there full time and went PRN. When she went PRN status, they adopted a rule that they were limited on PPE, and when they asked her to intubate and place an art line on a patient, and in that center, that was the role of the respiratory therapist to place the airway, to place the art line. They told her they didn't have PPE for her because they only had PPE for full-time staff. That just doesn't sound like any values that I want to be behind, and we need to fix that. There's no excuse. How do we guarantee adequate staffing? We have to make it tied to reimbursement. It has to come down to money. Hospitals have to be rewarded for when they're able to adequately staff and when they prioritize safe practices. And we have to make sure that our leaders are adopting legislation that penalizes or reduces reimbursement for organizations that are not maintaining adequate staffing. Oftentimes, this has been brought up by many nursing unions. I believe out in California that there's different policy related to safe staffing for nurses. And I'm always hearing, well, it's not possible for respiratory therapists. Well, precedent actually already exists. So in Florida, Chapter 383 of Maternal and Infant Healthcare, sections 15 through 19, back in the 70s, Florida prioritized, and they said that they wanted improved outcomes for maternal and fetal outcomes for high-risk deliveries. So they came up with a system where hospitals who agreed to certain standards would then be reimbursed at a higher rate, as well as receive additional lump funding each year in order to make sure that they're providing the most resources needed for better outcomes. Over here, you can see where in this model, which the statute still stands today, it says that one respiratory therapist is needed for every neonate, for every 4 infants receiving assisted ventilations in a neonatal ICU that is one of these designated centers. Florida has currently 13. They're called RIPIC. And then they also addressed equipment where they said 1 ventilator needs to be available for every 3 RIPIC neonatal ICU beds. This sets precedents. This says it's possible to set staffing ratios. It's possible to set expectations for equipment. However, it needs to be enforced. Hospitals could be out of compliance, and if they're out of compliance, then there needs to be ramification. Otherwise, if a policy has no teeth to it, it's only good as the paper it's written on. So once we're able to have these higher level conversations and really go forth in our advocacy and influence meaningful policy and have that frontline input, then and only then will we be able to really optimize and start practicing at a higher level where RTs are going to come into the field, they're going to feel better about their practice, and they're going to stay. These two memes here are very common ideas. The one talks about if every time albuterol was ordered but not indicated, I wouldn't have to play the lottery anymore, which is very true. It's often seen ordered as water. But you can overdose from albuterol. You can end up with a really severe lactic acidosis. And it's a horrible way to overdose. So we just need to be mindful. It's also tachyphylactic. So there's beliefs that the more you give it, the less efficacious it can be down the road. And we are RTs. We do have a particular set of skills that we've acquired both in training and our education, but then as well as at the bedside and in the hospital, we're able to be the person who can share ideas amongst different attending providers, and say, this isn't working, but Dr. Joe Eddy does this way and it seems to work really for him. Maybe we should try it with this patient. And those conversations happen 24 hours a day. But in order for that to happen, we really need to dedicate both time and staffing so that our RTs can be available to have those conversations. We are here. We're ready to serve. This is one of my favorite memes. The intubator says, "I'm struggling to see cords. Can you give me some pressure?" And the response is, "Yeah, his lips are blue and his pulse ox is dropping." And over here you see Hey Steve MD, who is a former respiratory therapist and now physician, who highlights that when the team leader in a code is distracted, the outcomes of those codes really go down. And the respiratory therapist is able to manage the airway, and that's within their scope of practice. It's just oftentimes not utilized. I just want to say thank you for the memories. Memes have been a great way for us to share and kind of come together and realize that we have a lot more in common in healthcare than we have differences. And this is my contact information. I encourage you all to reach out and share your ideas. And I look forward to working as we bring greater impact to healthcare.
Thank you so much, Rick. We're so glad you were able to join us today. That was really helpful, really informative. I think you and Anthony, to a certain extent, sort of touched on similar things, of that these specialties and these teams of people that are so skilled and are so underappreciated and so under-resourced and so understaffed are just so integral to healthcare. And something that we really want to do here at Impact is make sure we are, including you guys in the conversation, and make sure that we can't do our job without you. And we really, really appreciate you taking the time to demonstrate how very necessary you are to the care of all these patients.
Well, thank you for having me. I appreciate it.
We're so glad you were here.
Thank you.
You also set us up so well for our next speaker, who is also talking about staffing from a nursing perspective, which is obviously something that's really near and dear to our hearts, something that has been hugely in the news with strikes and union organizing and everything. So we're really excited that we have Sarah from She's in Scrubs on Instagram and Twitter to join us today to talk about just so many things. And I'm so excited to hear you. So we're going to pop off. Sarah's going to give us a presentation, and then we'll be back for a Q&A at the end. So can't wait to hear your speech, Sarah.
Thank y'all so much. Appreciate it. Really appreciate the founders for putting this all together. It's amazing. And so excited to read the comments and the chat from hopefully all the healthcare workers that are on. I've already been reading through and seeing so much support, and that's so exciting. I love the momentum. And Rick was an incredible speaker, and I really am so glad we had an RT voice on here. So excited to start this presentation. So I'm not very fancy, so I don't have like a presentation, but I do want to speak on burnout, on my experience, and on the last 2 years and beyond, what nursing has been like. So for context, I have been a nurse for 4 years now, and I have an ADN degree, so associate's degree in nursing, and it has been a rewarding career. I don't regret going into nursing. What makes this career difficult is where we are in terms of the abuse we face at the bedside, the historical context of where nursing is. And it has been impacted by kind of a savior complex, if you will. Like the Florence Nightingale trope, all of these things. So we've faced this need for nurses to be a savior, to be someone that can do all of these things without having to take time for themselves. And we've definitely experienced that throughout this pandemic. The most important part about this rally is the interdisciplinary aspect. We have as many people as we could have come up to be speakers, and I'm so proud of that, across the interdisciplinary board. So excited to hear more voices from different perspectives. But my nursing perspective has been through those 4 years, and sadly, as I've experienced, as I've progressed through my career, I've become more frustrated with nursing than I could have imagined going into it. I truly had kind of like the rose-colored goggles or glasses on when I first started as a nurse, and my mom is a NICU nurse, and her experience with the small babies made me really want to become a nurse and want to help people. And it started off that way. And in 2018, I started on an observation progressive care unit. I absolutely loved what I was doing. And then what I don't tell a lot of people is that my first experience with burnout was in 2018. So this was, 2019. So this was before the pandemic even started. So before 2020. And I had already experienced my first bout of burnout 1 year in to my nursing career. Even though I had those rose-colored glasses, I loved what I was doing. I loved my patients. I loved taking care of people. The impacts of what nursing has always been, the short staffing, the lack of support, the just get through it. You have no other choice, from management, from leadership, from the corporate world of healthcare. All of that was impacting me. And I felt like I was working very long hours. I was trying as best as I could, but I was still not doing enough for these patients in that 12-hour period. And that was building moral injury for me. The nursing culture where we shame and blame instead of, educate and support, that was taking a toll on me as well. And the leadership that I was exposed to me was toxic. And the unit that I was on, we had a mass exodus of nurses before 2020 even began. So those are all impacts that I'm sure so many of us have experienced even prior to this pandemic. It's just the pandemic has exposed these layers and layers of issues in nursing and in healthcare, and compounded on them. It's been difficult. And 2020, I did not foresee what would come. I don't think anyone did. And my gut, when I saw what was happening in Italy, made me realize, wow, this could get bad here in the United States. What I didn't realize was how bad it would be on top of the lack of preparedness by our healthcare systems and the lack of respect for our well-being and our health. So the first layer of moral injury that came about was the lack of PPE for healthcare workers, nurses, nurses, doctors, ancillary staff, RTs, all were told, we don't have the PPE to protect you from a virus that we don't know what it's going to do. And then looking back now to how deadly this pandemic has been, knowing that we were exposed to that they weren't prepared for a potential pandemic. And these hospital systems weren't prepared for a potential pandemic. They didn't have stockpiles. They weren't prepared to protect us in the event that something natural could occur and cause this much devastation. It's still something that stings. And every time that I reuse a mask or I see an N95 or I see a paper bag, that's triggering. So that's one layer. And then we get to the way these healthcare administrators have handled the first impacts of the pandemic, or when COVID first began. So we started off with, don't wear masks because you don't want to scare patients and you don't want to scare patient families, even though we already knew that COVID was inside of our hospitals before we were testing for it, because we had people coding nonstop. We had this respiratory illness that we couldn't test for. Everything was negative on RVP. And we're like, what is this? But don't wear an N95. Oh, it's not airborne. Oh, don't wear a mask because you're going to scare the patients. Then 2-3 weeks later, all staff members must wear masks. Oh, sorry, we don't have enough for you. So you have to reuse this, something that was always disposable with the initial use. And we're still not back to that, which is frustrating because I'm still wearing an N95 for most of a shift, which without throwing it away, because of rationing. So there goes that. Then our hospital administrators decide to furlough staff in preparation for the impacts of stopping elective surgeries because of this pandemic, to hopefully save money on, the benefits that they pay us, our insurance. And then the surges hit, and we have less staff than we had before, less support than we had before. And they go back and think, wow, maybe we need staff. So let's pay for travel contracts. And they do this over and over again, but they don't think about why they are hemorrhaging staff, why nurses are leaving to go to travel, why RTs are leaving to go to travel, why folks in every single discipline are leaving to go travel. Autonomy, respect, adequate compensation, that's all we're asking for, right? So after 2020, I decided to go part-time. I couldn't handle the impacts on my physical health, on my mental health. I was tired, I was exhausted, I was frustrated, and I still am, but being part-time helped me to be able to actually stay at the bedside. I have told myself with each surge that I don't know how I can get through it, how I'm going to make it to the end. And making it to the end each time has been incredible, but I understand and feel for those who have left the bedside entirely, who have stopped, who have just kind of almost not given up, but have removed themselves from a toxic, abusive situation. And it's not for not trying to get support. It's not for not trying to advocate for nurses, for healthcare workers, for our colleagues and our peers, because I spoke directly with a COO of our hospital and our CNO before the Delta variant hit in Florida in 2021. And I spoke to them and I told them that they were going to continue to hemorrhage nurses if they didn't give some sort of monetary support, some sort of staffing reprieve to truly dedicate as much of the resources towards getting safe staffing implemented, especially with the COVID surges, and especially on our COVID units. And the nurses, the CNAs especially, have dealt with the brunt of this because we are at that point of care contact with our patients. We are those 12 hours physically there for these patients. And with COVID, our exposure is through the roof. So I tried to explain that to our COO, our CNO. And I thought I would be, somehow supported. It was a little bit of a naivete on my part. But what I did get back after I expressed concern and just a dire need for at least monetary compensation, hazard pay for these nurses, I was told if we were to give $1 of a raise for every single member of our health system, not just the nurses, we would be down $3 million. That's what I was met with. What I read from that sentence was that these healthcare workers, the people that have stayed with them, their core staff who haven't left, weren't worth $1 more. And I'll never forget that, and I never will stop talking about that because it's something that almost changed my life hearing that. You think that people go into healthcare administration, into healthcare to help people, to help patients. But truly there are other motives, and the pandemic has shown us the impacts of those motives and has shown us that we are truly disposable in the minds of a healthcare system run on monetary value, run on corporate values. Healthcare should not be a business, but that's what it is. And I was really frustrated to hear that. Flash forward to the Delta variant. We hemorrhaged far more nurses than I can count after my conversation with the COO of my healthcare system. And we get the Delta variant in Florida. We went through something that I will never forget, something that is going to impact my mental health for the rest of my life, something that left me with newly diagnosed PTSD, something that left me on an antidepressant, and something that made me feel so much pain, so much sorrow for my community, for my peers, for just society as a whole, because we saw the impacts of unmitigated COVID in our community, unmitigated Delta variant in our community, and the impacts of an already strained healthcare system, a healthcare system that isn't a massive, 700, 1,200 bed hospitals. These are small community hospitals with 400 to 500 beds, already at the brink. ERs with over 100 patients holding. Terrifying. Something unprecedented right 2 years ago, but something we should have been prepared for, something we begged our corporate staff to listen to us about, and we received, "You don't deserve another dollar." So, the Delta variant, the impacts on our mental health, the impacts on our staffing. We lost more nurses each week because they were so burned out and exhausted by the excess death, by the excess responsibility, by the increase in ratios, 1 to 6 nurses on a COVID PCU, ICU nurses taking 1 to 4, 1 to 5 patients. These are unsafe standards, unsafe conditions that they could have been prepared for, but they decided to watch and wait. They hoped that there wouldn't be another surge and decided to hold on to as much profits as they could instead of actually addressing the issues at the core. And this is where we are. So not only did we have patients who were sicker than we could ever imagine, they also were receiving inadequate care, because that is the reality when staffing is short. They were receiving inadequate care. I spoke to these administrators as well about how unsafe it is to, and this is, healthcare professionals can relate to this and can understand most of this, how unsafe it is to have PCU patients, nurses and CNAs and RTs. RTs will have multiple floors, multiple COVID floors with multiple, like 36, we have 72 beds, 36 beds for COVID. And then we have multiple COVID floors, including an ICU, 1 RT. So I explained to them that 2 years ago, the standard would never have allowed for vapotherm, for heated high flow nasal cannula, for Airvo, for BiPAP, maxed out 100% on a PCU floor, 1 to 5 ratio. Having 18 of 36 or more patients on oxygen requirements greater than heated high flow nasal cannula, or maxed out on heated high flow nasal cannula or BiPAP. Having half the floor like that, and then having like 5 to 6 nurses on the floor, including the charge, on a 36 bed unit. Acuity being so high that you'd hear 4 to 5 code blues go off in a night. I explained this to them, and this was before the Delta variant. This was before the Delta variant. And I explained to them, this is not safe for these patients. These patients are suffering because they are not getting the attention that they would have required 2 years ago, when our standards meant vapotherm, BiPAP, go straight to the ICU. Why? Because they require 1 to 1, 1 to 2, 1 to 3 monitoring. so that they don't, so that we can watch them for air hunger, so that we can watch their respiratory rate closely, so that we don't, so we're not surprised when they crash, when they code. And it was so heartbreaking to look back after this Delta wave and think on the patients that we had on those heated high flow nasal cannula, on PCU, on BiPAP. Most of those patients that declined and went to our PCU, most of them we sent to the ICU or we coded them on our floor. Most of the ones that we sent to the ICU did not make it. So when people ask me after the Delta variant, are things better at the hospital? Numbers did improve, but it's because we lost a huge part of our community. So that's another layer of grief that we have to go through, is losing our community and being the ones to be there in those final moments to try to resuscitate countless people. I had only experienced one code blue before 2020. One. I have 10 fingers, right? That's not enough to count how many I've gone through in the last 2 years. And in a month during the Delta variant, we'd experienced at least 2 to 3 codes a week just on my unit alone. It got to the point where our hospital system, to hopefully promote vaccination efforts, started documenting and posting on Facebook how many deaths we had each week. Each day. Our worst day in my healthcare system was 18 deaths in one day across 4 hospitals. That is unheard of. That is unfathomable. You used to only hear maybe one code in one shift, and that was rare. Now, during that Delta variant, we had 5 to 6 codes a day per shift. I don't understand how that is sustainable, how that's sustainable for our mental well-being, how that's sustainable for the model of healthcare. And the fact that so much of this was preventable, the fact that so much of this could have been prevented, the fact that our corporate staff, what should have been our support, decided to leave us shorthanded, expected us to continue through what was hell for no extra pay, for no hazard pay, and just to continue to keep going. And then we're frustrated when we left. We're maybe avoiding giving people letters of recommendation when they wanted to leave, to that point. And it's just so incredibly frustrating to have gone through all of that and for them to still not see the bigger picture. On top of all of this, a few months later, once the Delta variant started, it was starting to wane, but we were still in the thick of it. They decided to pull each nurse aside and each member of our staff aside and tell them that they did a market analysis. They did a market analysis, right, of pay across different areas in Florida. And they told us, because of that market analysis, they determined that we needed a raise across the board. Every single member of the staff needed a raise across the board. Market analysis, sudden discovery that they were paying the lowest across all of Florida. So interesting. So we received, instead of that $1 raise that I told I wasn't worth, I received like about $3 to $4 raise, right? That's not enough. Nothing is enough to take back what we went through, especially not money, but it helps, right? It helps make you feel at least kind of valued for the excess death, for the increased responsibility without support. So it was just so incredibly funny to me to see how I wasn't worth an extra dollar 6 months ago, right? And now here we are, and they're trying to push more money on us. And they're also, they've also initiated a bonus contract to pick up shifts, but they still won't incentivize just showing up for our regular shifts, because honestly, each day it just becomes more and more difficult for me to even come into when I'm on the schedule. So this has been an incredibly difficult experience for me as a nurse, going into nursing with rose-colored glasses, hoping to be able to help people to the best of my ability, and then realizing that I'm not set up for that I'm not set up for success, that I am expected to pull as much out of myself, physically, emotionally, mentally, to sacrifice myself, to be a martyr for these patients, because I'm not given the support or the staff or the resources to truly give these patients the care that they deserve. So knowing that they became aware through me, through other nurses, of the impacts on these patients of the pandemic and the just deplorable standards of care, the standards where we're at are just horrible. I pray for all of my family to never have to be near a hospital within the next 5 years. Although they were made aware of the risks on these patients and the impacts on these patients on their care, they still decided to put profits over people. And that kind of took away the rose-colored glasses for me in 2019 and made me realize that, it was never about patients. And that is what Impact in Healthcare is all about. That is what this movement is about. That is what the momentum across the country, not only in healthcare, labor across the nation, people have realized that they will no longer stand for abuse and exploitation. And healthcare is one of the biggest industries, and nursing is a massive, massive industry. And if we use the power and numbers that we have in solidarity to unionize across states, and at some point, I'm hoping for a national union that is truly impactful, that impacts federal efforts. So we need social policy at a federal level to save our nurses, save our healthcare workers, save our patients. And it's not sustainable where we're at. And we finally have a light shined on all of us because of COVID, because of the impacts of this pandemic. And we need to hone in on that. We need to use that so that we can get true change at a federal level, because safe staffing is imperative to the safety of our patients and the safety of our staff and the safety of and the health and well-being of every single patient across this country. And it's not only in inpatient settings, but across public health, across outpatient settings. They need support. Our elderly need support, and mental health facilities need support. So all of these things, it's a trickle-down effect. If we're able to, as a collective, use this momentum to bring awareness to the issues that we're facing, normalize actually speaking on the issues in healthcare, and not falling privy to what these institutions want to silence us and quiet us regarding what is the reality in our hospital systems, in our outpatient settings. We need to use what we see and what we've experienced, document everything that we've experienced that has been unsafe, and these examples, and whistleblow. That is my role, I feel, on social media through this pandemic, has been to share the stories of nurses across the country and other healthcare workers across the country who have struggled, who have seen the struggle, who have experienced the most incredibly difficult times throughout this pandemic. And their concerns, their experiences are valid and must be heard. This is how we push forward and how we really impact healthcare as a whole. And it's so important to not forget about the other individuals who work in healthcare. So nurses, doctors, we truly are always in the spotlight, and it's so important that we kind of push for other disciplines to be heard, right? Ancillary staff in my healthcare system were not fit tested for N95s, even though they interacted with airborne patients, with COVID patients. And lab techs at my hospital, actually, the entire lab force got sick with COVID in the beginning of the pandemic because they weren't allowed to wear N95s. So how do we set a new standard that allows for all members of healthcare to be seen as valuable parts of the workforce, and not just nurses and doctors being given proper PPE, but ancillary staff being on the first list of people to be given resources to protect themselves from a unknown virus that, as we have seen, impacted people in such a severe manner. And we're going to learn more about the numbers of healthcare workers who sadly died due to COVID. I'm sure in the next 10 years, the research on the last 2 years will show some devastating data that I don't think I'm prepared for emotionally, right? And so yeah, that's kind of the overview of the impact of COVID on myself and the response by my system. And I'm sure there were even more inadequate responses across the country in different hospital systems. And I know that because I receive countless DMs from nurses, healthcare workers across the country on their experiences. And sadly, they do mirror mine and even worse experiences as well, which is terrifying to think, because every single time something goes bad, I think, can this get any worse? And sadly, yes, it can.
Sarah, I really appreciate your words. I mean, I couldn't relate more to the things that you said, and also just hearing that after 1 year of being a nurse, you felt burnout. That's a huge problem, and that's something that I see in the newer staff. When we're training them, they just look like they're already out of it before they begin, and no one should feel that way. And you're there to make a difference. You're there to help patients. And why are you being helped in such a poor way that you feel this way and undersupported? And so my heart just goes out to you. I really appreciate your perspective. You're amazing, and all of your hard work, being such a great advocate while you're working in this intense environment. Really. We had some questions submitted, but I don't want to run too long and keep you, because I know you have to work today. So I just wanted to ask you, do you think that burnout can be fixed? And if so, what would it take? What would it take to support all of us as nurses to fix burnout?
Yeah, so in terms of nursing, we kind of have to fix part of our own culture, if that makes sense. Culture of blame, culture of shame, culture of bullying. We do have that issue. So if we start with ourselves, I think that's important, because we're supporting our new nurses through efforts that don't shame them for not knowing something, that is more about teaching moments and asking questions and just being a resource that isn't judgmental or harsh or a bully. And sadly, we do have that because we kind of eat our young, right? That's one of the sayings. And there's a culture in that. There's also a culture in nursing that promotes hierarchies. And I think if we are able to kind of devote resources towards promoting LPN programs, ADN programs, supporting our nurses who work the bedside and don't want to become nurse practitioners and don't want to go into master's education, which that is an incredible feat. And I love nursing becoming field that is kind of going into higher degrees, we need to let the bedside nurses know, LPNs, RNs, that they are valued, that their work is needed, and that they don't have to continue, and they don't need to get a BSN, because truly you don't need to get a BSN, especially working at the bedside or working in outpatient settings.
I totally agree.
Yeah.
I was an LPN for many years, and I
Yes.
had my ADN. And again, I'm getting a master's currently, and so
Yeah.
nothing against education, but that was
Yeah.
my choice. You shouldn't
Yeah.
have to be forced,
Yeah.
because then we would retain people who like to be at the bedside. And these are
Yeah.
good nurses. These are the nurses that trained me, and they run circles around everybody, the LPNs who trained me,
Yeah.
I think it's classist, it's elitist, and
Yes.
it should not exist. I could not agree with you more.
And our professional organizations also compound on that. So, like
Yes.
Sigma Theta Tau, don't allow anyone ADN nurses. They only allow BSN nurses. That's an issue. So it makes you
Yes.
feel like you need to continue. And that support and that elitism, like you said, must be dismantled. So we have to kind of work on ourselves first, and then we continue to push for better support, I think.
I have chills. We love you. Thank you so much. This was wonderful. Thank you so
Y'all are
much. We really
wonderful.
appreciate it.
Yeah.
I appreciate y'all. Thank you for organizing this. It's incredible.
Thank
And
you
I'm
so much
excited
for being so
for
vulnerable
the next
with us.
one.
Yeah,
Hopefully
yeah.
in person someday, right?
Yes.
We're very hopeful that COVID will be a little bit better next year, and we would
Yeah.
really like to do a big in person next year when it's safe for everybody. But again, thank you from the bottom of our hearts. Thank you, Sarah. Thank you.
I appreciate y'all.
All right, next up, we have a note from one of our organizations that we're featuring today, Charm City Trikers. Charm City Trikers is very special to me as a person. Their president is actually my son's physical therapist, and their entire board and staff has taken care of my kids at some point between the hospital and now. So thank you guys. We're so excited to watch the video.
Hi, sweet girl. Helmet time. You ready to put your helmet on? Yeah. Yeah? I'm gonna work. Are you gonna ride a bike? Mama said I can ride it out to the car. You're gonna ride it out to the car? Okay, that's a good idea. This way mommy doesn't have to carry it. I'm gonna ride it home, right? You're gonna ride it home?
I don't know. Are you gonna ride it? Are you gonna ride in the snow? Oh, it's snowing outside now.
It is. Can I ride it at home?
At home, yeah.
Maybe a day it doesn't snow though, Dello. Okay?
You can ride it to the car though.
Dello, are you excited? Go, Dello. Let's go check this bike out. Ooh. Hold on, Miss Dello.
I'm gonna ride on my new bike. I've been waiting and waiting.
It was worth it, right?
I'm ready.
You got the perfect sweater on.
So thank you to Trump City Trikers for sending us that adorable video of some of the good work they're doing actually in Violet's hometown nearby. Our next speaker is our good friend Harrison, who is a PA and a PA instructor actually right down the road at one of our local universities. We are very excited to hear him talk about some toxic workplace cultures, the way those contribute to burnout of healthcare workers, poor patient care, and the ways we can fix them. Harrison?
Hey everybody, thanks so much for having me. I am going to go ahead and share my screen here so that we can watch some of these slides together and then we'll get started. All right, so hopefully you're seeing that PowerPoint. Somebody can shout at me if that's not the case. I can't see the chat, unfortunately. So like our host said here, my name is Harrison Reed. I am a critical care PA. I've been practicing medicine for about 9 years now. And for the last 3 years, I've been an assistant professor at the George Washington University PA program here in Washington, D.C. I am really excited to talk to you today about a topic that's really important to me, interpersonal toxicity in the healthcare setting. Now, I don't have a ton of time, and normally I spend about an hour at least talking about this subject, so I'm going to jump right in. But first, I want to talk to you about how we got here, right? How we got here with me talking to you all. Well, we got to go back a little ways here. This little pale-faced boy in the picture is me at about 11 years old with my mom and my first patient that got me set on a path to medicine. This is our pot-bellied pig, Chloe, and unfortunately, as a little piglet, Chloe was attacked by a bunch of dogs, and while she survived her injuries, she was prone to developing painful abscesses for the rest of her life. So as a middle schooler, I got pretty used to diagnosing and treating with an IND abscesses on a pot-bellied pig. And well, that's a little bit of a gross way to get into medicine. It really ignited a love of caring for other living things and helping creatures feel better. And while I eventually got away from the idea of veterinary medicine and into human medicine, this really was a nonstop path towards a dream career for me. Now let's fast forward over a decade. I was a little bit different in this picture. This represents something that happened to me after I graduated PA school. Left PA school, still super passionate about medicine, but very quickly realized that I was kind of split in half. There was this part of me that loved medicine, and then a growing part of me that seemed to really hate working in healthcare. It wasn't that I just got into a really high acuity ICU and was dealing with disease and death every day. I kind of felt like I was prepared for that. But the things that kept me up at night, while I thought about my patients, sure, the things that kept me up at night was thinking about the terrible experiences I was having with my colleagues. Those people that were supposed to be just as passionate about medicine and helping people, well, they were sometimes my biggest problem. Sometimes their abusive behavior was the biggest thing between me and giving my patients good care. Now, I kept this to myself for a long time, but over time you have conversations, and I realized I wasn't the only one feeling this way. So like any good nerd, I kind of dove into it as a research project and realized it was a small but growing body of research looking at this exact phenomenon, this phenomenon of toxic behavior in the healthcare setting. So I've learned a lot about this over the last several years, and I've written and published about it. I've spoken at national conferences and recently even started to build my own original research around this question. So I want to share with you what I've learned about this topic, but more importantly, what we can all do together to try to fix it. So toxic behavior or incivility or bullying or whatever you want to call it is tough to define, and I'm actually okay with that. I don't really like a stone cold locked in definition of toxic behavior. In fact, I think that that can sometimes be a bad thing. If you make something very well defined, it's easy for people to find loopholes, to use semantics to get around it. So I don't really care to make a formal definition of toxic behavior, but I think you need to understand that it represents a broad array of different things. It can be really overt things like yelling and screaming and throwing objects and sexual abuse and harassment, all of those terrible things we think about as being very overt ways to abuse other human beings. But it can also be really passive and subtle. There can be passive aggressive behavior. There can be sabotaging your teammates. There can be going behind their backs or over their heads to use the leverage of our positions to hurt each other. And there can be things like coded language, racism, sexism, microaggressions, and even language and actions that demean our patients, those people that we care a lot about in our patient care. So when we talk about a really broad definition of toxic behavior like this, we also need to know the prevalence of it. So I've put up on the screen here a few numbers that should, at least somewhat describe the prevalence of toxic behavior. This number 98% comes up a lot. I've kind of made a little aggregation of a lot of different studies here, but 98% pops up more often than you'd think. This is a number representing how frequently people experience toxic behavior on an annual basis. 98% of healthcare workers say that they experience some kind of toxic behavior on at least an annual basis. So just about everybody, at least every year. That probably doesn't surprise you. But as the numbers get a little bit smaller, they also get a little bit scarier. 30% of healthcare workers, and these studies mostly represent physicians and nurses, just so you know, it's an issue that we have to address to include more people in these studies, but 30% of healthcare workers experience toxic behavior on a weekly basis. And 10% of healthcare workers say they experience toxic behavior on a daily basis. 1 in 10 people dealing with toxic or abusive behavior every single day. Now, again, this can be a broad definition. So what about those really egregious types of toxic behavior like sexual harassment? I was really happy to see that Medscape finally did a survey looking specifically at PAs, NPs, and nurses in 2018. Previously, these groups like PAs and nurse practitioners had often been excluded from a lot of research. Well, the results weren't as encouraging as the fact that they'd asked the question. The people that experienced sexual harassment or abuse or misconduct, 11% of respondents in these groups, and another 14% said they witnessed this happening to other people. They just weren't the target. You should know that frequently studies find that people who witness toxic behavior suffer a lot of the same effects as those who are targeted by it. So these numbers to me were incredibly alarming. And I wondered, do they just represent outliers? Are we just focusing on a handful of people that are really monstrous and have heinous actions towards those around them? Or is this indicative of a more systemic problem? Unfortunately, I think the answer is both. Now, there are some, albeit anecdotal, but high-profile incidences that have come to light over the last few years. These are incidents of sexual harassment, of abuse, and unfortunately, in some of the most egregious cases, actual rape. These aren't things that I think are common in healthcare, but in these high-profile cases, the institutions in which these incidents took place actively worked to either cover up or hide the fact that they'd happened. In some cases, those perpetrators went on to go work at other institutions before any of this came to light. So while the actions themselves might be a small group of heinous perpetrators, the system itself seems to create an environment that empowers those people and in some ways even protects them from the consequences of their actions. Also, allegedly, this is all alleged. Although these are reported by very well-vetted sources, I just don't want to get sued. So I'm going to say that in many cases, these are claims and allegations. In some cases, there's lawsuits in progress. Okay, so why is healthcare so prone to this idea of perpetrators getting away with abusive behavior and an overall environment that seems to welcome more than punish this kind of behavior? There's a lot of reasons, but one big mechanic of toxic behavior that I think you should know about is called a power gradient. Now, power gradients can mean a lot of different things, but in general, it's any imbalance between two people or two groups of people. So power gradients happen in workplaces. Sometimes we know and acknowledge that, and we're fine with it. A boss and an employee have a power gradient between them. We kind of expect that. Healthcare bakes a lot of power gradients into its own infrastructure. You might think about traditional hierarchical gradients between colleagues like physicians and nurses. Even if that nurse isn't technically employed by a physician often has a lot of absolute objective, but also subjective power in the workplace. So there tends to be a power imbalance between people based on their jobs, even if they're not supervising one another or employing each other. But power gradients don't have to be this really well-defined thing. In fact, many power gradients overlap and crisscross. Some of them are just due to differences in social capital. So for instance, you can have a power gradient between a physician and a nurse that goes the other way. If you look at the United Kingdom, the UK, Britain, if you look at physicians over there, interns, trainees as physicians, their first year of training, they'll tell you that the person most likely to bully them is their attending physician. Okay, makes sense. Power gradient, right? But the second most common person to bully an intern, a physician in the UK is nurses. Now think about that. Nurses have a lot of other things that can put them in a higher power gradient than an intern. They might be more experienced. They might be more confident in their jobs. They might be more of them. They also might just have more social capital. They're popular people around the hospital. So power gradients don't always move in the same direction, and some are more powerful than others. You should know, though, that anybody who's outside the majority is likely at the bottom of a power gradient. So if you're different than those around you, you're very much susceptible to being at the bottom of a power gradient. So for instance, in 2019, JAMA looked at risk factors for resident bullying. So what are the factors that make residents more prone to bullying? They found that if you speak something other than English as your first language, if you're from a foreign medical school or a foreign residency, you're much more likely to be bullied in residency. Anything that makes you an outsider, puts you at the bottom of a power gradient, makes you a more susceptible target, and maybe has other things going on around you that make you more marginalized in general, so that you have overlapping gradients that are essentially setting you up for toxic behavior. Okay, so there's a lot of other mechanics I could talk your ears off about toxic behavior, but given that we're short on time, I think we need to move to talking about the outcomes of toxic behavior. So, for instance, there are 3 groups of people that are most affected by the fallout of toxic behavior in the healthcare setting. Those are us as clinicians, our patients that we care for, and also the institutions at which we work. So I just want to briefly mention these 3 groups and how each of them is affected by toxic behavior. So let's start with us. You're supposed to put your own oxygen mask on first, all that kind of stuff. Well, what happens to us when we are either in an environment where toxic behavior is going in all directions, or when we're actually the targets of it? Well, we know from a variety of studies that increased anxiety and depression occurs in those that are the victims of interpersonal behavior that's toxic. So we know that there's higher rates of anxiety and depression amongst those that are in toxic environments. We also see that similarly, there's increased rates of emotional distress and burnout. That makes a lot of sense. It's hard to be really invested in your workplace, in your work, to feel emotionally satisfied if you're also being emotionally attacked. It just stands to reason. But there's even more alarming and objective ways of seeing how clinicians suffer from toxic behavior. One study found that those that are suffering from toxic behavior have an increased use of sedatives and sleep aids. So that might mean over-the-counter sleeping pills, but think about it, that could also mean things like alcohol. And we already know that clinicians are more prone to things like anxiety and depression than the general population. We know that we're more prone to substance use disorder than the general population. So any other factor that can further increase and exacerbate that should be very alarming to us. If we care about the well-being of clinicians, then we have to be very cognizant of anything that might be driving up rates of these things that we know to be harmful. Okay, so that's us. What about the organizations we work for? Those are kind of important. They're pretty big stakeholders in this whole healthcare conversation we're having here today. Well, there's 2 big ways organizations are affected by toxic behavior and incivility and bullying and all that stuff. First and foremost, organizations will suffer from a loss of productivity. This comes from a variety of different factors, but think about it logically. If you really hate your workplace because someone there is constantly attacking you, if you're in that once a week or, God forbid, once a day group of people, then you probably don't want to show up to work. So maybe you'll take more sick days than you normally would have. And maybe when you show up to work, you take more breaks, you avoid those areas of the hospital where you know your abusive colleagues are. Maybe you avoid interacting with people. So you generally end up working less. Less productivity means less money for an organization. But there's a more extreme end of that spectrum. Let's say that you're so upset with this toxic behavior you're exposed to that you finally get to the end of your rope and you decide to quit. Well, employee turnover is extremely costly to organizations. For those of us in healthcare, we often have advanced degrees or some level of advanced training. We often have a lot of experience. We bring a lot to the table. And fortunately, some people in this conversation are very well compensated. So turning over employees in this kind of setting is very costly for employers. It can cost anywhere from 1.5 to 2.5 times the salary of an employee to replace them, go out and recruit, orient that new person, onboard them, move them across the country, probably pay some locums to fill in for them in the meantime, or a travel nurse that's going to come in and cost a lot more money. So all of these things are burning money left and right. In fact, there was this really cool study that some radiologists at a small hospital did where they wanted to calculate all of the costs that was going into toxic behavior in their hospital. And their calculations, once they corrected for everything else going on, said that $1 million a year was spent at this small hospital just on toxic behavior. Now, if I know anything about organizations, one thing they seem to care about is their money. So this should be a really important thing for stakeholders in the topics of toxic behavior. Okay, but speaking of important stakeholders, how about the patients, right? That's why a lot of us got into this business. And, going back to the times of Chloe the pig being my patient, I've always cared a lot about my patients. So if you want to get my attention, let's talk about how it affects my patients. Well, you might know this little thing called JCAHO or the Joint Commission. You may have heard of them. They're the ones that care a lot about whether or not you're drinking a water bottle at your nursing station, but they also care about something called sentinel events, when that water bottle would end up inside somebody in the operating room. Well, JCAHO says that sentinel events are mostly caused by poor communication, and JCAHO draws a straight line between toxic behavior and poor communication in the workplace as a red flag for things that might cause sentinel events. So while I don't always love JCAHO as an ally, I think in this case, they're dead on. That poor communication stemming from toxic behavior is a major risk to patients. But that's not all. Studies that have looked at medication errors in the setting of toxic behavior have found that anybody who's subjected to toxic behavior is more prone to medication errors. But maybe more importantly, they're also more prone to not reporting those errors. Think about it. If you know that you work in a really toxic place and maybe your manager is vindictive or maybe your environment is really punitive, you're really biased against ratting on yourself or maybe your coworkers that you like when there's an error. Reporting errors is the right thing to do, but it's only natural for human beings to shy away from something that might be harmful to them. So errors in toxic environments are less likely to be reported, which means systemic issues, which are often the cause of errors, are much less likely to be fixed. So we have a propagation of error after error, a snowballing of the damage caused by just one error that isn't fixed. There's a great study that looked at all hospitals in Pennsylvania and chose to see if there was a correlation between hospital mortality and workplace environment. Even when this study corrected for things like the training of nurses, the education level, the nurse to patient ratios, you correct for all that, they still found a statistically significant correlation between mortality and poor working environment. Basically, if you had bad relationships between your coworkers, your bosses, you had a higher mortality at your hospital. Pretty crazy. Now that is correlation, so we can't draw causation, but it's certainly something that raises an alarm. Speaking of causation, one ways you can get after causation is by looking at randomized controlled trials. Now, we can't really subject patients to toxic behavior as an experimental factor because that's kind of unethical if we think that it's really bad for them. But there's two awesome studies that looked at simulated resuscitation efforts. One of them looked at simulated neonatal resuscitation. The other one looked at simulated operating room resuscitation. Their treatment groups was just to put someone on the team who just sat back and made like passive aggressive, jerky comments to the team during the code, during the resuscitation. Every single team, or I should say those teams that were subjected to that passive aggressive behavior scored below the satisfaction limit on every single area of patient care, whether it was diagnosis, procedures, catching errors, communicating errors, everything that you can see was worse in that treatment group of the passive aggressive behavior, to the point where the care in those groups on average didn't even meet the standard of care for a resuscitation. That's pretty scary. And while you can't really lose a life in a simulation, that has to suggest that toxic behavior is killing people, especially in these high stakes situations like intensive care, emergency medicine, resuscitation, that sort of thing. Okay, so I've been throwing tons of information at you. What does all of this mean? Well, these things don't happen in isolated silos. There is a toxic culture death spiral that often happens. And when you look at a place and think, how did it get so bad? The answer is usually somewhere in this cycle. Look, we already work in super high stress jobs, in super high stress environments. So that small minority of people who are prone to toxic behavior and to taking it out on those around them is already going to be doing that. However, that's going to cause higher rates of depression and burnout in the rest of us, which means that everyone has short tempers and they're either prone to then becoming the perpetrators of toxic behavior themselves, or they're just going to be less likely to put up a fight to protect themselves. I mean, think about it. If you're depressed, you're much less likely to do something proactive, like go after a bully or somebody abusing you and protect yourself, or report them, or follow up any of the above. So of course that leads to more toxic behavior, and then employees will leave and we'll have additional stress from things like short staffing and inexperienced colleagues coming in and trying to do the job that our experienced colleagues used to do. Makes everything harder, increases the stress, and it leads to things like bad patient outcomes, which are already more likely in a toxic environment, which then, I don't know about you, I hate bad patient outcomes. Makes me feel really terrible if my patients aren't getting great care or if my patients are having bad outcomes. So that makes everybody even more depressed, even more anxious, even more at each other's throats, and round we go. That's how a just okay environment becomes a terrible environment so quickly. Okay, so I've probably depressed the heck out of you in a very short period of time here. There's got to be a solution to this, right? The answer is yes, but it's not simple or easy. If I could vaccinate you to abusive behavior, I would do it tomorrow. Unfortunately, we don't have a one-shot answer like that. So most simply, we have to go from a top-down and bottom-up approach to creating a healthy workplace for our workers. That means that we need institutional leadership and policies that protect those that are subjected to toxic behavior, but also just encourage a positive environment in the first place. And we also need buy-in from the frontline workers who are out there interfacing with each other and interfacing with patients on a regular basis. Okay, what does that look like in a practical or example? Well, I'll show you a few different ways that can happen. First and foremost, hiring is a great opportunity to address your culture. So it's much easier to pick a good candidate than it is to get rid of a bad candidate once you've hired them. So you do have an inflection point in the hiring process to sort of fix things. So what we need to do is move from this idea of selecting for the most productive people. Think about what people care about in your job interviews. They care about your experience, your training, your accomplishments, signs that you're a productive person, that you get things done. But what they should be doing is looking at your personality, whether you're a person of character, whether you're good to those around you, whether you meet the stated mission of your workplace, and whether your values align with the values of your team. So you can always become more productive, but it's very hard to go from being a bad person to a good person, or somebody who has weak character to someone who has strong character. So just because someone's a little more productive, if they're a really talented jerk, I hope I've already shown you how they can very quickly lower the productivity around them and completely wipe out any advantage they bring by being a superstar with a bad attitude. So we can hire for personality instead of productivity, but once we do that, we need to actually welcome them from that frontline buy-in. We need to have a welcoming environment for new graduates. We need to stop hazing people when they first get here. We need to make sure that we're setting an example from day one so that they can continue that example in a positive way. We can think about similar things when we look at the attitude towards bad behavior. So one of the best things you can do for negative behavior in the workplace is to call it out in real time. It prevents something called normalized deviancy. Normalized deviancy is when something bad happens so often that it becomes normal and we stop paying attention to it. So if someone's a jerk and gets away with it, it just becomes the way it is. And then people will shrug and say it's always been that way. If you call things out in real time, it prevents things from being normalized. It sends a message not just to the person perpetrating the bad behavior, but to everyone else that, hey, that's not okay. Unfortunately, calling it out is extremely risky. If you're one of those people that's at the bottom of a power gradient, if you're at the bottom of a hierarchy, it's really tough to call out somebody above you on that power gradient and not expect some kind of retaliation. So from the top down, institutions have to have policies that are very transparent about the reporting of bad behavior and how it's handled, meaning that the punishment has to fit the crime. There has to be actual consequences, regardless of who's perpetrating it, regardless of how powerful that person is. So that on the front line, when you are calling it out, you know that someone's protecting you from the hammer coming back down on top of you. And that same thing is just the attitude towards bullies in general. Bullies are just people who are serially propagating toxic behavior. We all have a bad day. We've all done something where we've been like, oh crap, I gotta go apologize for that thing I just said. The fact that you feel bad and want to go apologize means you're probably not a bully, but there's people who do that over and over and over again without remorse. So we need to be able to remove serial offenders, but one of the ways that we can help on the front lines with that is to avoid being something called a buffer. Now, a buffer is somebody who's really well-intended, but who does actions that kind of allow toxic behavior to happen anyway. So think about your manager that really likes you and is looking out for you, and they know you're about to start a shift with some jerk doctor that is always picking on you. So your manager moves you to a different unit that day. Well, that seems nice, and it might resolve the conflict in the short term, but what it does is subject some other poor soul to that same toxic behavior. It also prevents a conflict from happening, meaning that person who's a known abuser is not ever facing the consequences, the fallout from those actions. So while we do this to protect each other, we often do it to sort of dampen conflict, which then eliminates consequences from ever reaching someone. Now, if we want to be able to remove serial offenders, we need to stop buffering, call things out on the front lines, and then allow the institutional processes to take over, assuming they're actually intact. It's a lot to get all of this in concert, which is why it doesn't happen automatically. It doesn't happen just by hoping and wishing, and it doesn't happen very often. Okay, so I know that was a whirlwind. I know I'm kind of a motor mouth. I hope some of that landed for you, but if not, I'm always happy to go to your institutions and talk about this more. I'm always happy to talk about this more through all my other channels. But in conclusion, here's kind of what I want you to walk away with. We work in high stress environments, low wellness environments. It's tough out there. And healthy interpersonal actions aren't just going to happen automatically, or else they would have already happened. We see it. It would have taken care of itself if it was going to just happen. It hasn't. Also, institutions need to feel like they have an obligation to spend resources on creating and maintaining a culture of positive behavior. That means that institutions need to feel a pressure to spend money and spend their clout and their brands on maintaining this culture. Right now, it seems that the frontline worker is often the one shouldering the burden, and the institutions get to claim they can turn a blind eye to it and not spend the money. Although, ironically enough, I've already laid out a point for how they would probably end up saving money if they spent a little to improve their culture. All right, so I've talked a lot. I think I'm probably at the end of my time here, if not over it. So there's some conversations we need to have, not right now, but going forward in the future. We need to ask ourselves if we've finished describing this problem. I love survey research. I've got more of it coming out. I'm publishing more. I love it on my CV. But at some point, we need to acknowledge that we've proven there's a problem already. We need to move on. We need to stop underlining the point we already know, and we need to move towards researching and enacting solutions to it. Also, how can we get stakeholders to care? I mean, we know that we care when we're on the front lines dealing with this every day, but how about those institutions? I mean, it's already ostensibly costing them money. So what price tag is it that will get them to care? And what recourse do we have as clinicians, as healthcare workers, as frontline workers? Do we just vote with our feet and quit when we've reached the end of our rope? Or do we have other ways to leverage our power as healthcare workers to fix the solution before we get to that point, to actually impact our workplaces rather than just with our absence? What can we do besides just leaving? These are all things I want you to think about, talk about. These are conversations I'm happy to have with you in the future. I've got a bunch of references on the screen because like I said, I'm a huge nerd when it comes to this stuff. I've got additional resources. You can always reach out to me. I'm just full of all of these studies and a collector of them. So that's something that I just wanted you to be able to pause the video and write some of these down if you want to in the future. But in the meantime, I'm going to stop sharing. and flip back over to see you all.
Hi, Harrison. Oh my gosh. You're amazing. I was sitting here shouting at the screen as you were talking. I love your presentation. I couldn't agree more. We definitely, I mean, your speech ties in so perfectly with Sarah because we're talking about burnout, which it automatically, that word, it shoulders it on the healthcare worker, right? To find a solution. And yes, there are things that we can do, and we do need to look for things other than leaving, like you said, but we need to make it their problem. We need to make it the institution's problem. Why is this occurring, and how can we prevent it? And we have to hammer it home that it's actually, like you said, in their best interest. Something else I have to mention that you said, let's stop with the research. Everyone loves research, and it's great, but we've acknowledged it, right? We got it. Let's move on. What's step 2 now? Because I love it. I love reading about this stuff, but now I think it's time for action. And that's exactly why we're here doing this today. That's why we invited great speakers like you. And if you would ever love to be a part of our committee or our leadership, I think that your education and your presentations would really go a long way. We would love to have you.
Yeah, of course, I'd be happy to. That's kind of why I talk about this topic in particular, is because I think it's actionable. We might not be able to change the biology of our bodies or the physics of our planet, but we can 100% change our society, how we treat each other, the cultures we manufacture. It's all artificial. We have complete control over this. So not only can we study it, we can change it with the snap of our fingers if we really want to. It's just we have to get out of our own way. We have to align all of our interests and make it happen.
You're so right. You're so right. And thank you for that very thoughtful, presentation and your words. I really appreciate you being here. Thank you so much.
No problem. Thanks for having me. Appreciate it.
Next, we're going to highlight another organization that is very near and dear to our heart. I want to kind of make this a little clear too. These are not paid promotions or anything like that. These are simply videos of organizations that we love. They're doing community work, a lot of children, a lot of outreach, and it's tied with healthcare. So we wanted to go ahead and highlight some of these organizations.
When I met him and I seen him, I was like, what if I look like that when I get older?
He looks like me when I was little. So it was just cool, like almost seeing your younger self and just thinking about what was possible.
We talk about things that's just going on in our life, like feels like Eric is part of my family.
And growing up, there weren't really people in my life that I could identify as queer in the media or that I knew personally. To intentionally form that relationship can be very powerful, I think, for both of us.
I thought it sounded completely out of my comfort zone, which is part of the reason why I wanted to do it, something different. So knowing that I'm a positive role model for my little, I feel like it means a lot more than I expected it to.
Cheryl's like a big sister to me. I don't really talk to people a lot. I keep to myself. She's like a friend that I never had before.
So my name is Cheryl, and I have been Sammy's Big for about 5 years now.
I'm Javon, and I've been matched with Javion for a little over 2 years.
My name's Eric, and I've been matched with Levi for about 2 years. Whether it's in books or in movies or in relationships, it's really affirming to who you are and who you want to be able to look out and see someone who's like you and know that whatever you want is possible.
I definitely wish I would have had a big growing up. Just to have somebody to just kind of take me away and do something different. And it feels really good to do something that Sammy has never done before and just to see how much she loves it.
I think Javion has the potential to be somebody who's very impactful, not only in his family, but in his community. Just the imagination that he has makes me proud to know that any circumstances aren't hindering him. So I'm proud of the vision that he has for his future.
So to have representation, especially a real live person in their life who can show them what their potential is, I think that's really powerful. And I wish I had had that when I was a kid. And so I'm really excited to be able to do that with the Big Pride program.
Since I've known Eric, I've felt more comfortable in my own skin.
I don't understand the struggles that he's going through. When he talked to us about his issues, it was never a big deal at our home, but we don't know what it feels like to grow up questioning things. I just want him to be happy.
You know, I hear people say if you can see it, you can be it, right? Representation matters because we're not used to always seeing people like us do certain things. They just need that quality time, those words of affirmation to have an example and to know like I can make it.
Cheryl made it possible for me to think I could make it out of college and get a good life and a good job. I think it's because of the way that she's grown, because like she went to college and stuff and she made it out perfect, so I want to grow up like that. I don't know, like ever since I met her, I just love school.
He's the only one that listens to me when I speak. I think it's special because I don't tell nobody else about that stuff but Javon. He's like family to me.
I've seen other organizations like, you know, talk the talk, but Big Brothers Big Sisters has really walked the walk and lean into their values and being able to do it not only within their programming and their mentorship program, but also within their organizational structure, really challenging themselves to lean into that potential that they're seeking, to lean into equity. So I've appreciated that.
So thank you to Big Brothers Big Sisters for sending us that video. My takeaway is I want to be a big sister, and also I want to learn how to do a backflip. So tune in next year, see if we've made any progress.
We're gonna learn.
We're gonna learn,
Yeah.
or we're gonna get really close with the EMS agencies in our neighborhoods.
Anthony's gonna help us out.
Yeah, Anthony and Angie are coming to pick me up. It's fun. Okay, so the next speaker, I'm gonna be honest, is probably my personal favorite. It's one of my closest friends. My friend Sabine is a DPT who is currently practicing in Chattanooga. She does school-based, outpatient ortho, and hospital-based PT. She is super smart. She's going to talk to us about the importance of direct access and some of the barriers to care that are present in physical therapy, along with some of the sort of same themes that we've been talking about through every issue. Hi, Sabine.
Hi. I apologize in advance. I was sick this past week, so this is not my normal voice, but I hope everybody can understand me. So like Laura said, I'm Sabine. I'm a doctor of physical therapy in Chattanooga, Tennessee, and I split my time between 3 settings because what healthcare professional isn't busy enough already? I spend part of my time working in Walker County, Georgia, which is in North Georgia, right across the border, working with the special needs children and the medically complex children who are in our special ed program. And then I'm the other half of the time in an outpatient ortho private one-on-one clinic, which is super rare for a PT. And I feel very fortunate to have clawed my way into the one-on-one outpatient ortho field. And then I, the third half of my time work PRN at our local level 1 trauma center hospital. And that was more than PRN during the pandemic, as everyone can imagine. So I'm going to touch on 4 things today, and I don't have a presentation to share with you guys, so you guys just get to see my face the entire time. The 4 things I want to touch on are, what is a PT? Like, why the heck do we have a doctorate? And, what does that look like? What can a PT provide in terms of interdisciplinary medicine? Like, what else can we do to support other people in the field? Why are we both under and overutilized at the same time in several fields? And then the 4th thing is, like, why the heck are we everywhere? We are everywhere. We're in hospitals, we're outpatient, we're in SNFs, we are everywhere. So first of all, I just kind of want to explain what a PT is, because I think a lot of people are a little fuzzy, because the stereotypical PT is just somebody who assigns clamshells and gets somebody up and hauls a patient from the bed to the chair and back. And, we are always the bad guys. We leave the patient in the chair for the nurse to have to figure out how to get back later. And I just want to do a little educating on that. So a PT is a functional movement specialist. And what is functional movement in the 21st century? It's everything. It's going to work. It's getting in your car. It's running. It's playing soccer. It's being able to get on your couch. It's being able to get off of the floor if you fall, getting in and out of your bathtub. It's doing anything that you want to do and anything that you need to do to survive. So anything functional. And the 4 fundamental components of functional mobility are complex and intertwined, and they are why we are a doctorate, and it has to be a doctorate as of 2015. There are still some master's PTs out there. A lot of them have transitioned to a doctorate, but the field is getting deeper and our responsibilities are getting larger because of its complexity. So the 4 basic components of functional mobility are anatomy, the physical structures, how they work, every joint, ligament, fascial structure, nervous pathway, efferent, afferent, and all of the functional anatomy of a joint, the roll, the glide, what muscles and what tendons are acting on a joint at every angle of every motion, for everything anybody could possibly want to do. The second component would be the physiology of functional mobility. What pathologies, what chemical processes affect mobility? How does lung function affect mobility? How does heart function? How does a drug? We have to be able to take a person and look at them and look at their limitations and understand how every system physiologically affects their movement. Like, I have to know what a drug does and why it does it in order to treat my patient responsibly. Are they immobile because of heart function, lung function, drug, orthopedic impairment, etc.? Is it dementia? Is it neurologically related? The third component would be physics. We do a lot of physics. So physics is, the properties and interaction of space, time, matter, and energy. So what is aging if it's not space, time, matter, and energy, and the decline of all 4 of those things? And then mechanics is the 4th component, actions of forces on material objects. So if you can imagine walking, running, moving, anything, it is a force. There is a ground reaction force coming up through whatever part of your body is touching whatever it's touching, the back of your seat, your foot on the ground, anything. So in layman's terms, I like to tell people, and feel free to correct me if I'm wrong, but I like to tell people we're the civil engineers of the human body. We put together components to make a functional someone. We have to know a lot about a lot of different things in order to help somebody move. And motion is lotion is the thing you always hear with PTs. We all know that mental health is tied to physical health in a way, and that a lot of people, especially in this day and age, rely on physical activity and movement to survive. So what do we know? We know a heck of a lot. We have taken extensive anatomy, extensive statics classes, which if you're an engineer or an engineer or you've been an engineer, you know how hard statics and materials are. We have to understand pharmacokinetics, pharmacodynamics. And if we don't know what a drug does, we have to know how to research it and know how to read it and know how to interpret what it does. We also do a lot of reading telemetry, reading, MRI reports. We have to understand everything that comes out of a report when a patient comes to us, because we can't just call an ortho and be like, what's up? So from here, why was all this important? Like, why do you need to know what a PT is and what a PT does? It's because I think that our knowledge is underutilized in medicine, and we could help offload a lot of the people who are way overtaxed in the healthcare field. I mean, I'm not going to lie, as a PT in the hospital, I think that our lives can be a lot easier than, say, a nurse's or a pharmacist or a physician's, but I don't necessarily think that's a good thing. I think it's because we are underutilized and our knowledge is underutilized. And a lot of times that leads to people feeling undervalued, and it leads to people being underpaid. And we all know that leads to burnout. Because, you know, my brain knows a lot, your brain knows a lot, and it's not being used, and we're just being cast aside and used for things that honestly we don't need to be used for. So I'm going to break it from here into an inpatient and an outpatient role, because I do have experience in both. And I think I can speak personally to a lot of it. And also there's a lot of research out there that feel free to peruse, you know, basic terms on the internet to research anything that I say. And I'm happy to provide references afterwards as well. But like I said, I don't have a presentation, so it's kind of hard to do. So inpatient, the way I like to break it down that we're being underutilized in a way is by levels of care, right? And so I'm going to break this into like just kind of global levels of care. I understand there are more levels than the ones I'm going to you know, piece it out into, but we have limited time. So in terms of nursing, right, the mechanics behind a transfer, the number of times that I think PTs are called into a patient's room or put on, or an order is made for them because the patient simply needs to be moved from one place to another. Frankly, I think that nurses are done a complete disservice by not having any training on transfers. I mean, they have basic training, but the ways that they do it, it's not sustainable. The number of nurses that I treat personally in an outpatient setting from back injuries is appalling, and it's a disservice to nursing in general that they have to go through that. You know, because of our really good knowledge of like the physics and the mechanics of the human body, we can transfer people very well. And there are so many times that we're called in to move somebody. So if we could provide training, or we could provide knowledge to nursing staff in general, I think we would alleviate a lot of stress for them, because we all know that nurses take the brunt of the like patient rage when they can't get what they want right away. And a lot of times that's because of positioning. And they frankly position patients sometimes the way that we can, because they aren't educated on the positioning that they need or the precautions for surgeries. So I think that we could provide a lot of relief to nursing in a mental and a physical way by providing them with the education on how to move people effectively, so that they aren't getting yelled at by patients, and they aren't getting yelled at by patients' families. And the physician comes in and is like, why hasn't this patient done this thing that I've wanted them to do? So I think that's one way we could help. In terms of more of a mid-level, way in the ED, I know that a lot of PAs and NPs are put in the position of seeing a lot of orthopedic and vestibular impairments or injuries that physical therapists are very well trained on. So in terms of diagnosing, we can only technically diagnose a functional deficit, but in terms of diagnosing a ligament injury, a structural injury to an ankle, a knee, a shoulder, a hip, a foot, anything, a finger, we are just as effective at diagnosing those injuries as an ortho in the clinic. Statistically, there's a ton of research out there on that. We are very well versed on diagnosing injuries, because if we don't know an injury, we can't treat it. If you just walk in with like vague knee pain and I can't figure out what the heck the knee pain's coming from, I'm not going to be able to treat you. I can put ice on it and tell you good luck. So our knowledge of these things could save not only mid-levels from having to, order imaging, unnecessary imaging for patients, making them wait to read the imaging results, 2 weeks later, 10 days later. We can save them a lot of grief with vestibular injuries. We're vestibular specialists as well when it comes to concussions, dizziness. You've all heard of a Dix-Hallpike maneuver for like a displaced otolith, those kinds of things. And if you haven't, then I'm sorry that I'm kind of rushing through and grazing over that. But I think we could save patients a heck of a lot of time and a heck of a lot of injury or money and injury if we can expedite them and the diagnosis of their functional limitation or their mechanical limitation and get them the care they need immediately instead of waiting to read imaging results, even if it's 2 hours later or 2 weeks later. When it comes to ankle, wrist, hand fractures, if you get imaging in the ED, chances are a fracture isn't going to show up for another 2 weeks, and your provider knows that. So they're going to make you come back in 2 weeks anyways for imaging, just to confirm a fracture, and they're going to send you to PT in the meantime. So that's just an example of time wasted. In terms of case management, PTs are home safety and discharge disposition experts as well, especially when it comes to rehab facilities and safety and at home. We know how much force and how many pounds of force go through your knee, go through your foot, go through your hip, everything, when you're going up 7 steps to get inside. And we know based on your injury and which side it's on and which side your handrail's on and how your tub is positioned and everything. We can talk to patients and get information about their home that is extremely valuable for making a responsible discharge disposition recommendation. So I'm really appreciative of case management, obviously, because they do the paperwork, legwork to get patients where they need to be. And I think that if we were able to be brought in more often, even just as consult, we could definitely help them make some tough decisions. So once again, my hat's off to them because that is a lot to navigate between insurance and families. It's a lot. So in terms of the outpatient world, which is what I think from what I see, like a lot of people are more in the inpatient world, especially on the chat and in the rest of, everything else that's gone on. I think our autonomy and the access patients have to us directly is incredibly important to save them and other healthcare providers time and money. And we all know time is money, so they go hand in hand. On average, it takes somebody 24 days to get in to see a sports med or an ortho, and it takes them 2 days to get in to see a physical therapist. And like I said earlier, PTs and orthos have the same level of specificity when it comes to special tests for structural injuries. We can't order imaging in most states, but I hope that's changing. And the VA currently, PTs can order a lot of imaging. We are well trained in reading imaging results. A lot of times I come in and, a patient comes in and they say, like, my ortho didn't have time to go through this whole thing with me. And I spend 45 minutes reading through their MRI report with them, explaining every single thing that is wrong, or not wrong. And along that line of thought, in the outpatient world, right, low back pain is something that people come to the ED for. They get primary care through the ED for. They come to the hospital for it. If a patient gets imaging that shows some sort of structural degradation in their spine, they are 60% more likely to manifest pain from it, where, degradation and just a degenerative aging process is completely normal. It's the same thing I like to tell people as like your face wrinkling. Sure, the structural integrity is a little bit weakened, but just because you have a wrinkle doesn't mean there's something wrong with you. Just because you have a slight herniation does not mean that it is necessarily going to be painful or detrimental to your functional mobility. 30% of people at the age of 30 have some sort of degenerative process in their spine. And 85% of them are asymptomatic. So that's a really big one. I really think that having direct access to a physical therapist is important to keep people out of the pain management cycle that can be really unsuccessful and contribute to so many things like the opioid epidemic, unnecessary surgical intervention, and it can really change the way that people see their pain and their limitations by coming to see a functional movement specialist. And in the chat, I saw something about PT assistants, and I would love to give a shout out to that because PTAs make the world go around. If you have worked with the PT or the rehab department, chances are you have encountered a PTA because PTs do the evaluation for the most part in a lot of settings, and they make the functional diagnosis or the the diagnosis of whatever functional limitation they have, and PTAs execute perfectly. They know, honestly, probably more than any new grad PT. In my school setting, I work with 2 assistants who have combined like 50 years of experience, and I look at them for everything. Do not discount PTAs because they know a ton. I honestly can't speak much to their schooling other than the fact that they go through 2 very vigorous years of schooling and they have to pass a national board exam as well. And I don't think I've ever had a PTA gone wrong on me, so don't discount them, definitely. So from here, just to kind of wrap things up, I just want to reiterate that I think that PTs could really help alleviate a lot of the stress on the rest of the healthcare world. But that being said, I think that PTs, what a lot of people don't know is that we are very burnt out because of the underpay and the overwork. So I'm going to leave you a little nugget, and I see that somebody sees or wrote in the chat about multiple patients at a time. That's literally what I had down next. So my little nugget is if somebody comes to market to you or anybody you know about a physical therapy clinic, and they see their PT or their PTA sees more than 40 patients a week, that is a major red flag. Because in order to provide quality care, you need to see somebody one-on-one. The number of clinics that make a PT see 3 people at a time is absolutely disgusting, and it's appalling, and all they're doing is maxing out the amount of reimbursement they can get from an insurance company. And 9 times out of 10, the tech who has had no training and is not legally allowed to touch or talk to a patient in any rehabilitative way is providing the treatment. The laws are a little bit laxer in the state of Texas, but for the most part, techs are not allowed to contribute directly to the care of a patient. So if somebody comes to market PT to you or anybody you know or any ortho or anything, and they see more than 40 patients a week, they are making money off the backs of an underpaid therapist. In order for me personally to make $90,000 a year, which coming out of school, $175,000 in debt, right? Doesn't seem super fair with a doctorate. I only need to see 40 patients a week to make $90,000 a year. Most of these mill clinics are making people see 80 to 90 patients a week, and they start them at a whopping $65,000 a year. I'm going to let you do the math on how much a clinic makes off the back of a poor, underpaid physical therapist, because PTs are notorious for undermarketing themselves, like just the profession in general. And we have been trodden on, and it is definitely coming back to haunt us now. So that's the nugget I'm going to leave you with, is that PTs are also burned out, mostly in a huge underpaid, underappreciated, undervalued way. but there are still a lot of us that love what we do, and we really appreciate everybody else that works in healthcare, and we want to help you because I think we have a lot of knowledge to share, and we can distribute the wealth a little bit. So I'm not sure if there's time for questions because I think, things are running just a few minutes behind, but holler at me if you have any. My Instagram handle is on the Impact website, and I'm always down to answer questions.
Thank you, Sabine. I love you so much. Your talk was great. Abby was shouting at the computer again. So that's always a good sign.
The chair, you put the patient in the chair. Yeah, that's the nurse beef with PT, right? Yeah, but I was so happy that you explained that and you talked about what you do and that idea about the mills where you could make a living wage seeing such a significantly lower number of patients versus what they're asking you to do while being paid less, right? I mean, we can do that math. And I think that's the most important point when we're talking about, especially when we're talking about a higher level education doctorate. I think sometimes people get caught up with, well, that's still a good salary, 90,000, that's still good. Okay, but who's pocketing the rest of it, right? We need to look at that because that's the real thing. And then also why is your patient suffering because of that?
Yeah, I think that's a really good point. It's not, I think a lot of people in healthcare do make a good wage.
I'm shouting.
Yeah, Abby gets fired up.
I'm sorry.
And I think a lot of people, I know doctors make a good wage, and I feel like that's not necessarily even the conversation. Is not all of us saying that we need to necessarily even make more. I think PTs definitely should as doctorates, but I think the conversation is, I don't necessarily need to make more, but why is someone else making so much profit off of making me do a bad job that I don't want to do? So I think that was a really important point.
Exactly. Next, thank you again, Sabine. We so appreciate you. We love you.
We're going to send you a bunch of questions that you have to answer and we'll repost. Okay.
Yeah.
All right. Great. Love you. Bye.
Next we have William Amarque. He is a PharmD. William is one of my friends. We just did this so we could talk to our friends, basically.
Yeah.
He is a pharmacist in Florida. He does a lot of patient advocacy, a lot of talk about pain management and the opioid crisis, sickle cell disease, and COVID, as he was a COVID frontliner. And I'm just so thrilled he's here. So William, take it away. Hey.
Hey, how you doing?
Good. How are you?
Doing pretty good.
Good. Nice to see you.
Well, thank you guys so much for having me on. My name is William. I am a clinical pharmacist in Florida, and I've been a pharmacist for a little over 3 years now. And I'm excited to have this talk. And hopefully, after this talk, you'll get a little glimpse into the pharmacy world. So when you think of a pharmacist, what is the first thing that comes to your mind, right? You think of the person behind the counter, putting pills in a bottle and giving it to the patient. That's kind of how the media and that's kind of how, pop culture kind of portrays pharmacists, right? Is that person behind the counter. But we do, so much more. And especially during this COVID pandemic, it has shown that we've done a lot more. And it's interesting. I talk to, a lot of people, and a lot of people are not even aware that we have our doctorate degrees. And it's interesting. A lot of people are not aware also that we can do, after our PharmD degree, which is 4 years, we can also do residency training as well. So we can do either 1 year, or if you want to specialize, we can do 2 years as well. And there's a variety of specialties that pharmacists can get into. We can get into pediatrics, we can get into infectious disease, we can get into pain management, we can get into, cardiology, transplant. So there's just a wide variety of specialties that pharmacists can, go into. And, as pharmacists, we're involved in what is called pharmacotherapy. So basically it's the treatment of a disorder or a disease with medication. So, essentially we are that last check before, the medication goes to the patient, right? So, it's important that we understand the medication, that it's right for the correct indication, the correct dosage, and all these things that we're checking in, before it goes to the actual patient. So we have to make sure all these things are, correct. And, as a hospital pharmacist, I work, very closely with nurses, with residents, attendings, the dietitian when we do our, TPN management. So, as pharmacists, we're very integral and we're vital, in the healthcare team. And we work with, a plethora of other, healthcare professionals, as we saw in the previous speeches that were given. So it's, during the COVID pandemic, it's been very crazy for, different professions. But, with pharmacy, it's been, very crazy in the pharmacy world as well. And not just, me as a hospital pharmacist, but, community, pharmacist as well. So in the hospital setting, for example, our, infectious disease pharmacist, our infectious disease pharmacist at, at my hospital was very integral in, helping coming up with, COVID protocols and, understanding, the protocol and what drugs that our COVID patients are going to be getting, making sure, all that is squared away. So when we, had our, infectious disease specialist, she would work with our, ID docs in regards to remdesivir, tocilizumab, baricitinib, and then also when patients will come for the, monoclonal infusions as well. So, all these things are happening, behind the scenes. We have our infectious disease pharmacy specialists, working with our ID docs in order to, facilitate, the best outcomes for the patient. And also another big thing with the COVID pandemic is drug shortages. So drug shortages were something that is, very big and something that was, happening during the pandemic. And of course, pharmacists, when it comes to drug shortages is important because we can understand, what other drugs we can use if, a particular drug is on shortage. So for example, our MDIs, so our inhalers, also, hydroxychloroquine, as you know, the big fiasco with that. And then also just our, sedation medications as well for those COVID patients who were on the ventilator. So we had to, be creative and, really help out in regards to the, drug shortages that were happening, especially during, the COVID pandemic. And the thing is, me as a hospital pharmacist, being on the front lines with COVID, it's not just hospital pharmacists. Also, I wanted to talk about community pharmacists. A lot of people, as I said before, think of community pharmacists as someone who just, puts pills in the bottle, but they were also very vital throughout this pandemic as well. And, one of the most, one of the biggest preventative measures for COVID, obviously, is the COVID vaccine. And, where are people going to get the COVID vaccine? Obviously, the pharmacy, right? So if you drive down, any, block, you'll see CVS, Walgreens, Walmart. Pharmacists are some of the most accessible healthcare providers around. So, millions and millions of vaccines are being given by, these pharmacists. And as I'll talk about later, with pharmacy burnout and just being overworked, it puts a lot of stress on our community pharmacists. So, they are front line as well, dealing with, this pandemic as well. So as I talked about, pharmacy burnout, I want to kind of transition into talking about burnout and kind of workplace environment and a little bit about PBMs as well. So when it comes to, pharmacy burnout, there's a lot of, negative things that can happen that can, hurt both the pharmacist, but not only the pharmacist, but also the patients who are coming to the pharmacy to pay for the medications, right? So one of the big industry players that I'm sure people have heard about are PBMs, right? So what is a PBM? PBM stands for Pharmacy Benefits Manager. And, basically when they first came around, they were really to help with the administrative burden. They were to help with the numerous amounts of prescription claims, with the health insurer. And, over time, some of their duties kind of, grown as well. So PBMs are also involved in formulary management, contracting with, pharmacies, and then negotiating discounts and rebates with drug manufacturers, and things of that nature. But the thing is, with anything that gets created, obviously it can morph into something a lot bigger, and that's kind of what PBMs have happened to PBMs. They've kind of morphed into this huge entity. And the thing is, people have been criticizing PBMs because of how big they've gotten, and because of kind of the lack of transparency that has happened. And because of that, also, they have a profit-making motive, as people have talked about before, that kind of come at the expense of the pharmacist, and also especially independent pharmacists who are owning their own independent pharmacy. They really can hurt the independent pharmacist and also the patient as well. So when we talk about PBMs, I wanted to talk a little bit about how PBMs take advantage of both pharmacists and patients. So right now, they're the big three we call for PBMs. We have Express Scripts, which is under Cigna. We have CVS Caremark, which is under Aetna. And then we have Optum RX, which is under United Healthcare. So those are the big three PBMs. And they, make up, at least 80% of the, PBM market share. So, and they're responsible for processing a lot of, prescription claims, right? So to give perspective as far as how big PBMs are, there was this study done by Dr. Shirlene and colleagues in 2017, and they looked at one of the top PBMs, Express Scripts, and the revenue that they brought in was $100 billion in 2017 versus Pfizer, which was $52 billion that year. So if you can imagine, these PBMs are making more in revenue than some of our pharmaceutical giants like, Pfizer. So that kind of gives you a perspective as far as, how big, these PBMs have, really gotten. And the fact is that one of the biggest issues in how PBMs can take advantage of pharmacists is the reimbursement issues, right? So the PBMs basically can reimburse pharmacists lower than what it costs to actually, buy the drug. And that can really hurt the pharmacy business, because if you're making less, if you're an independent pharmacist who owns a pharmacy and you're getting reimbursed less than what the drug actually costs, that can put you out of business. And there's been many reports of independent pharmacies having to close down because the reimbursement is just so low. And what happens when a community pharmacy that's been in the community closes down? It's going to hurt the patients, right? So, what happens when an independent pharmacy closes down? It hurts the patients. That relationship that the patient and the pharmacist had is gone. And now the patient's going to have to go somewhere else. And so it just kind of disrupts things. It disrupts the community, disrupts that relationship. And it really does hurt the patient at the end of the day, because now they have to find another pharmacy, and they have to, they're not going to have that relationship anymore. So, there's been reports of independent pharmacies losing out on their business, and it just hurts the patient. It hurts the relationship between the pharmacist and the patient. And the thing is, PBMs also, as I talked about, reimburse the pharmacist low, and then they jack up the price that they charge to the plan sponsor. So that's called what we call spread pricing. So that difference, it goes back to the PBMs. It doesn't even go to the pharmacist to help them with the business, which they're losing out on the medications that they acquire for their patients. So this can amount to millions of dollars that the PBMs end up collecting, which is, ridiculous. But as I said before, PBMs have grown into this huge entity, and PBMs take advantage of pharmacists, and they also take advantage of the patient as well. So PBMs can also inflate the price of the medication, or the copay in which the patient has to pay. And they can end up, pretty much charging or inflating the price. And the patient's going to have to pay this inflated price, which is way higher than the price of the drug. And so the difference, again, goes back to the PBM. So I remember working in an independent pharmacist before I became a pharmacist as an intern, and I would see this. I would see this firsthand. And the thing is, back in the day, PBMs had what they called gag clauses. So, which is even more crazier, is that the pharmacist, these gag clauses, the pharmacist wasn't allowed to tell the patient that the price was cheaper if they paid, cash price for it. These gag clauses are no longer, are banned, but just imagine, how, money hungry these, organizations are, that they institute gag clauses that the pharmacist can't even say to the patient, that no, this is going to be cheaper if you go this route. So the pharmacist's hands are kind of tied. Good thing that gag clauses have been banned, but it just shows you the lens at the way some of these organizations really take advantage of pharmacists and patients as well. Another way PBMs can take advantage of patients is that PBMs really have a monopoly. As we said, there's the big three, as I mentioned before. So take, for example, PBM, CVS Caremark. CVS Caremark, they own their own retail pharmacy. They own their own specialty pharmacy, and then they own their own mail order pharmacy. So what happens is that they can steer patients who are on the plan to use their own pharmacies, even though, drugs may cost cheaper somewhere else. They steer patients to use their own, pharmacies, which is insane, right? Imagine, a PBM owning a retail pharmacy, owning a specialty pharmacy, owning its own mail order pharmacy, and steering patients to go there so they can line their own pockets, right? And then it would end up being, more expensive for the patient. So these are all different things that PBMs do, and PBMs are just one player in this industry that really take advantage of pharmacists and patients. So I wanted to highlight PBMs, and also I think something that is very important is pharmacy burnout as well. I think that pharmacy burnout is so important. And I was reading an article in the Chicago Business, and the title of that article was "Add Pharmacists to the List of Burned Out Healthcare Workers." And I thought that article was so fitting, because sometimes I research, articles that, give a list of healthcare workers that are burned out. And sometimes I never see pharmacists on that list. And I think that's, sometimes I think that's kind of strange, but I really like that title of the article. It said, "Add pharmacists to the list of burned out healthcare workers." And I think that's so important because, pharmacists, in whatever setting you're in, whether you're in the hospital, like I'm in the hospital, whether you're in the retail setting or whatever, we're being overworked and we're being, underpaid for our services. And I think one of the biggest things is the disconnect between corporate and between the pharmacy staff workers. I think there's a huge disconnect with what happens. A lot of the times you have corporate who just doesn't understand what goes on in the pharmacy world and what goes on, on the ground. And, corporate really, they don't take the pharmacy staff, our considerations as first priority. And there's many things that get talked about, but there's a couple things that I wanted to highlight. So, certain issues include being, overworked, also not having enough staff, having inadequate pay. There's times in the hospital where, we don't have enough coverage, especially during the COVID pandemic. It's big that we need coverage because my technicians are delivering are delivering medications all over the floors, even the COVID floors as well. Sometimes we're down techs, so I have to be the pharmacist and the tech. So that kind of, gets me away from the clinical work I have to do as a pharmacist. So there's many things that happen, in the pharmacy. So as I said before, not enough staff, inadequate pay. The big thing is that you look at the revenues of these, hospital corporations, the revenues of these retail corporations, and they're making billions of dollars. I think my hospital corporation last year made over $50 billion, and they can't even afford to, give the pharmacy staff raise. I mean, they give us a dollar raise. This past raise, they said it was going to be the biggest raise we've ever seen, and it was an additional, I think, 20 cents more. So it's just the disconnect. We're frontline pharmacy workers, working, frontline in the hospital, in the community, and there's just a big disconnect as far as our compensation. And as a pharmacist in the hospital, I also work, along bedside, along with the nurses, the residents. So pharmacists are not just down in the pharmacy dungeon of the hospital, verifying orders. We're out on the floors. I'm working with the nurses. If codes happen, we're there, drying up medications. So as I said before, we are very vital in the healthcare team, but also we face burnout just like many other professions as well. And there was a hashtag. I think a pharmacist made a hashtag called "Pizza is not working," and I love that hashtag because corporate, a lot of the times corporate thinks that they can appease us by these pizza parties, but it just doesn't work. I mean, we are being overworked, we're being underpaid. So I think that the "pizza is not working" hashtag, if you go on social media, you can see it, is very fitting because it's not enough, right? So I wanted to highlight a few things. There was a story of, I believe, a pharmacist who happened to end up passing away, which is a very sad story. They ended up passing away. They were waiting for pharmacy coverage. I forgot what state it was in, but they were waiting for pharmacy coverage. And they told her, it was coming, and the pharmacist ended up dying, having, I believe, a heart attack, and ended up dying. And it's just, you see how bad, pharmacists are being overworked. On top of all the stuff we have to do now in the COVID pandemic, adding on the vaccines, now with the boosters, and then now with the age group, I believe 5 to 11 now with the new age group, it's just going to bring more and more stress onto the pharmacist. And I've worked with pharmacists who have broke down in the middle of their shift in the retail pharmacy and just started crying because they couldn't do it anymore. I mean, especially I used to work in the retail setting before I got into the hospital, but the retail setting is just not sustainable. We have a lot of metrics. You have the drive-through. Shout out to my community pharmacists. They're really going through it right now. I mean, you have the drive-through. You have all the different metrics. You have patients coming in for flu shots and COVID shots, and on top of all the workload that they have to do, it really is stressful. And there was actually another story of a Walmart pharmacist that got a class action lawsuit, actually. And that pharmacist won the class action lawsuit. I think it was $27 million. And they won the $27 million. And I thought it was a kind of an interesting story because it was kind of, the pharmacist, winning for a change and, sticking it back to the big corporations who are exploiting that person. And some of the things that happened to that Walmart pharmacist who won that class action suit, they were being denied breaks. They were being denied overtime pay. They had inaccurate wage statements. And the pharmacist also found out that the company was defrauding patients. They were charging Medicare patients higher than they needed to. So, all these things were happening, and they, this pharmacist won the suit. And it was really good to hear this because, it's good to hear that a pharmacist actually, won something. And the pharmacist who got exploited was denied breaks, was denied overtime pay. In the story, it also talked about how she had taken time to get her immunization certification and they didn't reimburse her for that. So it's just a lot of different things that go into this healthcare system. And as a pharmacist, at the end of the day, I can't be stressed because it's my job to make sure, as I said before, we're one of the last checks in order to get the medication out to the patient. So if we're overworked, if we don't have enough staff, I'm tired that day, something just slips my mind and something goes out, right? That's going to be on me as a pharmacist. So that's why it's so important, because we have to make sure that we're properly staffed and we have adequate working conditions in order to best serve our patients, right? So, it's interesting. Just the biggest thing, as I've said before, is the disconnect, right? We've heard over and over again in the past presentations that during the virtual conference, just of the disconnect between the higher ups and the people on the ground, right? There's just a huge disconnect. And it's interesting, the CEO of CVS just tweeted out the other day that she was happy about CVS's third quarter earnings. So I went to go look at the statement, and it looks as if they made over $73 billion during this pandemic. And it's just crazy to me how we as pharmacists who are on the front line can get 20 cents for a raise, and these people are these corporations are profiting over 70 billion during the pandemic, right? So it's just a huge disconnect to me. And I think that a big change, especially in the pharmacy world, needs to be done. And I think that it's important to highlight all these things, because as a pharmacist, it's important for me to serve my patients, and I love serving my patients, and I want to make sure that I have the best working conditions and my staff have the best working conditions in order to make sure that the patient gets the right medication on time. And I think that these things really it gets put into perspective regarding the state of of healthcare right now. So I think overall, what I want you to get out of this speech is that I want you to understand the importance of pharmacy and the importance of how vital we are to the healthcare team. And I want you to understand that the pharmacy staff, not only in hospital but in the community, they are busting their butts in order to vaccinate everyone and just do the best we can do as pharmacists, right? So I think that at the end of the day, the patients really are one of the most important things, because it's so important as pharmacists that we serve our patients, and not just pharmacists, but healthcare professionals in general, right? So it's just so important that everything that we have been talking about today really gets puts to the test and really starts to have action behind all these things that we're saying. So I think it's really important to understand that especially in the pharmacy world, there's so many things that have happened during this pandemic. And I think that, especially in my hospital, when we were at the peak, we were, half our hospital was COVID patients. And, it's so important, as someone who sees these things, on the inside, it really takes a toll, on you. In pharmacy school, they don't really teach you about how to handle seeing death, or how to handle, seeing these things, right? So especially during the COVID pandemic, it really does take a toll on you. And, it really does, weigh on you, because these patients need to be taken care of, especially during, as I talked about, with the drug shortages, trying to figure out what drugs, what else the drugs, these COVID patients can get, as far as, different things with the MDIs and the sedation medication. So, all these things, pharmacists are thinking about and are doing, behind the scenes, but not also behind the scenes, but also, as I said before, right alongside, right alongside, the other healthcare professionals. So I think that, it's so important that we, understand this, especially in the pharmacy realm. And, just wrapping up, I just wanted to say that, once again, I think that, it's so important that we understand, how vital pharmacists are to the healthcare team. And I think that, this event has really showed, each healthcare professional and what they, contribute, to the healthcare team. So I think it's really important that, we really highlight this. And I'm glad that, we got to have, pharmacy on there to, just get a little glimpse of, what happens, in the pharmacy world. And I think that that's really important.
Oh my gosh, William, you're amazing. That was really educational. A lot of things that I didn't understand. I was so happy to understand your perspective as an insight, into this, pharmacy and CVS and Express Scripts and,
PBMs
PBM. And it's
topic.
like, it's crazy. I would love to have you involved. And, if you ever wanted to come on board, I would love it. I'm not going to pressure you, but I would love it.
We promised this entire event was not just a recruiting tool, but it kind of was.
But after I
It
talked
kind of
to you,
was.
I was like, I really like everything you're saying. Yeah.
Everyone's giving such good presentations that we're like, you need to come teach us.
Yeah.
We need your help. You are
we need
amazing.
your help. Yeah. But anyway, keep up the good work. Pharmacists are very much frontliners, and we support you and we see you. And I see you on the floors in the ICU. Laura sees you guys in the ED. I mean, it is not a joke. People got sick. People, were critically ill during this time.
You guys are the people that I call when I'm like, I don't want to do math. I'm not smart enough for this. I got to call the
Yeah.
big brains, and
Yeah.
I'm going to go do my fourth grade, my fourth grade medicine.
Yeah, I'm like, how fast can I run this? I don't know.
Do these drugs go together?
Yeah.
So we're so grateful to have pharmacists not only on our team in the healthcare setting, but also on our team here.
Yeah. Thank you so much.
One last additional note of thank you to you and all of the pharmacists who will be vaccinating our children starting this week. My daughter has her appointment on Tuesday to get her first Pfizer vaccine.
Yay.
So we're also thankful that you guys are out there starting to vaccinate your children.
Yes.
Up next is a video from Debriefing the Front Lines. Their founder is one of our department heads. She's the mental health department head, Tara. So we're super thankful that they sent this gorgeous video in. And if you're interested in getting involved in the mental health department or in any of our other department heads, just go ahead and send us an email to iwanttohelp@impactinhealthcare.org.
And so with a note on Tara's video, we watched it and we're like, oh, we don't look good enough for our videos. So thanks, Tara, for making us look very bad.
You look amazing, Tara.
Amazing.
We love it.
And then just notes for the rest of the program. I know we've gone on for a really long time. We are coming to the end of the program. We have a couple more really, really exciting panels and really good speakers that we want to let you know about. So if you're getting bored, it gets better, I promise.
Bored of us talking.
Bored of us, yeah.
Yeah.
Everyone's been great.
Yeah.
We're very dull. But
Yeah.
so if you want to have a heads up for you guys, after Tara and Debriefing the Front Lines, we are going to conclude our EM versus IM panel. We have our ER nurses, Jason and Christina, against Abby. I think
it's the nurses now,
yeah,
you
the
guys.
nurses, it got spicy. It got good.
Drop it in the chat
Yeah.
before you see it. I don't want to see this, I knew who's going to win.
Yeah.
Drop it in now.
Also, you can place bets on what topics you think we covered because we got some good ones.
What nursing issues did we cover, do you think? Put it in the chat. And also, while you're in there, please like and share because we really need to spread this too.
Yeah, so many people have done so much work on this. Not really us. Really, all of our speakers have done so much work that we do want to make sure that anybody who's interested in this does have a chance to see these amazing topics that we've had. And then after our EM-IM panel, we have our good friend
Shirlene.
Shirley Whirl.
Shirley Whirl is coming on and she's going to talk about residency and exploitation of residents and how I saw a little clip of a honeybee, how residency makes you like a little worker bee, I think.
That's
It's
a
a
good one.
preview.
And Shirlene is, obviously, you all know Shirlene. She is incredible. She's a great doctor. She's currently in fellowship. She is writing
She wrote a book.
Yeah, writing a book.
Wrote a book.
Publishing a book.
Coming out this year.
Yes.
The second we have it, we're gonna tag
definitely.
her.
And she's just so amazing. And the fact that she made time for us is such a huge
sacrifice.
We don't deserve it. We're so glad she did.
I'm sorry, but she's a cardiology fellow. She has no time. She was working like 3 24-hour calls in a row. And then on her day off, she came to make this presentation because she thought that this was important for people to rally behind. So I thank you, Shirlene. We love you.
So if you are still here, tell your friends, the EMIM panel, if you want to listen to me and Abby talk some more, that'll be great. But most importantly, come back for Shirlene to end the night. And now we'll go to Tara.
In March of 2020, for the first time, nurses were fearful for themselves, their families, their patients, and the community at large. Nurses were in need of a psychologically safe space outside of their affiliated workplace to express emotion free of judgment. It was then, one by one, we began debriefing the front lines. We are witnessing a unique and complex occupational trauma that is affecting the collective nursing profession. The COVID-19 pandemic inadvertently brought to public light the struggles, ethical dilemmas, and ongoing challenge of providing dignified, quality patient care within our healthcare systems. 96% of nurses report experiencing at least one symptom of post-traumatic stress disorder. 21% have met the criteria for a clinical diagnosis of PTSD. This trauma is having an immediate and profound effect. Debriefing the Front Lines is a nurse and veteran-founded 501c3 nonprofit organization. Our mission is to deliver psychological first aid, sustained emotional wellness, and continuing education to nurses of all specialties. We unite nurses and alleviate suffering through the sharing of personal stories and experiences. We provide nurses opportunity for creative self-expression as an integral part of healing cumulative caretaking trauma. Debriefing the Front Lines offers no-cost debriefing sessions to nurses across all specialties. Debriefing is a structured discussion facilitated by a trained professional aimed at framing abnormal and traumatic events into perspective needed for healing. Through guided self-reflection, debriefing offers nurses clarity surrounding critical incidents and assists in establishing a process for healing and recovery. Through daily support, monthly wellness subscriptions, group circles, and one-on-one self-exploration coaching, we help nurses connect to one another, sharing the trials, tribulations, and triumphs of the profession. Create a self-care plan as medicine for the mind, body, and spirit. Identify and implement daily self-compassion practices needed to remain healthy and well over a period of time. Develop self-soothe techniques to be used both personally and professionally. Since implementation on March 26, 2020, our most popular offering remains the Healers Daily Communication Initiative, a text message of love and support sent at 6:15 a.m. or p.m. Nurses can respond in real time and speak with a trained professional to help alleviate pre-shift anxiety, making this a uniquely personal offering. Debriefing the Front Lines holds continuing education provider status. We offer a variety of self-compassion and self-development education needed to maintain compact state nursing licensure. Debriefing the front lines influences and activates the power of community. We fuel efforts that address the need for psychological first aid and emotional wellness for nurses. We help nurses find their voice and empower them to speak their needs. Together, we are redefining the physical, emotional, and spiritual needs of the modern-day nurse working in a global pandemic and humanitarian crisis, upholding the belief that our commitment to service must always include ourselves. Your generosity funds psychological first aid for nurses across the United States. Visit debriefingthefrontlinesinc.org to help heal the healers of our community.
So I just jotted down a few things that I think maybe the ER nurses don't understand about the floor nurse or the ICU nurse or the step-down nurse, etc. And I'm just going to quickly mention them. And Christina, you just jump in. Christina and Jason both, please just jump in whenever you want to start yelling. Okay. Okay. So on the floor with the especially med-surg floor, I mean, we're talking about ratios. Everybody has ratio problems, right? But I mean, I've worked on med-surg floors where every single night we have 8 patients, every single night. And that's like you take 7 and you get an 8th. And it's just almost unmanageable. Like it's just impossible. And then on top of that, you know, your tech ratios, you might only have 1 tech for a floor that's like 32 patients. And it's like that person might as well not even be there because they're just flying, you know. So
sometimes we have no techs for a whole ER.
Right.
And then, yeah.
Yeah. And I know, you know, we did a lot of crowdsourcing. I know a lot of the nurses, the ED nurses, they said, you know, well, our patients we got a lot of people who are fighting, they're combative, they're, you know, a lot of altered mental status, blah, blah, blah. Okay. Our patients are walking, they're talking, they're falling, they're yelling, they got requests, they want to eat. It's like a never ending thing. We got people who are really sick. We got people who are probably ready to go home and, you know, they have varying degrees of problems and we have to really prioritize them. And we have to keep everybody safe all at the same time. I don't know how much of like the ED, I don't know how much I mean, correct me. What do you think? Like, are you guys really hyper aware of like where you're sending in your units? Like, are you sending to the med-surg floor? You're sending to a step down? Like, is that on your radar? Like, do you care about that?
Typical staff nurses, no, that's not on their radar.
Yeah. You as a charge, it is.
As a charge nurse, yes, it's on my radar. And then I have to answer for why is this, I have the house supervisor calling me, asking me why the physician put in this bed order. Like, that's a great question for the doctor.
Yeah. Yeah. Abby, where are you going with the question? Because like that is something that like I know what floor, what service I'm sending people to.
Because I've had that problem a lot where, like we were just saying, like, you know, on just a regular med-surg floor, and then the person needs tele, and then we have to transfer them or things like that. So I just feel like there's a huge miscommunication sometimes. Like, why is that person being sent here at all? And it seems to me it happens not like regularly, but way more often than it should.
I think it happens more often now because honestly, you can get through your entire shift without ever having the chance to review anything in the chart. You only know what you've put in it and tasks that you've completed. Like, you don't have the time. You should know, if you're experienced in any kind of way, what the patient probably is going to, but the newer nurses, I don't think that they get a proper orientation. Everybody is hurried up and shuffled out, and our ratios are really horrible in the emergency department. And we honestly sometimes don't even know that you have a critical lab until lab calls you and tells you that you have this lab. Like, I don't know that a specimen got hemolyzed until the physician and the ED says, can you redraw this because it was hemolyzed? Because it's not, regardless of whatever, but a lot of times it's because you just don't have time to look at those things. So me personally, I put everybody, most patients, I just put them on tele when they come in as a patient. And sometimes I've called report to a med surg floor and I'll tell them what their tele is. And they're like, well, they're not tele. And I'm like, well, I know that, but they were down here for me. So if something happened, you should at least know what their baseline was, you know?
Right. Yeah.
You can say that when the rat nurse shows up.
Yeah, exactly. No, I
But
appreciate
no, we don't have, we typically nowadays don't have time to look at all of those things. And that comes with experience or a verbal communication from, like, because sometimes ED physicians will be like, I'm admitting them to this. And if you've worked here any length of time, you would know what the outcome was. But the newer nurses, which is what you get now, because all of your experienced nurses have not stayed in the hospital.
Right.
So I think that's part of the problem. Because if you work in a good ER with good teamwork, yes, these are my rooms, but all of these are my patients and all of these are Jason's patients. And so we're all around them, and that's not my patient. I'm not doing that type thing down in the ED. I don't know how the other floors do it, but.
Okay. Okay. Ready? We're going to fight. Are you ready?
Yes.
Here we go. Okay. Sometimes I'm trapped in a room. Sometimes I'm in a room and I can't get out of that room. Sometimes I can't take report and I need grace. I need a little bit of grace once in a while and say, okay, I'm going to call you back. I'm going to call her back in like 15 minutes. Okay, cool. Because I hear this all the time. She's in a room, I'll call, so-and-so's in the room. I'll say it to the person calling, and they're so frustrated with me. And I'm like,
yes,
they're doing wound care. Somebody's bleeding. Like, what do you want me to do? Pull them out so they can answer the phone for you?
I mean, no, I don't. But so it starts with, I can give report, a nurse in the ED can give report on a patient when we have time to do so between the things that we're doing. Sometimes we have people in the emergency department that their only job is to handle throughput things, and say Jason's the team lead and he sees that my patient has a room, he'll just call report. And because we're also getting
3 ambulances.
Yes, we're getting multiple ambulances or, whatever, but I'm also held accountable for, as soon as that patient has a bed assignment, how long it takes them to get them off of my board. And it's a 30-minute window. It's just 30 minutes. That's all I have. And if you're behind on your times too much, then the nurse is held responsible. And then me as a charge nurse is held responsible because our shift time is poor. But sometimes we call, and so it's convenient, but typically there is a long history of med surg nurses and tele nurses and floor nurses just in general dodging report. And I understand that you're at lunch, but in the emergency department, if I'm lunch, Jason can take report on a patient. Jason can give report on a patient. So I don't understand why that's not a system in place on the floors necessarily, but it's also not good practice. But but everything in the emergency department is throughput. And they're like, I've gotten phone calls from ED directors at home asking me why a patient was still in my department when they had a bed assignment, or why a patient was still out in triage when I have an empty room and it's a weekend night and it's the director and I'm in the middle of walking to triage getting someone, and they're like, why is that patient still in the waiting room? And I'll simply say, because I had to walk back to the nurse's station to take this call.
Yeah. I think that's crazy. Honestly, I think that's absolutely crazy. And I think I didn't really understand that time crunch before Laura and I started talking about it, before Laura shouted it at me.
I told her yesterday and her brain melted. It was amazing.
Yeah, I was just like, wait, what? But okay, you said something that I was also gonna bring up. And this is another pet peeve. And I love you. We just met, but here we go. If you're giving a patient and it's Jason's patient and Jason is doing something else, right? And so you're just going to call because you got this time crunch and you're going to call me, but you never even saw this patient. You don't know this patient. You're kind of reading the chart to me. I can read the chart. Like, I don't need somebody to call. And I'm like, well, is this? And they're like, I don't know. What about this? I don't know. And I'm just like, all right, send the patient. You know, I'm just like,
yes,
cool,
bye.
bye.
It's a horrible, broken system, but it's how we are expected to behave down in the emergency department. Typically, what I would do is I would go in and tell Jason that he had a room and ask if there was something I could do for him while he called report. I like to stay after my shift to try to give report to the ICU nurse that's actually going to get the patient so they can get report from the nurse that actually had the patient. Not everyone cares about those things.
Yeah.
Like, people stop being human, and I just have a job to do, so I don't get yelled at, and so I don't get my 9 cent an hour raise this year. So
yeah,
but, you know.
Yeah, I think you're right, and definitely with the when you're talking about you're calling, why can't somebody take report if the nurse is at lunch? You definitely can. I do that all the time, and there's no reason. My only caveat to that is I say, like, but the person is at lunch. I don't want to accept this admission for them. Like, can you just wait 20 minutes? You know, I'll write this down. I'll communicate it to them. You can send
and
them
I've
later.
had conversations with the floor nurses that if you just take reports, then I can trickle patients up there. I know as a charge nurse, I know which floors are getting hammered, and I know that we just sent you 5 admissions. If you would just take report, because that's one less thing that my nurse has to do now. And I, down in the ED, sometimes those patients, if we have other critical patients, will get moved out into a hallway. And because all they're waiting on is for me to decide the floor's had enough time, or me to talk to the charge nurse upstairs, and they're like, we can take another one, you know? So I can manage those patients, but, you know, but it takes it off the table of something that, you know, my coworker has to deal with. And now I can put a new patient in their room. Does that make sense?
Yeah, definitely. Yeah. And I mean, so when somebody is like, we don't just get admission from the ED, right? Like, especially a floor, like we get downgrades all the time. So that's another problem too, where it's like, yeah, maybe the ED doesn't think we're getting hammered, but we are, you know?
And PACUs.
And PACUs
and transfers and direct admits.
When your charge nurses and your house supervisors and your other charge nurses should all be communicating with one another, because I can, as a charge nurse or a house supervisor, I can relieve what's in my power of pressure on the floors for a certain given time. I can make an argument for you. I've made arguments, you know, I'll fight your battle for you because it makes sense. I just need to know what battle I'm fighting. And then we were put back in every hospital I've worked at. I've always been put in a position where I then not only, it's because it's a tattling environment, I now have a logbook, and my nurses are supposed to put a patient sticker in it. And every time, the very first time the floor can't take report, they put that patient sticker, what time they try to call report, and the reason they were given to, and so it just became, and I'm like, I don't have time to half the time do half the things I'm doing right now. I definitely don't have time to go print out a sticker and stick it in this book. So, but we're encouraged to do that. And
then write an incident report.
And then I write an incident report. And I'm not writing an incident report because somebody doesn't take report. Like, if you just call, like, I've called the floor and they're like, they're in the middle of like a code brown, or they're doing wound care. I know you're going to be a while. I know that that floor just got a code or a rapid response called on them. Not everybody's patient with that. And that's, and it's sad that that's just how people.
Also, not everybody's a charge nurse.
Yes.
You know, the ER nurses don't know all the stuff that you know about the floor. So they'll be even less patient about it.
Yeah. If I get called for report, I do have a little bit of leniency, right? And that's where, Christina, I think you're talking about, you have seen people dodge the phone. I've seen that too, right? I mean, we've all seen it.
And they hide clean beds from the charge nurse.
Right. But I do, if I am seen as delaying care, then we have a big problem. Then, I mean, I could be written up. If it's a pattern, I could be fired for that. It's a huge problem for me. So I do have to be careful. I can say like, oh, sorry, whatever. Oh, I missed that one, whatever, once in a while, but I can't make it a consistent thing. And it can't be like 3 times they called and I'm still not picking up the phone. Cause then at that point, in my experience, I've seen nurses do that. Nurses who are just real burnt out and they just, they're like, whatever, like I don't care. And the ED will just send them at that point. And it's like, well, now you're just not getting reports. So that doesn't help you either.
If you start dodging, I'll have my nurses come and give you a bedside report. Like I'll take your rooms while you go and do that. Cause I need that patient out of here because I need that bed.
Right. Yeah.
But if I don't need a bed, cause I can make a lot of beds come out of nowhere, it seems sometimes. But yeah, like I really have to need that bed to be that shitty to somebody, or they just had to be really shitty for me to want to like counter that. And then I'm just like, I don't want to deal with that.
Yeah, definitely. And I think that's another thing I think is a common complaint on the floor is like, we don't have a bed or the bed's not clean. And like, sometimes I feel like the ED doesn't believe us. They're like, that's not true. And I'm like, I'm looking at it. Like, I'm really not lying to you. I'm sure people do lie, but like, I'm telling you, I don't have a room. I don't like, and then it's another problem where if we're talking about EVS, who is like so overworked and underpaid and understaffed, like ridiculously. And we have like 2 people, 2 people cleaning for the whole hospital. And then it's like, yeah, the bed's still dirty. I don't know what to do.
I've sent my ED EVS people, I've asked them if they would go and clean beds for me upstairs to help out. Cause I was full of boarders. What were they going to clean?
Right.
So I asked them, and I ask for forgiveness later from whoever gets mad at me for sending my employees to the floor.
We also don't have those resources to make some of those moves either. We can't be as creative, right? And we have a lot of those like staffing pressures of other departments. So like I just said, like if EVS is short, like I'm pulling my own trash. Transport is short, I'm a transport person now. Like pharmacy is short, I got to go down to pharmacy to get my goddamn meds. You know what I mean? It's just like, it's a never ending thing of like, I'm doing everybody else's job. We don't have a unit clerk today. I'm answering the phone. I mean, on night shift, I have to physically make my own charts. I have to scan, copy, fill out documents, print stuff, labels. I got to put the thing on the door, like the stupidest things that I should never have to do. I have to do all this stuff. So yeah, when they're calling me for an admission, I'm exhausted and I got 7 patients. I get it. It's not okay, but I'm saying I understand why somebody would want to be like, I'm going to wait. I'm going to take the second time they call me. I'm going to take report.
And then sometimes while you're waiting, because my patient's just waiting on report, I now have an extra patient. So I'm still having to take care of the patient that's being admitted that I want to give report on, so they're not mine anymore. But now I also just got some critical ambulance. So now I'm going to be stuck in there, and I am responsible for the patient that's sitting in the hallway waiting on me to give report because that's what they've decided to do.
I know that it is a joke, right? About the skin. I don't care about the skin. I see that on like Code Blue memes all the time, because I think he's an ED nurse. I'm sorry, but if we're going to talk about metrics, I really care about the skin a lot because we have to, I mean, Christina, I'm sure you're very aware of this. We have to document, was there a hospital acquired pressure injury, or was it there like in the ED or an on admission? And like, God forbid I miss something like that. I could get fired for something like that. It's a huge problem. It's a huge nursing metric that would be missed. It would be like a unit. I've seen it happen and like the whole unit has to have a meeting, and the person gets called out, and it's really bad, and then the hospital has to absorb the costs and all of this stuff. So but I think we have a tendency to only, whatever department you're working in, you have a tendency to see from your perspective, like, can't they see how overworked I am? Can't they see how overloaded I am? Right? I think we all kind of feel that way when like it's happening to everybody. And as you were talking, Christina, like I jotted this down in my notes that we're accountable for everybody else without anyone being accountable to us. That's how I feel. And I think that's what I'm hearing from you also.
Yes.
I agree to that too.
Mm-hmm.
Yeah.
Yeah.
You haven't talked about the IVs and the AC.
They're coming. I'm not. I'm not stopping those.
We'll get to it.
If I'm nice, your second IV will be somewhere more appropriate, but your first one it will always be in the AC.
So I'm
not in the AC, it's in their neck. Like those are the two places. Because everything that I do in the emergency department can be done in those two accesses, and anything else I'm going to have to do extra work later that I might not have time for. So I know that this is 100% good for anything that they might be here for, like from meds to CTAs to anything. So that's what you get. I know that I can get blood off that line later, like all the things. I don't like them when I have to go start doing a sepsis workup on you, but when I do my sepsis workup on you on my second blood culture, your IV is going to be somewhere more appropriate, hopefully, if that's what you have. So, yeah, because I don't always have an ultrasound. I don't always have someone that can do an EJ. Like I don't always have someone that can come in and put a central line in, even though this patient really, like, I don't have IV access to come and do, and I work with a huge dialysis population. So at this point, you get what you get. But in most situations, it's because that's the quickest, fastest, and it's the access that I can do 100% of my job through. So why would I do anything else? Because
yeah. I don't personally have this gripe as much as I heard it a lot when I was crowdsourcing. It was like by far the number one complaint of the floor nurses. Like, stop putting an IV in the AC. I hate this. Like, I hate it. I don't have a problem with it if you also place a second one. I got no problem. You want to be super efficient, like, go for it. It is, especially, my only complaint is when the patient is getting a bolus and, Michael's not my doctor, so he doesn't immediately DC it. And then I have, and then I have like all of these other meds. Because the second I take an admission, now I have all these new meds, the floor, just put in. So I got to start all these antibiotics. I got to do all this stuff. And I only have this one IV and I got all this stuff being pumped into it. And it's like, well, now what do I do? And like, I get it. We can start an IV. And I think that's a fair critique of the floor, is that, we could be better about that, there's no reason why a floor nurse can't just like pop an IV in quickly. But I think some of the floor nurses, they feel like maybe they're not as good as the ED. And like, also, again, we're just like all so overworked. It's like, now not only did I just get an admission, I might not even have got to round on my patients before I took this admission. And now, I got to give all these meds, and now I got to stop what I'm doing and put a line in when like this person might not have good veins, or, what, maybe I'm intimidated a little bit to place it,
Right. And when that patient came in, like, you don't know what they look like necessarily. And like, it was a time critical line. Some hospitals have a policy that if you have an AC line within 24 hours, that line has to get pulled. EMS line, all EMS lines are usually 95% of them also in the AC, because they have the same time critical thing and have to be super efficient like we do. I do think that the emergency department needs to be a little more cognizant of what the floors have to deal with. And I've always been a proponent that during like an orientation or whatever, you should have to spend at least a shift just to see what they have to go, so you can appreciate their side of things, so you can do little things that might make your life easier. and the floors should come down to the ED during their orientation for a shift or two. So you can see what we have to do, just like Laura had to shadow the charge nurses. Like if you see what we have to do, as screwed up as it is, you can have an appreciation to why we are how we are, and then we can be a little bit more, forgiving to one another. And when we have extra time, instead of, doing whatever, we can think about you and go and do those things that will make you a little less complicated.
I think
ED nurses are learning where to put IVs now, because now we're holding patients for like 110 hours down there. So they've started to make changes in their practice as well.
Yeah. I think that's a great idea. I think we should all have to do that. I mean, I think that should even be extended beyond nursing. Like you're saying, Laura had to follow the charge. I think everybody should have to do that, because it's much harder to blame when you actually know what's going on. Okay, so I want to get to, I made a little list, things that are difficult for the inpatient nurse. I just want to read a couple of these. Stop me, Christina and Jason, if you want to interject. Transferring patients at shift change, or sending all of them at the same time, 7:30. What's up? What's going on with that?
So here's my theory. My theory is that, because we get equally pissed when we've sat on this patient and all of a sudden it's 6:30 and I'm trying to wrap up a pretty little package for the night shift or the day shift, wherever I'm working. And I'm trying to get all of my stuff done. And I know as soon as I get to bed at 6:30, the nurse upstairs is not going to take report.
Mm-hmm.
I don't know why all these beds become available at shift change. And my theory is because of staffing. So we have all these empty beds, not now, but we have empty beds, how it used to be, empty beds, but we didn't have staff for them. But now we know that staff's coming in at 7. So now we can open up all of these beds. And so I think when you're talking about staggering schedules, the floors in the emergency department, the patients that get admitted, the units that admit to the hospital, I think should be on a different schedule than the floors.
Yeah.
Because it just becomes a huge clusterfuck is what it is. Because like respiratory therapy in where I've worked usually has it pretty good, because their shift starts and ends an hour before the emergency
6 to
department.
6,
So
right?
there's not an overlap where everybody's gone at the same time between the nurses and the RTs. And I think the floors should probably adopt, and the ED should adopt something like
those
that.
are out of the box types of things that, that the frontline people should bring up to administration. And if you have a receptive administration, stuff can change.
They would never do that at my job. I know that they would never do that. It's definitely something, this is not like a new concept for them. They would never do that. Okay, so promising patients that they're going to get things when they quote unquote get to the floor. I hate that. It's my biggest pet peeve. The patient comes to me and now they're waiting. They want all this stuff from me and I can't do it immediately for them. And they're so frustrated because they've been waiting downstairs 3 hours to eat or something like that. And I don't even have a diet order in yet. And it's like the worst. Okay.
You're saying ED nurses are doing that?
Yeah. The patient comes.
I'm used to physicians doing that to us.
I'll take that one. That one's on me. All right.
All right. Well, stop it, Laura. Okay. Okay. All right. I know a lot of people complained about, no allergy bans, things like that. I mean, I think there's a level of what's appropriate to cut corners and things that aren't. If this person has a latex allergy, like I need that information. I think that's important. Okay, so no report / surprise drop-offs. Okay, does anybody here, or have you ever worked at a place where the the nurses were not required to give report? Yeah. What do you think about that?
I think it's bullshit.
So we agree too much, I think, to fight with each other. Okay. All right, fine.
No, I think it's absolutely ridiculous that you don't feel like you should call a report on your patient. I think that it's absolutely ridiculous for you to feel that it's acceptable to send a patient to the floor with absolutely no warning and no idea of what they're getting.
I can't, I couldn't agree more. I can't imagine a world.
Yeah. I've had hospitals that I've worked at that it's the inpatient's nurse responsibility to call me for report, and you have 15 minutes to call me from the time that you get a bed assignment. And if you don't call me, I have the ability to send an S-bar with the patient up to the floor with them. And if you have any further questions after that, you can still call me. That's been a policy at a hospital that I've worked at. And that's been completely acceptable to everybody. I will say that that hospital, I probably had the most inpatient nurses calling me for report than in my entire career.
Yeah.
But
yeah.
But I also, then are you the nurse that buys into that system, or are you, I wouldn't buy into that, but I mean, I'm different. So
yeah. Yeah. Okay. This is a big one. The patient pooped in the elevator.
That happens.
They do.
They do.
Do
all
they?
the fucking time. I mean, all they do it all the time.
Do they?
They absolutely do. They absolutely do. And trust me, when 10 minutes ago, I just cleaned them up another time. And I feel so horrible when I show up, and I will offer to help you, the patient, but I'm just like, I'm really sorry. Like,
okay.
I swear. But I will say that I'm sure that it's been lied about as well. But it definitely does happen quite more often than people would even imagine.
Okay, fine. I'll just leave that one right there. Okay, fine. So, just some things, a lot of the med surg nurses in general, I think they just feel, and step down as well too. I think a lot of the nurses that aren't the ED or the ICU, they feel like they don't get a lot of respect. No one really takes them seriously. And we have such limited resources. We don't have always a doctor on our floor. It's it just, in general, I guess I just wanted to give the vibe sometimes of like how people feel. People just feel kind of like beat down and like no one really cares about their unit, or
This is true. When COVID started at a hospital that I worked at, we were at a very low census, and so we were having another unit help, like, so they didn't have to go home and not get paid. They were coming to the ED and being task nurses. And we were really ugly to them because they were just med surg nurses. And I might have had a very interesting closed door huddle conversation with my coworkers before we went out, because when you want the med surg nurse when you have a med surg hold, because you don't know what you're doing. They know what they're doing. Like, they know how to manage all of that.
Mm-hmm.
They don't want the ED patient. It's just like when the ED doesn't want an OB patient. They want the OB nurse. Like, you want those people when you have those. So you can't treat them that way when you invite them into your, and this is what I told them, when you invite someone to your house, you can't then turn around and treat them like shit. Like,
right.
You just can't. So you have to respect what they bring to the table, and you can't expect them to have the same skill set as you. We are raised in very different environments, but it just needs to be some type of mutual respect. And I think that goes back to, you should go over there and see what they do, because we would float you over to like a CDU unit or something, and you don't want to go over there because you don't want so you have some respect for them. So you need to acknowledge that when you're being shitty.
Yeah. Okay. All right. So I just have some little tips in case there's any ED nurses, if they want to help the inpatient nurse. So obviously a lot of this stuff is going to go for everybody. Please have patience with us. We're trying. Please start the treatments for the reason why they're getting admitted. For example, please hang the first bag of antibiotics. It helps a lot. And there's a lot of delay of care with that. If you can, there's always going to be those patients that do have to come right immediately, right? But if you can, try to just be mindful of when shift change was. And if you can, work around that a little bit, let the person just at least get their feet on the floor and see round on their patients at least before they get a new admission. If there's if there's an emergency, if we're coding somebody, it's the same as you guys. Like, I can't take report, right? You're going to have to call back. That's just the way it is. Sometimes we don't get a full set of vitals. The one that they'll give me on the floor is like 4 hours old. If anybody wants to send a patient, they should be putting a new set of vitals. Like, I should know what's going on with that patient, and know what's baseline. So I actually know what I'm looking at. A big one for me is pain meds. Like, please, if that person is there for something, a fracture, something like that, please give them some pain meds, because it might take a while, and a lot of times they don't come to the floor with a PRN order. And I think that's probably a miscommunication between the doctors or something, but they will just be like useless, and the person's screaming in pain. And that's my worst. That's when I feel like most inadequate as a nurse, is like the person is screaming in pain and I can't even get a hold of the doctor because, she or he is running around probably admitting somebody else on a different floor. I don't even know how to get in touch with them. It's like really, really difficult. And yeah, if you can give your own report on your own patient, like, please do that instead of calling for other people. That's all from me. Okay, now it's your turn. You go.
My turn.
Yeah.
Oh.
I crowdsource a little bit of stuff from the ED nurses. You don't have to go step by step for this if you want, but if you just want to read them, whatever you feel like resonates with you, because I wanted to make sure that we included your department. I don't want it to be all.
I'm probably the worst ED nurse to have do this, because I think the way that we do things is just totally wrong.
I know. So I crowdsourced some of this from one of our former colleagues as well. You might be able to tell.
Yeah. Oh, I'm sure I will be able to. Throughput is everything. It absolutely is. And it has nothing to do with the nurses. It has everything to do with the people in the office. And I have absolutely no control over that. Absolutely none. I'm getting hounded by directors or managers. Why isn't this? Or yes, throughput is sadly one of the top goals in the emergency department. I'm sorry. Patient caps aren't a thing. No, we don't have patient caps. There's no set number. If they're unstable, we do still take them. Jason and I have worked together recently, and between the two of us have 8 patients, but 7 of them are mine because one of them is his. And that was just because that's what I did. But he had a neuro TPA patient, one-on-one patient, and he could not take care of his other patients. Nobody else thought this was an issue in the department. And so I just absorbed his patient because that's what I do. And was it unsafe for me? A little bit, but what happened was just the bare minimum was getting done on each 7 patient, because they were all emergency patients. And I'm one person and I can only be in one room. So no, there's no caps. Absolutely none. I've worked 2 traumas at where I worked with Laura in the same room. I've answered a trauma call, another EMS encode, while I was in the middle of starting a line on a critical trauma patient. And I still have to figure out where that patient's going to go. And the nurses still get the patient. Like, I don't have extra nurses and I can't make unstable patients wait. Like, or you can come to another ER that I worked at that let unstable patients wait and they died in the waiting room. So it's a horrible situation. And yeah, that goes back to the TPA, TNK patients. Upstairs for the floor, that's a one-on-one patient. In the emergency department, that is a 1 and the rest of the patients that you have. So when that's what we're dealing with, and then we call to try to give a report and you're like, I'm at lunch. It just really kind of rubs us the wrong way, because we've just been trying to not drown and let our patients become harmed because of what they're making us take. So yeah, that's what we're doing. And yeah, this mindset is completely different. If it's not killing you, I don't care. I wouldn't say that I don't care. You're just not a priority right now. If you're not actively dying, and I have actively dying patients, you are not a priority to me. That's just how it is. I don't know how else
That's triaging.
yeah.
Basically.
And so, and it's triaging through your entire patient assignment is what you just keep having to redo. It's not that we don't care. It's just that we had other things that took a higher priority, not your admitted patient that you wanted me to give meds to. Like, and so how we think is once you're an admitted patient, so it's kind of what our philosophy is I have patients that haven't been treated or evaluated by a physician at all. And then I have this one that's been through my complete emergency department workup and now is being admitted for a doctor. So you're no longer in my list of priorities, a priority to me anymore, because now I have 3 ED patients. I think that they should definitely be separated because you shouldn't have to work like that. You shouldn't. I've been put in a position where I've had to readdress how I was giving care in an unsafe environment based upon a code status. That's not appropriate. I don't work there anymore. And so, but because that was just a common thing. But yeah, we don't have nurse ratios in the emergency department. And now the ED nurses are getting really mad because when the travelers come in, not that we have anything against the travelers, some travelers have ratio limits in their contract and they're taking less patients than what we're expected to take. And nobody seems to have a problem with that. So if you don't have a problem with these nurses only taking like 3 critical patients, why am I still having to take 4? Like you've set a precedent saying that you don't care and you'll even pay more for that, you know? But, and then like that, we have ICU travel nurses that come down in our emergency department, which has worked really well because those patients aren't going upstairs either. So they're just, but they have a 2-to-1 ratio down in the ED. I've had multiple times 4 ICU patients and just me, and at the same time. So, the ED nurses do not have a cap on acuity. In the great state of Texas, where I am now, we have this nice little safe harbor law that you can declare before you accept an assignment, saying that basically your license is in jeopardy, but you're not responsible for any poor outcome that might happen because of your staffing assignment. And it goes through the Board of Nursing and it's an immediate thing. But as far as I'm aware, I think Texas is the only place that has that particular safe harbor. There's a lot of rules to it, but yeah, no, if you're not actively dying and someone else is, you're not a priority to me anymore. We don't ask questions that aren't relevant. I don't care when your last bowel movement was, unless you're there for something that's relevant to bowel movements. I just don't. Of the laundry list of things that I have to do and ask you, it's not a priority. I do my skin assessment when I get you naked and put you in a gown, and the first time I have to roll you to clean you up or whatever. Because we sometimes, more often than not, get all of our patients at the same time. I'll get in 4 rooms, 4 patients within 20 minutes. So I have to prioritize what questions I'm doing and what treatments I'm doing and who I think I need to go get a doctor for instead of letting them wait. And yeah, we don't understand the excuse of I just got a patient. Like, I don't know if when I try to call report, you're like, well, I just got a patient. I don't know if you're just like venting at me, like, okay, because we always are just getting patients without warning. Like that's just, but so we don't understand what you guys what inpatient side goes through, because that's our entire day is I don't know what I'm getting in the next 30 seconds in my room when it shows up. And half the time, EMS or whoever might not even be able to tell me. And it's just this, we're going to have to figure this out. Patient's nonverbal. They don't speak our language. Like I've been in a situation where we accidentally kidnapped a Mandarin Chinese speaking woman because they thought that she needed health care, but she didn't. They just didn't have her language and they just scooped her up and brought her in. That was a cluster. That was a lot of apologizing on my part. But so it's not, we don't ever get the information either. So we don't understand why you can't function like we do, basically. But
Yeah.
it's an unrealistic expectation on our part.
Yeah.
We're just like, we don't get it.
Yeah, because
this is our day to day. This is every patient. If
Yeah.
I knew, and then when you work in like a larger city, you don't even know the ambulance that you're going to get because it doesn't come through. Like a lot of ERs, the particular ambulance will call the particular hospital and give a report. In larger cities, the ambulances call dispatch, and the dispatch just tells you you're getting an ambulance in 10 minutes. They don't give you anything.
I get that, but like our admission and our paperwork and stuff, it's like so much different, right? And we can't cut corners. We have to be accountable. So it is like totally different to like just be like, oh, I'm gonna take 3, it's like totally different.
Yeah. And Abby's taking a patient with like 80 admission orders.
Yeah. Yeah. You guys have any closing thoughts? You have any well wishes? You want to say who won?
I did. I showed up.
I think
Actually, you're the winner. You actually are.
Like the ER may have lost. I didn't do great, but Christina wins.
Christina wins. Yeah. Maybe I am overall is going to win though.
Well, I will save my fight for I don't know, Twitter or something. That seems fun, right?
Yeah.
I think everyone wins and everyone loses to a certain extent. I mean, I think we could all extend each other, and maybe that's me copping out. That might be me copping out. But I think we all are a little bit losing based on the system we have. And we're all losing a little bit based on the fact that we don't have what we need. And I think maybe we're also winning because we're all doing the best. This is like so cheesy. We're all doing the best we can with what we have. And we're trying, and we're here, we're trying to make a difference.
Aw, I love that. Love you. That's so sweet.
Aw, me too.
There shouldn't be winners and losers in a hospital system that we're all trying to work together. Now that's cheesy.
Oh, I like that.
I like it.
I also like that because I'm pretty sure I lost. So Jim just gave me an out. I mean, I do think that's true. Like, I think right now the system is, we're losing. I mean, I think healthcare workers are burning out. I think patients are getting bad care, and that shouldn't be how it is. Like, it should be that all of our patients are winning and that we like our jobs. So maybe we all lose, but we're all winning because we're.
Well, actually, I'm amazed that patients, how good care some patients get despite everything, and I think that's because of the healthcare workers and the dedication. I mean, it's just. We do so much more than the system really supports us doing, which is why patients, do as well as maybe they wouldn't do as well if we didn't go above and beyond. I don't know how long it's going to last.
Yeah.
Yeah, I think that's a really good point. I'm really glad you said that because, I mean, I think people are pulling heroic things just like out of their like asses.
Especially with COVID. I mean, the heroes, as much as I can't stand that, as far as the way it kind of is going with, we actually are heroes.
Yeah. I think that to me is why it's so frustrating to see healthcare workers when they are taken advantage of, because like to Christina's point, like we do have people who are going to stay clocked out an hour late. We do have people who are going to just, I've punched out and helped my coworker because they're just drowning, in admission. And that's why sometimes we're vulnerable to be taken advantage of because we are those types of people and we want to help,
Most people don't dump on each other in the healthcare world. I have found that. I mean, my colleagues, I can't think of any of my colleagues who dump on the other person.
Yeah, if it even looks like we do, we feel so guilty about it.
Yeah.
Actually. So
yeah, I think that's true. And I mean, I think, and that's something I do want to, I guess, close with is I think it's easy for all of us to get frustrated with the circumstances we're working in. And I think we should be frustrated with the circumstances we're working in, but it's also like, this is a great fucking job. Like, this is like, we get to do the coolest stuff in the world and like actually help people. So, I mean, it's frustrating. And I think the fact that we're all here is testament to us loving our careers and wanting it to be better. Violet on this.
Okay, well, hey, welcome back. Thanks so much for joining that. So who do you think won? Emergency? I am. And the more important question, are Laura and Abby still friends after that, guys?
I'm also fighting with Violet now, so
Oh.
this is really kind of
Okay. Hear me out.
So I have no friends left. So next.
Okay.
All right. Sorry, we're back.
Okay, sorry. It's me, I guess. Okay. So next we have Shirlene, who has the amazing novel On Rotation. It's going to be out in summer of 2022. She is a cardiology fellow. She is a cartoonist. She is smart as heck. She is amazing, fun, funny, beautiful, stylish. I just love her.
Cool.
I'm obsessed.
We said earlier this was an Abby fan project. It's not. It's a Shirlene fan project.
Shirley.
This is all about Shirlene.
This is who we love, and yeah, we support it. Yeah.
I hope she's watching and thinks we're really creepy now, because I feel like that's good.
I'm going with it. Yeah.
Okay.
Anyway, without further ado, Shirlene, take it away.
My name is Shirlene. I'm a cardiology fellow at the University of Chicago. I'm the creator of Shirley World MD, a graphic medicine platform on Instagram, Twitter, and Facebook. And today I'm going to be talking a little bit about resident training and how it creates physicians who don't really know how to advocate for themselves. I'm going to quickly go through these objectives because I think this talk is going to go a little bit long, but mostly I'm going to be walking you guys through what the path to a doctor is and kind of how I got to this final point and how we can fix things. So this is me circa, say, 2010, applying for medical school, super excited about it. And like many pre-meds, if you asked me why I wanted to be a doctor, the crux of my answer would be something like, I like science and I want to help people. But there were a couple things at play that maybe were less spoken. One of them is that, I'm a Ghanaian immigrant. My parents, like many other African parents, recognize 3 professions: doctor, engineer, lawyer, and I decided to go with the doctor. I also was 18, and so 10 years of training, 10 plus years of training. At the time, I didn't really know what that meant and what that would entail. And so it seemed like a small thing to pay, price to pay. Medicine was very familiar. The pre-med track is very well laid out as compared to other tracks into other careers. And finally, I hadn't really investigated other professions that help people. Regardless, I meant well, and a lot of pre-meds who kind of come in wanting to be doctors generally mean pretty well when they choose to pursue this path. It's a pretty winding, long path. Full of lots of stopgaps. So this picture that I kind of stole offline outlines it somewhat. So that all these various paths, but really I would like to think of them almost more as barriers because, the whole purpose of medical school training is to weed people out, right? The weeding out starts really earlier, but let's start with in college with organic chemistry, where, you got to have like a super high GPA to even be competitive for medical school. And Orgo was the place where lots of people got cut down and there was a lot of crying in the lecture halls. After that, you have the MCAT, and a competitive MCAT score is around the 85th percentile to get into medical schools in the United States. So there's 85% of people just out. Step 1 is now pass fail, but previously it was the kind of test that if you only had one opportunity to take it, and if you didn't get a high enough score, you were cut off from your chosen specialty, potentially for life. And shelf exams and all of third year would go into this. You had to do research on top of it to be competitive for a lot of specialties, and especially competitive for more elite medical institutions. And then finally, after you did all of this, maybe you could end up being a resident. I'm leaving out another big part, which is the debt. Costs a ton of money to become a doctor. So this is from the AAMC, just looking at the debt burden for people who do have debt. And I'll make a note that there's a significant portion of medical students who have no debt, and that is because their parents pay for their medical school or their family pays for it. And that is a super it's a point that I can get into at later times, which is that medicine is really only accessible for the wealthy. There's a big problem with that too. But for those of us who are not as wealthy, the mean debt is around $200,000. And this is, when I break it down by public-private, you see that it can even be higher than that. So you can see that the median debt for people who go to private medical institutions is $330,000. It's a ton of money. And this has only gotten worse over time. So tuition is also only the surface of this issue. The cost of applying to medical school is incredibly steep. It's about $10,000, including the cost for applications, hotels, flights, etc. Residency is also can be equally expensive, around $4,000. That's around the average, and goes much, much higher if you're applying to competitive specialties. It doesn't include exams. It doesn't include the cost of study materials, and all of these are fairly necessary because medicine is so competitive. Even once you're in, that deciding not to pay for a certain study resource may actually be super detrimental to your career. So, really, and keep in mind that medical students aren't making any money while they're in medical school. It's a kind of a schooling that requires it's a full-time job in and of itself. So. Can come to be incredibly expensive. Now, a lot of people like to refer to medical training as a bottleneck. I think that's not quite accurate. A bottleneck implies that it might be slow, might be sluggish, might be inefficient, but everybody eventually kind of gets through. And medical training, I think, is more like the Hunger Games. Really, it's a survival of the quote unquote fittest. And empathy for your colleagues really doesn't have a place in it. Especially fairly early on. In fact, you're incentivized not to help each other because the competition is just so stiff. Now, what is this all leading up to? It's really leading up to the match. Now, the match is when we are applying to residencies, we interview at a bunch of institutions if you get lucky. Then you make a rank list of the institutions you would like to attend. The institutions make a rank list of the medical students they would like to attract. It all goes into a magical ERAS box. And then on a fateful day in March, everybody opens their envelopes and finds out where they're going. Unfortunately, the match can be tragic for a lot of people. So of the 78.5 registrants, only 78.5 of the registrants to the NRMP actually matched to a residency, which left 21.5 graduate physicians without a training position. That means that we have a bunch of doctors just sitting around who've been trained, who've gone through medical school, who've made all the sacrifices I just named, and they never actually get to practice, or they have to apply multiple times before they get an opportunity to. I know a lot of people will say, oh, well, some of these are IMGs. First of all, a lot of IMGs are already trained physicians in the countries they're coming from. But secondly, even when you look at allopathic US medical schools, you find that, it's still 5% or so of medical school graduates are going without a match. And without a match, you can never become a clinician. So as you can see, the stakes are incredibly high. Like now you have all of this debt and there's no way for you to pay it. Now, part of the reason why I'm bringing all of this up is to show you that, the methods, the reasons why a lot of physicians learn to not to self-advocate for themselves is because it can hurt them, it can be genuinely detrimental into their career in this incredibly competitive environment. So one of the ways that this comes up is during the third-year clerkships. So third-year clerkships are a time when medical students are judged or evaluated by their attendings. And a lot of times those attendings, judgment of them can really determine what happens with their career. So for example, we have clerkship grades that are broken down into honors, high pass, pass, and fail. And back in the day, for a lot of our attendings, a pass or a high pass was like a perfectly respectable score. However, now things have gotten so competitive that really, if you want to get into a specialty, you would like people try their best to get honors in those specialties. There's less room for error. So I'll give you guys an example of something that happened and why this is important. So I had a friend back in my third year of medical school who did a great job in her surgery rotation. She talked to her attending afterwards. Her attending said she did everything right, like no critiques, you were wonderful, you did everything right. And then she got her grade and found that she got a high pass. So my friend, being alarmed, decided to go to the attending and ask, hey, I saw that you gave me a high pass on my clerkship and I asked you for feedback. You said I did a great job. What did I do wrong? What could I add? And why didn't I get an honors? And the attending said very simply, well, you just lacked a certain je ne sais quoi, right? This quality, right? You just didn't have it, right? And so here goes my friend heading over to apply for residency positions. And she says, hey, I'm like really interested in your specialty. I've applied, I haven't heard back. I'd really like an interview. And the program director is like, we only interview people who get honors. So sorry, like you didn't get an honors. You don't really get a chance to even show your stuff, even though you were, at least even subjectively, were an excellent student. And this has consequences. There's a lot of mistreatment in the medical field, unfortunately, and up to 63% of medical students have noted in surveys that they are the victims of workplace violence. Workplace violence being defined as sexual harassment, intimidation, physical and verbal abuse, etc. And these rates are even higher in marginalized communities. However, most of them don't report because the stakes are too high. They have too much to lose, and the retribution could be devastating. And I'll tell you another story. When I was a medical student, it was early in the Trump administration, and Tom Price had just been appointed the head of the Department of Health and Human Services. And several physician committees and organizations, including the AMA, came out with statements endorsing this because they were just glad that a physician had the role. However, as we all know, Tom Price is kind of a scumbag. And so I was really involved in Physicians for a National Health Program, and a few of us put together a petition. One of my friends sent out the petition to physicians in our community saying, hey, like, can we please say that we don't agree with this? And a prominent physician in our institution sent her back probably one of the cruelest emails I've ever read in my life. And then sent a message to our dean saying that this student should be punished for her lack of professionalism, for sending out a petition he could have just scrolled past, right? So luckily, our dean at the time was very understanding, and so she was not punished for this, but it was a real possibility that if we'd had someone whose viewpoints aligned a little bit more closely with that attendings, that it could have had real professional consequences for her. So let's go back to where we were. So where we were talking about the match now. Let's say we've matched into residency. So what happens in residency? Residency is a 3 to 7 year long training program, and there's no ability to negotiate your contract. You basically, like, you sign up, you get matched, you go where they tell you to go. Very few residencies offer any kind of benefits that are worth talking about. So 401k, sick leave, maternity leave, paternity leave, etc. And keep in mind that by the time we're coming into residency, most of us are over 25, at an age where thinking about starting families is a thing, and where we should really be thinking about things like our retirement and saving for our retirement. We're not really able to do that during those years. There's also very little flexibility for life events, and kind of given the hours that are involved with residency and the lack of flexibility, it's almost inaccessible for people with disabilities. There's also, of course, a significant mental, physical, and personal cost to doing a residency program. The biggest of all is sleep deprivation. There's increased rates of depression, pregnancy loss, and infertility, as well as motor vehicle accidents that are associated with this. And unfortunately, the study that I was talking about, was published in JAMA, still didn't really have a very great take on how to fix this. They were like, we should just take 30-minute naps throughout the day and drink some coffee. 20% of medical residents also meet criteria for clinical depression, and 74% for burnout. And some of this it makes sense. Like before COVID, many of us didn't call in sick, even when we were sick, because we knew that taking time off would cause issues, force our co-residents to have to cover. All right, so who came up with this brilliant system? So these two mustachioed gentlemen are William Osler and William Halstead. So they kind of existed around the same time, and were friends with each other. So under Dr. Osler, residency was very literal. Physicians actually lived in the hospital. They almost lived like monks. They were encouraged not to be married. They ate their food in the hospital, et cetera, et cetera. And the main thing that Dr. Osler did was encourage thoroughness and patient-centered care. He wanted the students and residents to be taught at the bedside, really champion the physical exam and history taking, et cetera. Then we have Dr. Halstead, who really came up with a lot of the traditional, especially surgical residency structure, with a bottom base of a larger group of interns, a slightly smaller group of senior residents, and then a chosen few chief residents who kind of ran the show. He was a champion for safe, methodical surgical technique, especially like surgery that was dependent on physiology. But he also had a really terrible cocaine addiction that he tried to cure with morphine. And it's actually postulated that part of the reason why he developed this structure was to cover for him, because with chief residents and senior residents kind of running the show and doing operations, he could disappear to get high or to recover or withdraw. And he did this. He had an absence actually that was 5 to 6 months long. The board of trustees tried to reach out for him, he ignored them, and he almost got in trouble, lost his license, but his residents did all the surgeries for him, so he had his butt covered. But also things were different back then. Back then, physicians in the United States were predominantly able-bodied white men, and actually Dr. Osler's and Dr. Halstead probably wouldn't be super happy to see me being a physician right now, given some of the things they wrote back then. And they encouraged people to be unmarried. Importantly though, they structured residency in order to center patient-centeredness and attention to detail. And that's something I think that we're kind of missing today. We really more emphasize throughput and efficiency. So you guys probably have heard of duty hours and you're like, whoa, 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 it's not like it was back then with Osler and Halstead. What about duty hours? Those made things better, right? And I think talking about duty hours is like talking about pineapple on pizza. Some people love it. Some people absolutely despise pineapple pizza. But let's break down what duty hours really are. So they were put in place by the HCWs starting in initially really like in 2003 thereabouts, but it was set off in 1984. I'll get into that in a second. Regardless, what those rules are that residents can only work 80 hours a week. They get 1 day off a week, and they have a maximum shift length of 28 hours. So like, okay, that's pretty terrible. It's still two full-time jobs, but actually the asterisks are there for a reason. That's because the 80 hours a week and the 1 day off are averaged over the course of the month. So that means that, for your 1 day off, you could work 20 days straight and just have 2 days at the beginning of the month and the end of the month, and it still works, right? Also, home call doesn't count. So what that means is that you could be on call every other day, but as long as you go home and answer the phone and write notes, it does not actually count towards your duty hours. This is actually how a lot of surgical residencies still work. And also, it's actually pretty darn hard when you break down like the duty hours to really break them. It's pretty difficult because it's average over a month. And so if you can imagine, if you work 1 week 100 hours and 80 and 188, and then you have 1 week in there where things actually get a little bit better and you only work 50, you actually don't break duty hours, even though you've worked more than a full-time job for the entire month, right? And I think like all of this is really put in place to make it's intentional, right? To make duty hours very, very difficult to break. So let's talk a little bit about the history of work hours. So when we go through, I've already talked a little bit about the residency program championed by Dr. Osler and Dr. Halstead and at Johns Hopkins. 1950s is where we kind of see residents finally saying enough is enough. And they go on strike in New York City. And eventually the hospitals there agreed to decrease the on-call frequency because previously you would be on call for 36 hours every other night, which atrocious. The HCWs, which is the governing body for residencies, was created in 1981. They didn't do anything about work hours at that time, however, until in 1984, Libby Zion's case. If you guys aren't familiar with Libby Zion, she was a young woman who came into a New York hospital with serotonin syndrome. She was given Demerol, which made it worse, and eventually, unfortunately, ended up dying. But she was wealthy, white, and pretty, and so her family really went after this, and they ended up blaming the resident's exhaustion because he was in his 18th hour of his shift for this medical error. And this is what really triggered the duty hour limits. So those start happening. And so 1990, it's initially just on a few specialties, and then it expands. And eventually in 2003, we got the duty hours that you guys have heard me talk about. In 2011 is pretty funny because they tried to restrict interns to 16-hour shifts. People got upset. And so now it's back to 30 hours. So as I said, lots of people don't like duty hours. And actually, if you look up literature about duty hours and by physicians, most of it is negative. And so even this particular paper, which really was asking for more empirical evidence against duty hours was still kind of had a snide approach to it, like, oh, like physicians think that having duty hours is destroying a professional ethic, are curmudgeonly, and trainees who would rather be exhausted than leave patient care unfinished have to like suffer through being asked to go home. It's very like, oof. And that's kind of the running theme of a lot of the literature out there about duty hours. And most of all, like what comes up the most, honestly, is what I call a red herring, which is why the Swedish fish is there, which is patient safety and resident education. So there's this thought that, patient safety and resident education will be compromised by duty hours. I find this disingenuous for several reasons. So first of all, if you are applying to residencies, we all kind of know that there's a vast difference in the rigor of different residencies and the number of hours and the exposures in different residencies, and that you actually don't need to approach duty hours to be able to check off all of the requirements by the ACG and me. The research that's been done has focused more on the hours themselves rather than the work that's actually been done. And these days we spend a lot more time on documentation. For example, it's been found that about most residents spend more than 4 hours a day just on documentation, which ends up being less time than we spend at the patient's bedside. And then the biggest thing, which is staffing, right? These complaints about patient safety and resident education being compromised have actually been shot down multiple times. Most importantly, in these two major trials I compare in first, which were randomized controlled trials that looked at whether the resident education or patient safety were affected, and basically found out that neither were affected by the implementation of strict duty hours. So, here's the thing that people aren't really talking about, right? Is like that instead of pitting duty hours against each other and patient safety and resident education against each other, what if we just had more staffing so that we would be able to have fewer handoffs and more fluid handoffs? And people, like it seems like that's a taboo topic to talk about. Instead, what happens frequently is our senior physicians kind of poo-poo us a little bit, and while not really taking into account the fact that the medical complexity of our patients has increased, our workload has increased, and our debt burden has increased. Why does this happen though? Like, why do physicians like to eat their young? I think this all comes down to hazing. It's this whole thing of like, we have to suffer, so everybody kind of has to suffer with us, and taking the suffering to be a virtue. So only a few papers are out there that are actually saying the silent part out loud. So that this is really coming down to money, right? So we're seeing papers that talk about how the implementation of duty hours, even as they are, cost neurology departments $200,000 a year. Actually duty hours, although they improved residents' lives, made the program directors and other attending the leadership's lives a little bit harder. It gave them more workload. Even though the residents preferred it. And that because there was no longer free labor in the form of residents, pediatrics departments then had to scramble to find attending physicians and advanced practice practitioners to fill up the gap. So what are some consequences, of having this incredibly all-encompassing training, all-consuming, training? And some of these are this, like we come out of residency and fellowship without much of an idea of how the world works. There's no personal finance that is baked into our training. We have a hard time negotiating good physician contracts, and oftentimes continue to work like residents and sign contracts that ask too much. There are, for example, increasing EMR and EHR demands, like inbox management, et cetera, that is not really compensated for. This is only now becoming compensated for. And what we're finding is that, the work-life balance is really difficult to attain even after attendinghood is done. And that really we're seeing physicians be more satisfied in practices or in specialties such as dermatology, ophthalmology, et cetera, that are deemed controllable. This is by the AMA, not me. Than they are in these uncontrollable specialties that are still so necessary. And importantly, residency and fellowship is finite. And so there's really less incentive to advocate for trainees once people are done training, even though, even after training, half of physicians continue to work more than 40 hours a week. And although this is mostly in the uncontrollable specialties, which are specialties like internal medicine, family practice, OB-GYN, and the surgical subspecialties. I think the most important part about this, though, is that we learn that withstanding abuse and neglecting our bodies is a virtue, and that we also learn not to direct our frustrations towards systems, but instead towards individuals. The other thing I think happens is what I've kind of already mentioned, when you're sleep deprived, you're tired, and when people become your work, you start having less empathy for them. And I think that is an effect that happens. I think we're also less likely to engage in political action in part because due to tiredness, but also due to the fact that we're taught to kind of respect the systems that we're in. So, all right, I've talked a lot about the issues and what are we going to do to fix it? So I think there's a lot of simple fixes that we can do actually even on an individual basis. I think the first one is leaning into empathy. So for physicians and for physician trainees, I think that it's really important for us to normalize human emotions. It's something that is a real problem, I think, in our profession, is that we expect stoicism. We expect people who are on hour 30 to still be performing at their 100% best, even though that's literally, well, for most of us, not very possible. And I think even allowing space for people to feel real emotions, whether that is stress, frustration, exhaustion, or sadness is really huge. I also think that on an individual basis, we really should be prioritizing making sure that especially our juniors are able to fulfill their human needs. So whether that is eating, drinking, using the bathroom, et cetera, and giving them the time and space to do so without making them feel guilty. I think normalizing empathy towards patients and really processing things out loud. So when we have frustrating situation with our patients, we're able to direct our frustrations in the correct direction. And I think that importantly, avoid comparing struggles. I think that there's this tendency to always compare struggles, especially like with the advent of duty hours, to really understand that, even though things might be a little bit better, it's still really hard. I think for other healthcare workers, I'm bringing up this because it's something that's still pretty painful to see, and I don't see that many people speaking against this. Is this idea that I'm just using this one example, like, oh, brain of the doctor, heart of the nurse, right? Like this idea of doctors as kind of heartless and unfeeling, and like everybody else is really there to rescue patients from physicians. And I think that a lot of medical trainees who aren't yet attendings and haven't yet realized the power dynamic that can exist between doctors and other healthcare workers often feel demonized and left out of discussions. I also feel like a lot of discussions about the difficulties of physician training kind of easily get derailed or minimized by others, right? And I think that it's important to remember that medical students don't have an understanding of how the hospital works outside of what they're taught in their own duties, and that the best way we can all kind of pool our resources and understand that we're all in this together is to just try to attempt to understand exactly what the schedules are for the residents that you're working with, what their demands are, what is being asked of them by their attendings, right? And vice versa, trying to communicate that to them, because I know that when I've talked to a respiratory therapist, nurses, et cetera, I've learned a lot, and it's helped me manage my patients and manage our relationship a lot better. Next, I think it's really important that we organize. I think this is something that physicians are not used to because we're not used to being employed, but now we are overwhelmingly employed. And because of that, we really have to stick together in a lot of ways. And so the UAPD is one of the biggest physician unions. There's also a resident union called Committee of Interns and Residents. And I know that there is some effort underway to potentially merge these organizations. I also think there's a need to dream bigger. A lot of hospitals rely on resident labor in order to function, and I think that's wrong. And I remember the first time I brought this up, it was almost like a super hot take. But there's a lot of advocacy in place to open up more residency positions to get these trained physicians who are out there who are unmatched, who want to work, to get them working, and to help relieve the rest of us and to help address the physician shortage. Happily, this advocacy is actually working. Actually, in December of 2020, the Congress expanded residency positions for the first time in 25 years. So added 1,000 additional much needed physicians. And so continuing to push for more and continuing to push for more humane conditions is a huge thing. I think there are already a lot of people who are advocating. These are some of my favorite accounts. Laura Bader, Brian Carmody talks a lot about like the nonsense that I talked about in the beginning about the path to medicine. Natasha Fezensenka, and one of my favorites is Residents Protecting Residents. But you guys should feel free to tell me about any other organizations you know of. And so I think I'm going to kind of conclude this talk by saying, the biggest thing I think with medicine is that you got to be able to put your own oxygen mask on before you put on anybody else's. And I think that for years and years, and maybe since the conception of modern medical training, we've been teaching people to do the opposite. And so I'm hoping that as more of us start talking about this and more of us start drawing residents, trainees, medical students into advocacy for themselves, that they'll also be able to have the time and mental space to advocate more for their patients. All right, so that's all I've got. And I guess I will be going live for questions.
No. Hi, everybody. Thank you so much to Shirlene for that amazing talk that we were absolutely obsessed with. And also, we keep shouting at the computers, which is not helpful, but it's really fun.
Yeah.
Thank you to every one of our speakers.
Thank you to our speakers. Thank you
to everyone.
Thank you to Dustin. Thank you to Susie. Thank you to William.
Yes,
oh,
everyone.
Yeah, okay.
Yes.
Oh, yeah. Thank you to Harrison. Thank you to Sabine,
Sarah,
to
Michael,
Michael, to
friend
Jim,
Michael,
to Rick. Thank you.
No,
Yeah.
Yes, thank
in the comments, thank you to Jason. Thank you to Anna. Thank you to
Harrison.
Thank you, G.
Yeah.
And
Rick has
Michael,
been our comments, and we're
Dr.
here
Rao.
for it. And I've agreed with everything, so I'm very excited about that.
Hey, we had a bunch of people who came to our rally today from North Dakota, from Utah, from
New York,
from Chicago, right? Anthony, thank you to his crew. Thank you to
it was Angie and Mike and Terrence and everyone who traveled down with
Thomas.
Anthony.
Thomas.
Thank
Thank you to Thomas. Yeah. Thank you to Resident Life MD. Thank you to Code Blue Memes.
Everyone who's sharing all of our
memes
stuff
are
this entire time. Yes, everybody.
Yes.
Sabine's brother Antoine. Thanks for logging on, Antoine.
Yeah.
Julie, our amazing behind the scenes.
Julie, special shout out.
Yeah.
She's been the one like pulling all the strings behind it.
Yeah,
Make sure you guys can see what we were talking
She's made everything look pretty, and she's dealt with 1,000 texts just today, just from me. So shout out to her.
Thank you to my dog Lucy for just being beautiful.
Yeah.
Like,
and
thank
also
you.
letting
to
me
her.
carry her around all day, which is great.
Laura carried me and Lucy today.
I carried
Literally.
her more, honestly, but it's fine.
She's bigger. No,
And thank you to everybody who has been purchasing merch and supporting us and believing in our group and how hopefully we can help change things.
Yeah.
And this has always been not really about us. I mean, we've been talking a lot today, and we apologize for that, because it's never been about us. It's never been about centering ourselves. This is about making it possible for you guys who have these great ideas and who really want to change healthcare, making that something accessible and something that you can do while you're burnt out and while you're tired and while you're working. So thank you to all of you for joining us today, for participating in the comments, for chatting with us, for sending your thoughts, for sending your questions. We love you guys so much. We would literally be doing nothing at all. We'd be like asleep this weekend if it wasn't for you guys. So
we love you so much for taking time out of your busy life. You have friends, family, you have your life. You're going through a lot. Pandemic is still happening, right? The pandemic is not over. It's still that's why we're virtual, right? And we could not appreciate you more for taking time out. It's not easy. It's not easy to do that. So thank you. Thank you for caring about creating a better system. Thank you for joining us.
Thank you to everyone who's donated or bought things to Riot Healers and Rad Girls and everyone that's been helping us as far as getting actually started as a legitimate organization.
And to Anna from Feminist in Florence.
Yes. And Sarah, we miss you. Our founder who's not here. We love you, Sarah.
We miss
you
so much.
Maya, baby Maya.
Baby Maya. Yeah. I think that's it.
So we are so glad that you guys were all here today. We can't wait for you guys to see what's coming up next with the organization. A lot of you already know this, but our next step is building out our departments and our committees and our sections and making sure that everyone who's involved in healthcare or touches healthcare, from patients to
beyond,
maybe not administrators, we're not really sure, but almost everyone who
maybe
touches,
nurse managers,
we'll talk
we
about
could try
it.
to convert them back to
make
us.
a case, maybe not like the C-suite, but anyway, so getting everyone who touches healthcare involved and making sure that we can find a common ground in all of our interests and all of our needs and all of our passions for helping our patients and helping ourselves.
We have a lot of power together. And that's the only way that we can do this. We have to do it together. There's no other way. We have to pool our resources. I want to see if there's an issue for the RTs. I want to see nursing rally behind. I want to see the residents and vice versa. I want to see if there's an issue with the residents. I want to see everybody else rally behind. And we can make a big impact. We can make a big change that way.
So everyone who joined today, thank you. If you found anything about this powerful or if any of it was informative, please send it to any of your friends that you think might also learn something from it or be inspired by it.
Like and share.
Yeah, we really want change to feel accessible to everyone in healthcare. I think we all need it. So if you think anybody in your life needs to hear it, please send them our way.
And again, if you want to join our committee, I want to help at impactinhealthcare.org. Just email us and we'll try to hook you up with the department.
Yeah, we're going to take a couple days off because this is a lot.
Yeah.
So give us a few days.
BRB.
But we are so excited to get everything organized and moving and get on to our next steps and get some direct action going.
All right. That's it.
Thank you guys. Thanks, Julie.
Thanks. Bye.
Hey, Thank you.